Brown, the current board president. Let me click the pop-up. Present today, let's see, it is 8:51 a.m. on Tuesday, February the 8th, 2022. Present for this virtual board meeting, we have Dr. Lynn Krause, Dr. Brian Jolly, Dr. Lenora Newsom, Dr. Debbie Mack, Dr. Rodney Richmond, and Miss Carol Rader, and board member Miss Amy Ford is out this morning. So we will make a record for the notes if and when she joins us this afternoon. And with that, I will turn it over to Dr. Kirtley.
Morning, everyone. Hope that you had plenty of fun in the 1 day of quote unquote snow from last week, as some of my northern friends are calling it. And then they got here and realized it was ice, not snow. Just right off the bat, we've already done our call to order. We generally will go ahead and consider the financials and our minutes. We actually have Lena with us this morning. Lena, do you want to go over the financials for us?
Yeah, okay, there's the button. Good morning. Yes, I would like to do that. This financial report, it's actually from the end of the calendar year, and includes our treasury fund and the money management trust fund.
Find CHI, St. Vincent, Little Rock Diagnostic.
Hey, Brenda, you need to mute.
Wait while I transfer your call.
I muted her.
The total balance, like I said, is the end of the year, it's $3,957,622. That is both the treasury fund and the money management fund. Right now, our renewal season is actually coming to a close, and I checked our statistics that Jennifer runs for us every week, and we have 94% of pharmacists have already renewed, and 99% of the retail pharmacies. So we'll just have some more trickle in until renewals officially close online on March 31st. That's what I have for the financials.
Dr. Mitchell, if
You want to do a motion for that first and then do the authority, John, or?
Yes.
Yeah, let's do it separate, please.
All right. Any questions or discussion about the financial report? Hearing none, do we have a motion to approve?
I'll make a motion. One
Okay,
of us can be first and one can be
Yeah, one can be second, yeah.
I heard about 3 motions. So I have Dr. Newsom on the motion and Dr. Mack on the second. Any additional discussion? All in favor?
Aye.
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 Any opposed? The motion carries.
And just so it's easier for Ms. Whitmore, who is going to be taking down everything, when we vote, if you will say aye and also raise your hand, and so we can see everybody in here, just so she gets everything she needs to get. Thank you.
That's what I had to do all of last week with ACE, is everybody raised their hand, and if you want to vote against it, you have to wait, and we did thumbs down. But I don't think we have a whole lot of those.
No. Okay, so also and under the CFO tab, I believe it is, we have every year, according to state law, the first meeting of the year, the board has to authorize the $110 stipend payment that members get for attending regular, informal, and called board meetings. And then there's also a list of possible meetings to be approved for reimbursement. So yeah. Any questions about that, or go ahead and entertain a motion?
Okay. Do I have any comments or discussion? Hearing none, do I have a motion to approve?
I motion to approve.
Okay, I saw and heard Dr. Krause on the motion. Dr. Jolly, was that you on a second?
Yes, thank you.
All right, a motion and a second. All in favor say aye.
Aye. Aye.
Any opposed? The motion carries and was unanimous.
And then I believe the last thing is the minutes, and I think the only ones we had were the October board meeting and then also the December public hearing for the rule changes.
helps if I remember to unmute. Not hearing any discussion while I was talking to myself. Do I have a motion to approve the minutes from October?
Oh, I see, Dr. Kraus has a hand up.
Dr.
Yes,
Cross, do you have a comment?
Say that again, Lana. I'm sorry. I caught part of it and not all of it. I
Oh,
want to
I'm sorry. It's the minutes from the October board meeting and then also the December public hearing meeting that we had on the rule changes.
Thank
That's
you.
the 2 minutes. Mhm.
to make sure. Yes, I move to approve.
I'll second.
Have a motion from Dr. Cross and a second from Dr. Mack. All in favor, say aye, raise your hand, hold it up.
Aye.
Aye.
Okay, any opposed? The motion carries and was unanimous.
That's all for me. Thank you.
Thanks, Lena. All right, for the next thing, we're going to go through reciprocity. We have our reciprocity candidate schedule where we have about 25 for each 30-minute block. So I'm going to have to go through this a couple times for everybody that is on screen with us now. What we'll do is we will pull you up alphabetically. All the board members have copies of the excerpts from your reciprocity application. We have to kind of go through those, like for me, back and forth one at a time to pull up those documents and close them. So it may take us a minute if we're wanting to look at something on each one of you. When we call you up, what the board members are going to want to hear is who you are, where you're from, where you went to school, and why you're getting a license in Arkansas. They'll also look at your reciprocity questionnaires and see if we have any questions for you. We ask that you stay until the end of your group, which at that time you would be dismissed. If you want to continue watching the meeting after that, you're welcome to do so. We would ask you to switch over to the YouTube link just so that it helps some with our bandwidth, keeping us from having any issues with Zoom. Any board members, anything else you want to add before we get started on reciprocity? All right, I'm going to kick it off. The
John,
first one I have is Amr, and is it Abdul Maqsood? Lynn, you got a question?
real quick. So in our Dropbox package, we're going to go to reciprocity list.
Yep. Well,
Okay.
the reciprocity list is the list of names, and there should be a second link that actually has every individual's information.
Yeah,
The
there's
questions.
yes, February reciprocity questions. If you click on that folder, it's got the
Thank
package for everybody that's going to be there.
Sorry, thank you.
Luke, is that all in one big document on yours?
No, I'm sorry, we had it. It's all individual.
Yeah, that's what I thought. Okay.
So yeah, I don't know. It may be easier just to click on it. Yeah, I don't know which is easier, the one big or this, but either way,
Yeah.
we had it this time. It just ended up being each individual, but they are in alphabetical order, so it should be easy to follow.
Yeah. I know.
Yeah, I can work it. I just wanted to make sure.
Yeah. For some computers, it becomes such a large PDF, it's hard to manage. So do we have Amir? Going once, going twice. All right, we will come back if we need to. The next one I have is Zubair Afzal.
Here.
All right.
Hey, sir. This is Amir.
Oh, okay. Well, Amir, can
Yes,
you
sir.
guys turn on your cameras and we'll get started with you, Amir.
Sure. Give me 1 second here.
I'm sorry, it was at 9 o'clock. I don't know if you heard my name, but I was just able to log on.
Okay, we're calling everyone up alphabetically. All right, Amir.
Hi.
So it's your turn to give us your rundown.
So my name is Amir Maqsood. I'm a quality assurance pharmacist, state of Florida, Miami, Hallandale Pharmacy, 503A Pharmacy. That's pretty much everything.
And where did you go to school?
Oh yeah, I'm a foreign graduate, School of Pharmacy, Alexandria University, Egypt.
Okay.
Yeah, and then went through all of the FBGEC certifications and took all the examination and now licensed in 11 states, including the state of Arkansas. Yeah, I was very good in pharmaceutics and pharmaceutical chemistry. That's why I picked compounding, and I found my passion in the job of quality assurance pharmacist / compounding and all the compliance and regulatory in regards to compounding laws and stuff. Yeah.
And where did you do your internships at with your foreign
Sure.
graduate?
Yeah, I did my internship at Promise Pharmacy in Baltimore Harbor area, Florida.
Okay.
Yeah.
And the pharmacy that you're working with is mainly doing compounding, all patient specific?
Yes, all patient specific, customized medications.
Is any of it shipped directly to prescribers' offices or all direct to patient?
All direct to patient.
Any board members have any questions for him? All right, seeing none, we will move on to, is it Zubair?
Yes. Hey, good morning.
Howdy.
Hey, so just a little bit of background on myself. I went to school at University at Buffalo and graduated in 2014. After that, I did my residency with Midwestern and Walgreens in Arizona. So it was a community pharmacy residency. I did that for 1 year. And then afterwards, I got a position as a specialty pharmacist at Walgreens. And at that time, we were focusing mostly on hepatitis C, and we had a lot of the newer drugs come out, the Sovaldi, Harvoni, Vicurapax. So was very, very heavily involved in that. And then 2016, I made the move to California, which is where I am right now. Walgreens opened another new specialty pharmacy. I took the lead on opening that up. And most recently, in 2020, I was hired by BioPlus Specialty Pharmacy, whose focus is oncology, to open up their, California pharmacy and open up their Western division business. So that's where I'm currently at. And the reason why I'm getting licensed in Arkansas is because we ship to different states. And obviously for us to ship into the state of Arkansas, I have to be licensed and be the pick for that state. So our focus is mainly oncology. I'm board certified in oncology pharmacy. And we do everything from prior authorizations to financial assistance, and then monitoring outcomes and reporting adverse events as well.
And are all your shipments direct to patient, or are you shipping to clinics?
Most are direct to patients. There's a handful, just a few, maybe like a Prolia, or sometimes you have the oncology infusion products. Those are shipped to the office.
So just so that you know, or anybody else, we only allow you to ship products to the clinic that are products that must be administered in that clinic setting. So if it has to be infused, that is fine. But, historically, we get a lot of people that wanted products like Enbrel or Humira that are self-injected medications. Those are not approved generally by this board. There could be exceptions with patients that cannot administer it, but that's something we would need to discuss.
Okay, perfect. Thank you.
Any other questions? All right. Next up, I have Mary Alves.
Good morning.
Morning.
My name's Mary Alves. I'm in Pennsylvania. I went to school at Wilkes University, and I graduated in 2006. And I'm currently working for a mail order pharmacy, just kind of getting started and hoping to take over as pick. So I'm getting licensed in many states and hoping to include Arkansas.
Okay. Anybody have any questions? All right, thank you, Mary. Joshua Anderson.
Hello, Mr. Kirtley. My name is Joshua Anderson. I'm from Elmwood Park, Illinois, which is right outside of Chicago. I went to Purdue University, and I'm trying to get my Arkansas license to become pick of the pharmacy I work at, which is CVS Caremark Mail Order Pharmacy in Mount Prospect, Illinois. I currently have a staff pharmacist that has an Arkansas license. That's the current pick, but I'm pick of my home state of Illinois, so it only makes sense that I would be pick of Arkansas also.
And yours is mainly fulfillment side, not processing.
Correct. We're a back-end fulfillment pharmacy. The adjudication, DUR, that's all done in what we call a front-end processing pharmacy. Correct.
Okay. Anybody have any questions? All right, next up I've got, is it Hannah Badra?
Morning. My name's Hannah Badra. I'm from West Palm Beach, Florida. I graduated from Palm Beach Atlantic University down here in West Palm Beach. I'm currently employed by Mint Pharmacy down here. It's a mail order pharmacy. Our pick left, so I'm trying to get my license so I can become the pick in Arkansas. That's about it.
And what does Mint specialize in?
Non-sterile compounding, mail order, mostly ED medications and cosmetics.
Okay. And all direct to patient?
Yes, sir.
Okay. Any other questions for Hannah? And I would say, I know on some of the websites like Mint, you've got to be sure that those prescribers have an Arkansas license in order for those prescriptions in Arkansas to be legal. I know most of those companies have lined up their physicians to have legal practice authority in whatever state they're trying to serve patients. So that's something to watch out for.
Sounds good.
Okay. Caitlin Baker. Do we have Caitlin on with us this morning?
Hi, can you hear me?
There you go.
Great. Hi, my name is Caitlin Bakir.
Okay.
And I live in Overland Park, Kansas. I'm from Wisconsin originally. And my district manager asked me to get an Arkansas license to provide relief for the on-site specialty pharmacies there in Arkansas. Occasionally when they need to take vacation or for training new people. So I'm planning on coming there to Arkansas maybe 2 to 3 weeks a year to help with training and also vacation time for specialty pharmacy.
Okay. Any questions for Ms. Bakir? All right, seeing none. Let's see, John Barishman. See, is John on with us?
I see him, but it doesn't look like his camera is on.
Well, I don't think we've got any noise from him either.
No, but he's not muted, so not a no-show, but let's come back to him, I guess.
Okay, John, we will try you. It says connecting to audio. All right, we will come back to you. You may want to log off and reconnect.
Don't panic though. You're not like out or anything like that.
Yeah.
It's okay. Nobody panic.
If I push him out, he can't come back in. But if he logs off, he can come back in. Jennifer Barkloff or Barlakoff.
Barlakoff, yep. Good morning. My name is Jennifer Barlakoff. I live and am from Erie, Pennsylvania. I went to the Lake Erie College of Osteopathic Medicine School of Pharmacy. I am currently becoming tech of the mail order compounding pharmacy that we have. Everything is patient specific. We do ship to some clinics, but it is all for in-office use.
But it's patient specific for in-office.
It's still patient specific, yes.
Any questions you guys have for Dr. Barlakoff? All right. Got Jay Barnhart.
Good morning. My name's Jay Barnhart. I'm from Jackson, Mississippi. I currently serve as the pick for Noble Health Services. We are a specialty mail order pharmacy, shipping patient-specific medications to their respective houses and/or doctor's offices. So, seeking to get licensed in Arkansas to fulfill this role with Noble.
And what drugs are you shipping to doctor's offices?
Mainly the doctor's offices are like Tremfya and Stellara, the really expensive ones. But most of those go directly to the patient's houses.
Yeah. Stellara becomes a tough one because it includes in its package insert training for patient self-administration.
Right. So majority of the ones that we ship, the doctors don't train the patients to do it. So they still want it to come to their doctor's offices, but I think we have maybe one patient in Arkansas and it's not Stellara. So
there you go.
This is Humira and Enbrel are our two main contenders.
Yeah. And those are absolutely patient self-administered. But anyway, if you have a problem with any of that, give us a holler. We'll talk about it. Anybody else?
John.
Yes.
So that is shipped to the physician's office or not? I'm sorry, I'm confused.
Are you asking me or Dr. Barnhart?
I assume Dr. Barnhart. I'm wondering if it's, but I guess in a way you as well, because I know we don't allow shipping to physicians' offices on patient-specific medication, but I know that there's probably a few exceptions in there as well.
Yeah. What we generally say, like if it was, an infusion that has to be administered in a clinical setting, that's automatic. We have drugs like, Remicade or the biosimilars for that have to be infused. So even though it's patient specific, we would allow that. You have some medications such as Vivitrol for opioid use disorder that are supposed to be administered in a clinical setting. So there's some drugs like that we do not have a problem with it going to the prescriber's office or clinic for professional administration in that setting. Historically, we have seen a lot of people where we have drugs that are meant to be self-administered, and some clinics just want to have them there and hold the patient's drugs, and we have not allowed that. There have been exceptions. I mean, I've dealt with things where they had a patient that was legally blind and therefore could not appropriately draw up doses on their own or had disabilities that we've given exceptions one at a time. Does that help, Dr. Krause?
Yes. So is this gentleman sending Humira to the physician's office or to the patient?
Yeah, Humira is sent directly to the patient. The only ones that we would be are the ones that are, like I mentioned, Tremfya or Stellara. But when I pull the report for Arkansas, the main contenders are Humira and Enbrel. So those are going directly to the patient. If we do run into an issue where the provider is asking us to send that, I'll make a note and just reach out to make sure it's permissible before we do so.
Thank you much. All right. Next, we've got Mark Bemis.
How's it going? My name is Mark Bemis, a pharmacist at PillPack by Amazon Pharmacy. I graduated from MCPHS, or Massachusetts College of Pharmacy and Health Sciences, in the Manchester campus. I am looking to be a backup pick, and I currently work in our billing department.
Any questions? All right. Paula Marie, and I'm going to take a guess. Is it Bozier?
It's Booker. It's like a, yeah. My maiden name wasn't it was not easier so I mean, but at least I went from a P to a B, so that's good.
You moved up in the alphabetical line.
I did, not an ease of saying the last name though. My name is Paula Booker. I currently reside in Phoenix, Arizona. I did my undergrad at University of Arizona, originally from Mississippi, which is why I love these Southern accents that I'm hearing right now. And I did pharmacy school. I went to pharmacy school at Midwestern in Glendale. And currently I work in the quality department for a 503B that's in Chandler, which is a suburb of Phoenix. And I'm the pharmacist in charge. So the intent is that to get licensed, this Arkansas, if licensed, if granted licensure here, will be our 39th state that the facility will be licensed in, just so we can set up accounts and start selling in Arkansas. So with that being said, we are an FDA, we are listed on the FDA 503B outsourcers. So, and so we've been inspected by the FDA as well.
When was your last inspection?
This last July.
And I'll ask this out of ignorance. Have you guys already applied with us for a business license?
Well, and I'm in charge of that as far as the actual permit license to the board. I'm pretty sure that we have, because I sent the questionnaire in, and
Okay.
I'm pretty sure if that, I think I've been doing that. I have to go and look because it's always a step process with me. So I've taken, this is now, since I came aboard in September, this is now the 9th state that I've got licensed in. So it kind of runs all together.
Okay. Well, I was going to say, whether you have or have not, don't be surprised when we ask for like unredacted 483s and copies of other inspection reports.
Yes, and I do have that. We still are waiting for our the EIR from the FDA from the inspection, but we've done any corrective actions and stuff like that. So we've taken care of anything like that.
Okay. Anybody else?
I was just going to say, don't hold your breath on that EIR.
No, we certainly aren't. But I mean, it was good. I mean, for me, this is the first time that I've worked in quality second time that I've worked with the owners. So it's been a huge learning curve for me. We're coming from retail and specialty. So the slower the process that any of this is, in the more kind of stuff that we have to go through, it's been really a good learning experience because now I know what to do. So, but yeah, I agree. You can't hold your breath with the FDA.
No. All right. Next up, I've got Sarah Blue.
All right. Can you hear me?
We can hear you. We just can't see you.
Okay, I guess I'll click on my name. Or start my video. Can you see me now?
Not yet.
Okay. Okay, I clicked on start my video. Says, okay, not able to start my video. Can you just, I guess, listen to me?
That is up to the board members. We generally want to see videos so we know who we're talking to.
Okay, let's see here. It says, let's see.
I would prefer to come back to her. Maybe she can log off and do a quick Google search on how to work Zoom.
Yeah, because it's saying asked to start my video, but it's not letting me start my video.
You may have to authorize the camera on whatever device that you're using, but maybe we can come back to her.
Yeah.
I don't want to totally derail her application process, but it's
Okay.
possible. I would like
Okay.
to see.
Okay, I'll try to figure it out before y'all come back to me.
Yeah, we'll come back to you. You'll be after Foley.
Okay.
Next up, I've got Sharon Braxton.
Hi, good morning. I'm Sharon Braxton. I live in Dallas. I went to Campbell University and I'm trying to get licensed in Arkansas. I work for Cardinal Health as a remote order entry pharmacist. So in order to enter prescriptions remotely for the clients we serve in nursing homes and hospitals, I need to be licensed in Arkansas.
Anybody have any questions for Dr. Braxton? All right. Seeing none, next up we've got, let's see, that's not right. Is it Rachel Bunda?
Yes, it's Rachel Bunda.
Okay.
Hi, my name is Rachel Bunda. I'm from Columbia, South Carolina. I went to school at University of South Carolina here in Columbia. And I work for Nephron Pharmaceuticals for their outsourcing, 503B outsourcing facility. And I'm pick for the 503B.
What a picture ought to be.
And Miss Sarah, we're going to mute you for now because we can hear other stuff. There we go. So, Rachel, when was your last inspection?
It was before the pandemic about 2 years ago. So we're literally due any day now.
There you go. Any other questions for her? All right, seeing none, we'll move on. Got Nancy Butler.
Good morning. Hi, my name is Nancy Butler. I currently live in Brooklyn. I went to school in Long Island University, the Brooklyn campus. I graduated in the year 2006. I'm currently the pick here at K Pharmacy. It is a pharmacy that ships generics to other states. We're licensed in about 38 states now. I do hold 15 licenses right now. We will be shipping generics, no company, no control, patients who opt to have to order delivery from our facility.
And it's a subsidiary of a telehealth company. Tell us about that.
So K-Health is a telemedicine company that serves patients who have behavioral health issues or for primary care. That company is our parent. Currently, our parent uses TruePill to fulfill orders for patients who want mail order. We will be they'll present us as an option for a mail order to those patients. And if they like, they can choose us.
So everybody on that's doing mail order, you're going to be sure you've read the current Arkansas laws about how the patients must choose you. You cannot obtain patient information from a parent company, sister company, healthcare plan, or anybody else. It has to be approved directly to the patient first. Any other questions for Dr. Butler? All right, see none, we will keep moving.
On the meeting.
Is it Dima Chitani?
Yes, hi. My name is Dima Chitani. I currently live in a suburb of Illinois. Our pharmacy is part of TruePill, just like Nancy. And we're not operational yet. We are still in the process of getting our Illinois State Board license. We will be doing mail order directly to patients in Arkansas, but I'm getting licensed in order to be able to do that.
And just so you know, you'll have to be open for some period of time with an operational inspection before we would process your business application.
Okay.
So if they do a pre-opening inspection, we don't accept that for licensure. It would have to be an operational inspection where you've been up and going for a period of time.
Okay. Good to know.
Any other questions for Dr. Chitani? All right. Let's see. Nico Conoroso.
Hello. Can you hear me?
I can.
All right. Hi, my name is Nico Conoroso. I'm from Buffalo, New York, currently live there. I graduated from DuVille College School of Pharmacy in 2019, and I work for a 503B outsourcing facility, and I'm getting licensed in Arkansas as the backup PIC.
And when was your last FDA?
About 2 years ago, due any day now.
Seems to be a common theme that we hear a lot.
Yep.
Any questions? Seeing none. Nathaniel Cordero.
Yes. Good morning. My name's Nathaniel Scott Cordero. I'm a pharmacy supervisor in San Antonio for the front end mail order. I went to Oregon State University. That's where I graduated from. The reason I'm looking to get this license is to become a backup pharmacist in charge for that pharmacy. So that's why I'm here.
And Scott, that's CVS.
Yes, CVS Caremark.
You told us everything but the company.
Oh, I'm sorry about that.
It's all right.
Yeah, I was with Walmart for 15 years, so I've been to Arkansas a couple times for some other meetings. Yeah.
Any questions for Scott? All right. Next up, I've got Andrew Curtis.
Hey, good morning. I'm Andrew Curtis. I live in Greenville, South Carolina. I went to Medical University of South Carolina in Charleston, South Carolina. I work for Omnicare, which is a long-term care portion of CVS Caremark. And right now I'm really just getting licensed in Arkansas. Was requested by my boss. I guess it's just a backup PIC. We initially we're going to look into doing collaborative practice agreements with some providers in our long-term care facilities where we could, sign prior authorizations for them and assist them with that process. But I don't think that's going through. So, just getting a license to be backup PIC eventually.
Okay. So not sure you can do all that from your state to Arkansas, but that's a future discussion more than likely.
Yeah, we're kind of a weird niche in pharmacy, and we don't dispense any drugs or anything. It's more just assisting facilities with avoiding non-covered charges and recommending covered alternatives, et cetera. So.
Well, I think the bigger issue is trying to do like disease state management or collaborative practice agreements, because there's no such thing in Arkansas as a collaborative practice agreement for a pharmacist. That's a specific legal term that is specific to physician assistants and APRNs. So while we have disease state management, it's a little bit different. And I understand South Carolina has some restrictions on that as well.
Absolutely. Yeah. We don't do it in South Carolina. Actually, it's only a handful of states. We only have 2 clinical intervention centers in our company, and we service like half the country in ours. And there's several states we can, but just kind of depends. But I do not deal with that legal department, trying to figure out what states we can and cannot. But I've been told we cannot in Arkansas. So.
All right. Any other questions for him?
Sorry, I have a comment.
Sure.
Trying to choose my words carefully. You are fortunate that you have a legal department, and that's great. But assuming we vote to give you a license, you are responsible for making sure that your company follows the regulations for the state of Arkansas. Whether you have a legal department or not, this board would hold you personally responsible for that.
Yes, ma'am. I fully understand. I fully understand that. I apologize.
No, it's okay. I just want to make sure that was clear.
Yeah, no, I do understand that. And if they ever do tell me that we figured out we can do it, I would make sure to double check with you guys before.
Hopefully we never get there. I just want to make sure that was clear.
Absolutely.
Anything else for Dr. Curtis? All right. Is it Kyle? Is it Drabach?
Yep, Kyle Dressbeck. I'm located here in Columbus, Ohio. Graduated from the University of Findlay in 2014 in Findlay, Ohio. And I work for Script Hero Pharmacy, which is a mail order pharmacy here in Columbus. Seeking licensure to serve as the PIC.
And what's different about Script Hero?
Oh, wow. We're a standard mail order pharmacy. We receive prescriptions from prescribers Yeah, I think that's.
So like, how does a prescriber find Script Hero?
Yeah, so yeah, good question. So a couple of different channels. We're currently in our business development phase. So I don't want to share too much detail on the call here, but we work with clients to have patients select our pharmacy as a mail order pharmacy.
So when you say work with clients, who are the clients?
They could be a telehealth company, would be an example.
So a telehealth company is helping link patients to your pharmacy. Are they paying you? Are you paying them? Like what? I guess what I'm trying to ask is, oftentimes our board members say, well, how do you get business in Arkansas if we've never heard of you? And if there's some type of kickback arrangement, remuneration, or profit sharing, that's a different arrangement that may not be legal in Arkansas. So I understand you may not want to share your business model with us, but at some point we can discuss it or we can table it.
Yeah, that sounds great. And we haven't applied yet as a pharmacy, but when we do, we can call that out in terms of how we work through anti-kickback.
Okay. So Dr. McCready, if you'll flag then Script Hero, we will want more details on that prior to any approval. Any other questions? All right. Let's see. Get back on my right list. Andrew Ducote.
Hey, good morning. Can you hear me?
Yes, sir.
Yeah, I'm Andrew Ducote. I'm from Baton Rouge, Louisiana, currently living in Keller, Texas, just outside of Fort Worth. I went to school in Monroe, Louisiana, ULM. I've been a hospital pharmacist since I graduated in 2011. Currently, I have a part-time job with LifePoint Health, where we provide remote hospital pharmacy coverage, mostly for smaller kind of outlying community hospitals after hours. So currently, we service 3 facilities in Texas. Our director asked us to get licensed in Arkansas because they're looking to expand to Arkansas this year. I don't know exactly which hospitals we're going to be covering in Arkansas, but LifePoint does currently own 3.
And question for our staff, have we already approved LifePoint as a provider for offsite order review? I don't know that answer, but are these are all hospitals owned by the same group?
I lost you for a second. I lost you for a second.
Are these all hospitals owned by the same corporation?
Yes. Yes.
So you're covering fellow hospitals. It's not a third party group.
That's correct. Yeah. So we operate a little bit differently than, say, for instance, Cardinal, who goes into other facilities. These are all owned by LifePoint. That's correct.
So we would just have to approve those facilities in Arkansas for that type of coverage from a fellow hospital. It's a fairly similar process, but it's a singular approval for the company to cover itself versus other companies like Cardinal or Pipeline had to get approval as a corporation to cover a third party company. So
okay. I'll have my director reach out to you guys, I guess.
Okay.
Okay.
Any other questions for Dr. Ducote? All right. Michaela, is it Icabina?
Yes, Michaela Pennington. Hi, everybody. I'm coming to you from South Dakota here. I'm from Sioux Falls, South Dakota. I went to school in Brookings, South Dakota State University College of Pharmacy. Graduated 2016, and I am seeking licensure in Arkansas to be a contingent pick at Medvantix Pharmacy, which is a small mail order that primarily deals with patient assistance programs. We do ship some to doctors' offices, but it is like the Rituxans and infusible products that have to be shipped to hospitals and infusion centers.
Any questions for Michaela? All right.
Thank you all.
Absolutely. Joseph Estrada.
Hi, everybody. I'm Joseph Estrada. I'm from Silver City, New Mexico, and I went to UNM College of Pharmacy in Albuquerque, New Mexico, and graduated in 2018. Moved here with my wife last year and have been working under a temporary pharmacist license at CVS here in Fort Smith, Arkansas.
Any questions for him? All right, and it looks like we've got Megan as well on the split screen.
Hi, I'm Megan Estrada. I'm from Fort Smith and I did undergrad at UCA and then went to UNM College of Pharmacy in Albuquerque. And I worked in Silver City, New Mexico at a hospital the last 3 years. And then we just moved back home for me in November and I'm working at Mercy Fort Smith.
Any questions for the Estradas?
Welcome home.
Thank you.
All right. Let me. Carissa Fisher.
Hey, good morning. My name is Carissa Fisher. I graduated from Mercer University in Atlanta, in Georgia in 2012. I've been living in Northwest Arkansas since about 2016. Moved here with Walmart, working in pharmacy operations, and wanted to get my Arkansas license since we've committed to Arkansas as our home, and we'll be here long term. And so I want to be able to practice here in Arkansas.
And Ms. Fisher, did we give you a temporary?
No.
Okay, but you're aware that you'd have the practice after inactivity for supervised for a period of time.
Yep.
Okay. Doesn't hinder you in any way. It just helps, if anything, protect you from getting thrown to the wolves day one.
I appreciate that.
Any other questions? All right. Next up, we have Elizabeth Foley.
Good morning. I'm Elizabeth Foley. I reside in Novi, Michigan. I graduated from pharmacy school at Ohio Northern University in Ada, Ohio. I work for Ascension, Michigan Specialty Pharmacy, and I'm looking to get licensed in Arkansas to be the pick for our pharmacy there and open up our services to the state. We do ship mostly directly to patients. There are a few exceptions where we'll ship to the doctor's office for Vivitrol or Remicade. But for the most part, it's just to patients. And our last board inspection was in August of 2020.
Any other questions for Dr. Foley? All right, and I think we're going back, wasn't it Sarah, I believe? I had a note on my screen and then it went away.
Okay, can you see me now?
There you go.
Oh, okay. I had to end up getting on my iPhone. I don't know what was going on, but yes, I'm Sarah Blue and I'm from Texarkana, Texas, and I still live here in Texarkana. And I've graduated in December of 1987 from University of Texas at Austin Pharmacy School. And before that, I got my BS in zoology from University of Arkansas in 1984. But anyway, I would like to get my Arkansas license because I just a few months ago started working at a Wadley hospital that's here in Texarkana, Texas. And they have also a satellite hospital in Hope, Arkansas. It's about 30 or 40 miles from Texarkana. And so we do remote order entry whenever the pharmacist isn't there. And also they would like for me to sometime, go work there. So I'm just working as a relief pharmacist. I'm kind of worked for Walmart for the last 18 years. And before that for Albertsons for 10 years. And actually Wadley was my first job when I first got out of school. I worked there in the late 80s when I got out of school. And now I've gone back and it's completely all new technology. It's been a challenge, but it's, I really enjoy working there, and I'd like to be able to get my Arkansas license to help them relieve to cover for vacations and stuff.
Any questions for Dr. Blue? I think somebody's going to tell her she has to wear a Razorback gear when she comes back across the border.
Oh, yeah. Yeah. Well, I am a Razorback. I graduated from University of Texas and University of Arkansas, but when the football's playing, I've got to be for University of Arkansas because I lived on campus for 4 years.
Let her in.
Yeah, they're just, I'm a diehard Razorback.
There you go. Well, I do not see any more questions for you. So, Madam President, that's the end of our first group. If you want to take a vote to accept them, and then we've just got a couple of housekeeping things we'll review with them and start our next group.
Okay. I assume the questions we had on some of the facility business stuff has nothing to do with the actual pharmacist license, correct?
I'm sorry, we had one Barishman that Nancy says we skipped because we're right known for him.
Yes.
We did.
Good morning.
There he is.
I'm sorry, let's get him real quick.
Good. I'm sorry about that. I was having audio video problems. My name is John Barishman. I am one of your neighbors to the north in Missouri. I'm a graduate of the St. Louis College of Pharmacy, which now has some other really new long name.
Yeah.
But I don't know what that is. And I work for Accredo, which is a part of Cigna, and I'm doing it to become one of the backup picks.
And what is the mascot at that college?
The Eutectic.
But what is it actually?
That's a great question.
It's a bear or a gremlin or something. No one knows what it actually is.
I was going to say like a cub, so yeah, I would go with a bear. Yeah, nobody has any clue though.
It's nerdy pharmacist humor. I've heard Wolverine, bear, Teen Wolf. I've heard all kinds of stuff.
Yes.
My apologies, Dr. Barishman. I did not mean to skip over you.
Nope, that's my fault. I'm sorry.
Back to you, Dr. Mitchell.
All right. Thank you for that catch there from the board staff. Dr. Kirtley, there were a couple of notes that we had made for Dr. McCready to follow up. Those do not affect pharmacist licenses, correct?
That would be correct.
Okay. So board members, any questions or discussion on any of the applicants in this group? Hearing none, I will accept a motion to grant these permits.
I'll do the second. Mine was muted. I'll make the motion.
Okay, so I was like, I didn't hear the motion.
I was so confused.
Dr. Mack on the motion and Dr. Newsom on the second. All in favor, raise your hand, keep it up, and say aye out loud.
Aye.
Aye out loud.
I knew somebody was going to do it. Okay, you can put your hands down. Any opposed? The motion carries. So if you are in the next group, don't panic. We're going to call you up here in a minute. We just do this in sections. So if your name wasn't called, don't worry, you're probably coming up. And I'll turn it back over to Dr. Kirtley.
So a couple of things for you, and we'll go ahead and get this out of the way for group 2 since they should be on. We do audit 100% for CE. You do have to have your CE requirements for Arkansas. This is the first year of the biennium, so it'll be 30 hours with 12 live, 12 being nationally accredited. If you are not sure about your nationally accredited CE, it should be in your CPE monitor profile. If it's not in there, it's not going to count. Couple of other things, you will see if you have questions about practice issues or anything else, call our office. If we don't answer the phones, it's because they're all tied up. We do not have a computerized answering system except for after hours or when all the phones are busy. Dr. Kraus, you want to tell them real quick about our state association, which is very involved?
Yes, thank you. We have a very active and successful association of pharmacists, the Arkansas Pharmacists Association, and would invite, ask, would love to have you join. And we have just stay in the know of what's going on politically in the state and in the surrounding areas. So anything I missed there, John?
Now, I think that's the biggest thing for a lot of people that join it. They do it because they get more real-time political information than what the Board of Pharmacy is actually involved in. The other thing I will tell you is, especially if you're practicing in Arkansas, we do have a closed Facebook group of Arkansas pharmacists. It's the Arkansas Pharmacist Q ampersand or and symbol A, that a lot of people share tips about things such as suspicious prescriptions, job openings, ask professional questions. A couple of us on here are moderators and even answer a lot of regulatory questions. If you're interested in that, you can find it on Facebook, and we would ask you to answer the question. You're an Arkansas licensed pharmacist, and then we would admit you into that group as well. With that, that is everything I have for the first group. We would dismiss you if you have already had your interview with the board today. And then as everybody gets off, I'll give just a second for that. Thank you, guys. And then we'll start with the second group here in just a moment.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thanks.
Madam President.
Thank
Yes,
you.
sir. Yes, sir, Dr. Krause.
Can we have like a 3-minute comfort break,
Yes.
please?
I'll let you guys have a break, and I'll orient everybody that's about to come up.
Thank you.
I just refilled my coffee, so.
Yeah. All right, for everyone that is joining us for our 9:30, we are just a few minutes behind. That just happens sometimes. I think with Zoom, it actually takes longer to do this than it does in person with people coming up to the table a group at a time. What we will do today is we will be calling you up in alphabetical order. The first one we'll have today is we're in the G, so Paul Gleespin will be our first one when the board members get back. We're going to want to know 4 things from you. We're going to want to know who you are, where you're from, or like where you live, where you went to school, and why you're getting a license in Arkansas. Most of you that have come on site to take your test have already been through this with me or with someone else on our staff, as we generally try to do that as part of our testing procedures. If we have any issues with Zoom connectivity, generally what we will do is we will hold your name and come back to you at the end of the group. This group will end with Matthew McDonald. So we've got about 24, 25 of you in this group. So as soon as our board members get back in just a moment, we will get started. Does anybody have any questions? All right, seeing none, we will be back in just a moment. So for everyone that's waiting on Reciprocity, staff just reminded me to tell everyone that when you get through this process, we will be processing your license and mailing it out like today or tomorrow. After the last group of 25 people got off, our office phones are already ringing with people asking when they're going to get their permit. It's like we can't hand it to you through Zoom, unfortunately, so it's going to be a couple of days, but we will process those this week. With that, I think that we have people popping back on from our board. I've got at least part of you on here. There we go.
Hey, how are you?
We will call you up alphabetically in just a little bit.
Okay.
John, I'm not sure. Did you say that it's okay for them to have their camera off until it's their turn, and then we do prefer that they turn the camera on?
I did not say that, but we would absolutely be fine with that.
Okay. It helps the bandwidth on the Zoom, or I don't know, bandwidth might not be the right word. It's not my department, but we do like to actually see you when you're talking to us. So if you are not camera ready, you have about 3 minutes.
So this group will be alphabetical. We will go from the G's to the middle of the M's, and then we'll pick up again with the next group and do another orientation for the last group of M's. So we're running just a little bit behind with some Zoom challenges this morning. I think that we've got everybody. Dr. Mitchell, if you want to start on this group.
Ready, set, go.
All right. Once again, just as a reminder, the board's going to know who you are, where you went to school, and why you are getting a license in Arkansas. First up, we've got Paul. Is it Gleespin?
That's correct.
Okay.
My name's Paul Gleespin. I'm coming to you from Hunt Valley, Maryland. Went to the University of Maryland for my pharmacy school training, and I currently work for a company by the name of AIS Healthcare. We have 3 distinct divisions, one of which is a specialty pharmacy. We currently have 5 locations throughout the southeast of the United States, and I have been tapped to start the Maryland location, which will service the Northeast and also serve as a redundancy for the Southeast locations. Currently not licensed in Arkansas. We are starting the process. We transitioned our facility to Dallas, and we're starting with a clean slate to build the specialty operations here in Maryland.
So are you in the process of getting permitted in Maryland?
That's correct. We have a meeting with the board March 1st, I believe, to start the process. And then I have 2 years of training ahead of me before we're pretty much up and running. During that time, I will be spending most of my time in Valdosta, Georgia, at one of our facilities that services Arkansas. So they asked me to get my Arkansas license.
Okay. Any questions here? All right. Next month, I have Riker Grant.
Hey, good morning. Can you guys hear me?
Yes.
Okay. Hey, I'm Riker Grant. I am from Alexandria, Louisiana. I graduated from the University of Louisiana at Monroe College of Pharmacy in 2016. I've been a hospital pharmacist for 5 years, and I'd like to relocate to Arkansas, and I'm getting a license because I'd like to continue to work as a pharmacist in Arkansas when I relocate.
What area are you relocating to?
Little Rock. Okay. That's the plan.
Lots of big hospitals right around here.
Great. That's great news.
Any questions for Dr. Grant? Seeing none. Next up, we have Sharon Grant.
Hi, good morning, everyone. My name is Sharon Grant. I'm currently living here in Tampa, Florida. I graduated from Howard University College of Pharmacy in 2008 and currently seeking licensure in Arkansas so that I can be the PIC of our pharmacy here in Tampa, which is seeking licensure in Arkansas by the name of IV Solutions RX. And we service mainly patients that have rare disease states, and we do home infusion therapy for those patients.
Any questions for this, Dr. Grant? All right. Next up, we have Brandon Green.
Hey, good morning. My name is Brandon Green. Can you hear me?
Yes.
Okay, great. I went to school at Butler University. I graduated in 2014. I am out here in Colorado. I work for Welldine Mail Order Pharmacy, and I'm going to be hopefully taking over here as the PIC here in the coming months.
Any questions for Dr. Green? All right. Got Rebecca Griffey. I think you're on mute. There you go.
Now, okay. My name is Rebecca Griffey, and I went to school at Northeast Louisiana University School of Pharmacy in Monroe, Louisiana. Can't call it the other thing because it doesn't make any sense to me. But I'm a Texan that recently relocated to Minden, Louisiana. I also am a remote order entry pharmacist for LifePoint Health Service Center out of Brentwood, Tennessee. So we are required to get several licenses. LifePoint recently merged with Kindred Healthcare and they formed a new company called Scion. So that may be, I also work with one of the other candidates that you just interviewed in the first group. That may be the company that is filing for license with the board and not LifePoint. It may be called Scion. But that's what we do. We service remote facilities that do not have overnight staff. And to work for the state of Arkansas, I'm required to be licensed. So that's why I'm here. Also, a shout out to Nancy Sweet. She didn't see me on, I mean, she's like your super person for pharmacy. She didn't see me on camera and actually called me and said, "Are you on?" So, wow. Thank you, Nancy.
Well, and you've got Nita's there in Minden, Louisiana, as I recall.
We do.
I went to school with the son of the owners or former owners, so I've heard a lot about it.
I haven't been there yet. I mean, we just moved here. We've been here less than a month, so I haven't eaten there yet. We're still unpacking boxes, and it'll be a while.
I understand. Any questions for Dr. Griffey? And what you can't see is Miss Sweet from time to time will take off running down the hall towards me to tell me what I forgot also. So she's keeping me covered as well. All right, we've got William Haygood.
Yes. Hey, I'm Will Haygood. I live in Madison, Mississippi, just outside of Jackson. I graduated from University of Mississippi School of Pharmacy, and I'm applying for licensure to become the PIC. We'll be submitting our pharmacy permit soon for Vital Care of Central Mississippi. We're a home infusion pharmacy currently servicing the whole state of Mississippi.
Any questions for him? All right, see none. Brian Highfield.
Hi there, my name is Brian Highfield. I'm from Tulsa, Oklahoma. Went to pharmacy school at the University of Oklahoma, Tulsa. Graduated in 2009. I currently work for Care First Pharmacy in Broken Arrow, Oklahoma. We are a full retail pharmacy and a full non-sterile compounding pharmacy. We currently hold an Arkansas license. The PIC that was here before left for another job opportunity. So I am applying for licensure to take over his spot as the PIC for Arkansas.
Any questions for Dr. Highfield? All right. Next up, I have Christopher Horning.
How you doing this morning? Christopher Horning. I reside in Marcy, New York. Graduated of Albany College of Pharmacy in '96. Spent 2 years for chain retail pharmacy and 23 years at a independent retail pharmacy. Work for Propel Pharmacy. It's a mail order pharmacy here in Cicero, New York. We exclusively fill prescriptions for a parent company, Norris, which is a telemedicine company.
And what is Nurex? And I know we've got Dr. Hurd up with you here today. What is Nurex?
Can you hear
me? You're choppy on our end, but I could make most of that out.
Nurex is a company. They initially Norris is a telemedicine company. They initially. What did you say?
I'm sorry, we are.
I think he's still responding to you.
Yeah, it's real choppy on our end.
Okay, I'm sorry.
You. So we've seen you. Let's see if I can. Yeah, I'm gonna stop your video and see if that might help us at all. If we can actually hear you.
Okay.
That might be a little bit better. So tell us again about Nurex. Dr. Mitchell, if it's okay with you, I would suggest that we might let them exit and come back.
Norris is our parent company. We fill prescriptions exclusively for them. They are a telemedicine.
Yeah, we're getting like sporadic bits and pieces. So do you guys mind to be kind of an exception to the we want to see your face when we're talking to you rule, and maybe call back in without video, just using audio only, and then we will come back to you guys at the end of this group so we can hear about Nurex.
Okay.
And we'll do that for Horning and Hurd.
Yes.
All right. So I have Angela Huddleston.
Good morning. I am Angela Huddleston. I am in Castle Rock, Colorado. I graduated from the University of Colorado in 2009. I currently work for Walmart and am looking to relocate to Arkansas with Walmart.
And what part of Arkansas?
I'm looking at Rogers.
Okay. Any questions for Dr. Huddleston? All right. I'm going to skip down to Lynn Marie Jansen.
Have myself on mute. There we go. Hi.
There we go.
Hello. Hi. I'm Lynn Jansen. I'm from Columbus, Ohio. I graduated from Ohio Northern in 2010. I work for Solio Health Home Infusion Pharmacy, and I'm getting licensure to be a backup to our current pick.
Any questions for Dr. Jansen? All right. Next up I have, is it Ms. Teresa Joseph? You're on mute.
Hi, my name is Ria Joseph. I currently live in Frisco, Texas. I graduated in India. I'm a foreign graduate. I came here, I did my internship, and finally became the pharmacist at Sanzarix Pharmacy. Currently, I work with Sanzarix Pharmacy at the Frisco store.
Okay. Any questions for Dr. Joseph? All right, seeing none, we have Dr. Kadakia, and you can
Hi.
correct my pronunciation on that.
Yeah, good morning. Yeah, my name is Vaibhav Kadakia. I am in like the Chicago suburb area. I graduated from Drake University in 2016 in Des Moines, Iowa. I worked retail, and currently I work for CPS Telepharmacy. And what I do is a remote order entry for hospitals around the country, including several in Arkansas. So that's why I have to get licensed in Arkansas.
Any questions for him? And I think everybody's familiar with CPS already. All right. Let's see. Newport, is it Kalki?
Yep, that's me.
All right.
So I'm from the Chicagoland area. I also work for CPS Telepharmacy. We do more the clinical services, so MTM therapy or MTM services. And one of the states that we service is Arkansas. So that's why I'm applying for my license. And I went to Midwestern University, Chicago College of Pharmacy, graduated in 2009.
Any questions for her? Because if not, we have Dr. Kapoor up next, and she's also a CPS.
Hi, my name is Manisha Kapoor. I am from Chicago, suburb of Chicago, Naperville. I graduated from Midwestern University in 2016, worked for retail for about 5 years, then moved to CPS along with Nipper and Vivek and Sarah. We do clinical care services, transition of care, MedRex, discharge counseling, and of course, remote order entry. That's why, and one of the state, as everybody else said, we need to get licensed in Arkansas. So that's why we all are here today.
You just helped me increase the names of pharmacists with the last name starting with K by like 10-fold. Any other questions for her? All right, next up we have Robert Knight.
Good morning. My name is Robert Knight. I'm in Tucson, Arizona. I graduated from the University of Colorado in 1998. I'm seeking licensure in Arkansas to be the backup pick at my employer, MedWise RX. We're an MTM pharmacy.
Any questions for Dr. Knight? All right, Shannon Landry.
Good morning, I'm Shannon Landry. I'm originally from Fort Myers, Florida. I got my degree at the University of Florida. I most recently worked federally at Pine Ridge Hospital in South Dakota, but you didn't have to change your license when you're federal. It can be from anywhere. Yeah. Now I'm moving to Arkansas, the Fayetteville area, to be with my family, and I want to be able to continue to work. So I'm looking for an Arkansas license.
Okay. Any questions for Dr. Landry? All right. Next up, we have Rebecca. Is it LeBay?
It's Levitt.
Levitt.
I'm pretty close.
I tried to make it fancy.
That's right. Yeah, it can sound French. That's fine. My name is Rebecca Levitt. I live in Glendale, Arizona. I went to school at Midwestern University here in Glendale. I am the Quality Assurance Manager at Atlas Pharmaceuticals. We're a 503B outsourcing facility. We were last inspected in May of 2021 by the FDA. and I'm seeking licensure to be a backup to the PIC.
Any questions for her? All right, seeing none. Reva Malky.
Hi. I'm Reva. I'm from Detroit, Michigan, suburbs originally. We moved to Conway, Arkansas last year, so for my husband's work, so I'm seeking licensure here. I graduated from Chicago State University in 2016, and I've worked for CVS. I haven't worked for a couple of years now, but I'm planning to go back soon.
So just a warning, if you're out of practice for 2 years, you have to work under supervision of a pharmacist for a certain number of hours in order to practice, which in many ways.
Actually, yeah, it won't be 2 years until June. So yeah, I think
in many ways it's a protection to help you not be like a pharmacist alone, you know, your first couple of weeks back.
Okay, that's good to know. I didn't know that.
Any questions for Dr. Malky? All right.
Thank you.
We have Sarah, is it Malababic?
Yeah, pretty good. Malababich.
Babich, okay.
All right. Hi, my name is Sarah Malababich. I am from Chicago, Illinois. I graduated from University of Illinois at Chicago in 2019, and I am getting an Arkansas license because I work for CPS Telepharmacy, along with everybody else who's already been on this meeting, and we service Arkansas.
Any questions for her? All right. Mitchell Manor.
Morning, my name is Mitchell Manor. I'm in Indianapolis, Indiana. Went to the Ohio State University, graduate 2013. I'm with Olivet Pet Pharmacy. I'm currently the PIC, and we are hoping to begin shipping to Arkansas.
All vet specific orders?
Yeah, all veterinary prescriptions. Yep.
Not salespeople orders?
No.
People laugh, but we've seen cases on it.
Right.
Any questions for him? All right. Next up. Is it Sa Marapu?
Yes, Sai Priya Marapu. Can you hear me?
Yes.
Okay, my name is Sai Priya Marapu. I am a pharmacist who graduated from India in 2016. I'm originally from Corpus Christi, Texas. Recently, we moved to Texarkana. I started working with Albertsons on Texas side, but now I'm seeking licensure to be able to render my services for the only Albertsons store that is located in Arkansas. And a huge thanks to Ms. Sweet for being so supportive, and also for Mr. Kirkley, because I don't feel shame to tell everyone that I failed my test for the first time because of many family issues, and I wasn't the greatest at the moment, but then Arkansas State Board of Pharmacy is one of the biggest support. I took my test for the second time, passed the board, and now I'm here.
We told you could do that.
Thank you. And right now I tested positive for COVID. This is my 6th day of quarantine. So I'm not feeling the greatest. I am having fever and cough and chills. If the board is okay, I would like to request that I would like to leave once after I introduce myself, because I'm feeling terrible now.
We have like 3 more people, so it's only gonna be a couple more minutes for you.
Yeah, that's fine then. Yeah, it's been 2 years I'm working in the COVID situations, but I got tested positive now.
Man, we'll keep moving along so we can get you done. Heriberto Martinez.
Dr. Kirtley, we're going to see him at the very end of reciprocity.
Okay, my apologies. And actually I see that on my secondary list. So Warren Mark. Robert Warren Marks.
Hi, good morning. My name is Robert Martz. I'm here in Kansas City, Missouri. I graduated from South University School of Pharmacy in Columbia, South Carolina. I work for a company named Sophie. We're a nuclear pharmacy. We already have a non-resident pharmacy permit with Arkansas. The reason I'm here today is because the current non-resident PIC has left to pursue another opportunity. So my company would like me to fill his position.
Any questions for Dr. Martz? All right. Sherry Malden.
Hi. Yes. Let's see. Am I muted? Let me see.
Nope, you're good.
I'm good. Okay, great. Yes, I'm Sherry Malden, and I graduated from the University of Mississippi, also known as Ole Miss, in 1990. 1990, I think I'm the oldest one on here. And I live in Knoxville, Tennessee right now, and been here, about a year and a half. And I work for Fresenius Medical Care. I'm a PIC here, and we handle dialysis products across the United States. We have several distribution centers. I believe you had mentioned Benji, being at the one in Arkansas, who was once with the board. And let's see, what was the other question about why I want to get my Arkansas license? Is so that we can, we will do a lot of like cross coverage, I guess, type things to ensure if there, say, is a natural disaster, or, you know, the building, something happens, or our patients aren't, you know, they're not without. We will just, you know, take the more expensive route of shipping farther. So.
And I think most of us are familiar with Fresenius. Any questions for her? All right, seeing none, the last of this group, until we catch up with the two others, Matthew McDonald.
Hey. Hey, my name is Matthew McDonald. Born and raised in the Chicagoland area, like quite a few people went before me. I also worked for CPS Telepharmacy in the remote order entry and verification side of things, which is why I'm seeking licensure in Arkansas so that I can legally serve those inpatient facilities. I went to the University of Iowa College of Pharmacy, graduated 2020.
Any questions for Dr. McDonald? All right, let's bounce back to Dr. Horning and Dr. Hurd. Let's see if we've got a better connection now.
Hi, how are you?
Doing well. I can hear you very well finally. So my question earlier is if you could tell us a little bit about NurX and how you guys are getting prescriptions.
So they employ their own providers, and those providers send the prescriptions over directly to us or any of the other pharmacies that they have that we can't fill. They do give the option if there's a prescription that we for some reason we can't supply, we will offer to send that prescription over to a local pharmacy in their area.
And this will be for both of you, but you probably also should look at the newer Arkansas laws about how patient prescriptions, especially on out-of-state pharmacies, are accessed, because if patient doesn't choose your pharmacy, you cannot have their prescription. It doesn't matter who really steered it to you. The patient has that authority up front, else you can't just have like a business sharing agreement or anything else under HIPAA. It's a more stringent law in Arkansas. And we also, Dr. Hurd, if you want to let us know who you are, where you're from, where you went to school as well.
Yeah, hi, I'm Kathleen Hurd. I went to Albany College of Pharmacy and Health Sciences. I was a nuclear pharmacist for 7 years before I started here at
Propel in October.
Any other questions for either of these?
I went to ACP also, just saying.
Okay. Dr. Mitchell, that's it for this group.
All right. Any questions from any of the board members for any of these candidates for reciprocity? Hearing none, I will open the floor for a motion to grant these applicants pharmacist licenses.
So move.
Second.
All right. I have a motion from Dr. Richmond and a second from Dr. Jolly. All in favor, hold your hand up and say aye.
Aye.
Aye. Any opposed? The motion carries. Dr. Kirtley?
All right, so you guys should have already heard the following. You will get your licenses mailed out sometime the next couple of days, so be patient with the mail service. Please do not call us and ask us when you'll receive it because we cannot control the rate of delivery after it leaves here. Once again, CE requirements, 30 hours, 12 live, 12 ACPE. For anybody that's in the next group, you should already be on. We do have a very active association in the state of Arkansas that many pharmacists wish to join because they do more political updates as to what's going on politically and opportunities and so forth that really come to the Board of Pharmacy. And we also have a private Facebook group, Arkansas Pharmacist Q and symbol A, letters Q and symbol and letter A. If you ask to join that group, let us know if you're an Arkansas licensed pharmacist. There are a lot of regular questions people found on there, a lot of advice, as well as job opening opportunities, forgery notifications, and things like that. So if you have any questions about any of that, please do not hesitate to contact us. But that is all I have for this group, unless I've forgotten something else. No. All right. Well, everybody in that second group, you are free to leave, and we will pick up with group 3. The first one in that group will be Jill Bearer.
Hello. My name is, can you hear me? Sorry.
Give us just a second. We've got a whole bunch of people leaving, so our screens are all scrambled for just a moment.
No worries.
And for this group, I know some of you have heard this or observed this. We're going to want to know who you are, where you are from, where you went to school, and why you are getting a license in the state of Arkansas. Okay. All right. Have at it, Jill.
Okay. Hi, my name is Jill Mayer. I am from the Phoenix, Arizona area. I went to U of A College of Pharmacy. I am currently working for Chewy Pharmacy, veterinary pharmacy mail order. I am getting an Arkansas license as my role is backup pick for Chewy Pharmacy.
Okay. Any questions for her? All right, seeing none. Next up, I have Jamie Sue Montesano. We have her on. All right. We will come back and try her again later. I have Salita Moore. There you go.
I'm Salita Moore. I'm from Rock Hill, South Carolina. My pharmacy location is in Charlotte, North Carolina. I went to the University of South Carolina's College of Pharmacy. At that time, it was the South Carolina College of Pharmacy. I graduated there in 2013. Right now, I am working at Queen City Pharmacy, which is a pharmacy location for True Peel, and this one is located, of course, in Charlotte, North Carolina. I'm the PIC, or the pharmacist in charge, and I am seeking licensure in Arkansas so that if we need to, we'll be able to ship to patients in Arkansas. We are direct shipping to their location as well.
Okay. Any questions for Dr. Moore? Seeing none. Jason
John.
Morgan. Oh,
I'm sorry.
Lynn.
I was just going to ask, what type of prescriptions the pharmacy delivers?
Mostly is birth control, erectile dysfunction, antidepressants, and some maintenance medications.
Specialize a lot.
And how do you get these prescriptions? I'm sorry.
Most of them are electronically prescribed by the prescriber to the pharmacy of choice by the patient. So they choose us and then we fill it.
A lot of.
How does a patient find out?
Through the prescriber, they give them the option of where they would like to get it filled. And some of them have just direct patient selection. Just depends on what kind of medication it is.
Is there any kickback to the prescriber?
No.
So, Dr. Krause, some of these are set up through different telehealth companies for lifestyle meds that they will offer to connect the patient, to a contracted pharmacy or their pharmacy of choice of the patient. Anything else? All right, Jason Morgan.
Hello, my name is Jason Morgan. I am from Buffalo, New York, and I graduated from DeVille College of Pharmacy in 2016. I'm getting licensed as a backup pick for the 503B pharmacy that I work for.
And when was your last FDA?
About 2 years ago. They should be there any day. And then California is going to be there in 2 weeks. They've got us scheduled.
Okay. Any other questions for him? All right, I've got Christy Neely up next.
Hey, I'm Christy Neely and I'm from Jackson, Mississippi. I graduated from Ole Miss in 2002. I work for an independent home infusion company in Jackson, and we are trying to get in with our Blue Cross Blue Shield of Mississippi as a designated specialty pharmacy, which requires us to be able to provide to all their members regardless of where they live. So we just need to be able to ship specialty meds out of state if needed.
Okay. All direct to patient?
Yes.
Any other questions? All right. Next up, we've got Kimbrell Nelson.
Good morning. My name is Kimbrell Nelson. I'm from Memphis, Tennessee. I attended pharmacy school at the University of Tennessee and then moved to now Columbus, Ohio. I currently work at Script Hero Pharmacy, and I'm seeking licensure in Arkansas to serve as the backup pick.
Any other questions? We already talked to somebody from Script Hero, so. All right, seeing none, we will move on to Catherine Norris.
Good morning. My bandwidth just kind of broke up, so I'm hoping you can hear me.
We're good.
Okay, my name's Catherine Norris. I went to Western University of Health Science in Pomona. I work at Advanced Diabetes Supply Pharmacy. When I applied, I was applying for backup PIC. Right after I sent my application, our PIC resigned. So now I'm applying for Arkansas PIC. We do diabetes supplies. We ship all over the country, including Arkansas, which is why I'm applying for my Arkansas license.
Any questions for Dr. Norris? All right. Michelle O'Neill.
Hi, good morning. I'm Michelle O'Neill. I'm from Mount Laurel, New Jersey. I graduated Rutgers in 2005. I'm with Stokes Pharmacy, and I'm trying to be the backup PIC for Arkansas.
And on your compounding, all patient specific?
Yes, we are a patient-specific pharmacy.
And is everything going directly to the patient, or is any of it going to prescribers?
To the patients.
Okay, on here it says compound for office stock, and it says veterinarians, apomorphine, metronidazole, cisapride, cidofovir.
Cidofovir. Yeah, we do. Yeah, that's true. We do a little bit of office supply too when needed.
So it's not all directly to patients?
No, sir.
Okay. So you will probably want to listen to conversations we are having this afternoon at 1 about the legality of veterinary prescription office stock.
You got it.
Any other questions for her? All right. Maru Ortega.
Good morning. My name is Maru Ortega. I am from Chino Hills, California. I graduated from Western University of Health Sciences College of Pharmacy in Southern California. I am seeking licensure to become the pick for New Factor at our Temecula location. We are a specialty home infusion pharmacy, and we have patients across the nation, including Arkansas.
Any questions for Dr. Ortega? Seeing none, I have Casey Orton up next.
Hi, good morning. My name is Casey Orton. I'm from Scottsdale, Arizona. I graduated from Creighton University in 2011, and I currently work for OptumRx, and I'm just looking to provide some license redundancy for the home delivery pharmacy should it be needed.
Any other questions for Dr. Orton? All right, Dr. Patel.
Hi, my name is Dhwani Patel. I am originally from Valdosta, Georgia. I work with Advanced Infusion Care, and around September, I moved to Dallas, location of the same company, Advanced Infusion Care, and took over the PIC position as the previous PIC left. So I'm getting Arkansas license because our pharmacy license was due to renew end of last year. But as we did not have the Arkansas licensed pharmacy, our compliance department is working closely with Arkansas Board of Pharmacy to get that compliant. I graduated from pharmacy school in 2012 from Toro College of Pharmacy, New York. Since then, I spent most of my time at retail and been with Advanced Infusion Care for past 3.5 years, and we mainly supply immunoglobulin therapy to different states.
Any questions for Dr. Patel?
What was the name of the company again?
Advanced Infusion Care.
We're familiar with them, Dr. Krause. Anybody else? All right.
Thank you.
Absolutely. Larry, is it Piccone?
Yeah, it's Piccioni. How are you guys?
Doing good.
Good. So my name is Larry Piccioni. I graduated school 2016 from Albany College of Pharmacy and Health Sciences. I currently work in Mount Pleasant, South Carolina at a specialty pharmacy, Blue Sky Specialty Pharmacy. And basically our pick left, and I'm getting licensure in all the states needed for me to take the position.
What's special about Blue Sky?
Basically, we work with, well, first off, we're like the biggest rheumatoid how do I say this, and GI, I think, practice in South Carolina. We do the most prescriptions for that disease state. And basically we deal with high dollar medications to get patients patient assistance and making sure, you know, helping them in the doctor's office, putting them on the correct therapy. And basically after we get the patient on the phone, we do like the initial assessments and then mail it to the patient.
Okay. Any other questions for him? All right. Next up, we have Michaela Pennington.
Hi, everyone. I'm Michaela Pennington. I went to Ohio Northern University, graduated in 2017, currently in the Columbus, Ohio area. I also work at Script Hero Pharmacy and am seeking licensure in Arkansas just to serve as another option for a backup pick if needed.
Okay. And I know we've already heard from a couple other Script Hero people today. We've got that flag for future application to go through the business model of it, just so you guys know.
Yes, sir.
Any other questions for Dr. Pennington? All right. Brandy Pickle.
Good morning. My name is, can you hear me?
Yes.
Okay. My name is Dr. Brandy Pickle. I'm from Farmerville, Louisiana, just south of El Dorado, Arkansas. Went to school at the University of Louisiana at Monroe, graduated in 2005. And I'm seeking Arkansas licensure to be a consultant at large for Omnicare Pharmacy. I'm currently a consultant for Louisiana, Mississippi, Georgia. I think that's all the ones I'm working for them right now. But so I'll just be serving as a consultant at large, mainly doing admission medication reviews for the primary consultants for the homes.
So if you'll wait till Valentine's Day, you'll want to read the new rules because we just got rid of the endorsement process for consultants. So there's no longer in charge or at large. It's just consultant pharmacist.
Okay. Yes. I saw where you've gotten rid of the requirements for the extra.
Yeah, the extra CE, the extra fees, all that's gone. If you're doing a good job, they'll keep you hired, and if you're not, they won't.
Correct.
Any other questions for Dr. Pickle? All right, Benjamin Rapp.
Yes, can you hear me?
Yes, sir.
Hi, I'm Benjamin Rapp. I'm in Franklin, Tennessee. I work for a company called Premise Health. They run on-site clinics in pharmacies for large employers. Premise, I went to college, University of Tennessee College of Pharmacy in Memphis. Premise Health has employees all over the country, so we're looking to get licensed in Arkansas so that we can service those employees and their families from the pharmacy here in Tennessee. Did I miss any of the questions? Nope, got it.
I think that's got us.
All right.
All right. Any other questions for him? Next up, we have Jean Reed.
Good morning. My name is Jean Reed. I graduated from St. John's University. I live in Long Island, and I work for a CareMed specialty pharmacy. And the reason I'm getting licensed in Arkansas is for license redundancy. In case something happens to the pick, I will be the replacement pick.
Okay. Any other questions for Dr. Reed? All right. Terkeisha Robertson Jones.
Good morning. I'm Terkeisha Robertson Jones. I reside in Atlanta, Georgia, and I work for CareSource. CareSource Pass is one of the new passes in the state, and so it's a requirement from a state requirement for our contracting for a pharmacist to be on the board. So that will be me.
Any other questions for her? All right. Natalie Solis.
Good morning. My name is Natalie Solis. I went to Midwestern University in Glendale, Arizona. I live in Scottsdale, Arizona. I work for Covetrus, and we're currently applying for our non-residency permit in Arkansas, and I am the pick, and so I'm requesting or coming, trying to get my Arkansas license.
Any questions for her?
John?
Yes.
Yes.
What type of practice is it? Can you explain it a little bit to me?
Sure. Covetrus we're only veterinary medications. We do both commercial and compounded.
Thank you.
Thank you.
So you probably also need to listen to the discussion at 1 o'clock today about veterinary office stock.
Yes, I made note of that.
Okay. Any other questions? All right. Stephen Shepard.
Good morning, everyone. My name's Stephen Shepard. I graduated from the University of Maryland at Baltimore. I currently work in Los Angeles County for Albertsons Safeway. We are a combination facility of central fill and mail order. Mail order is going to be the reason why we need to have an Arkansas license. We don't really send any central fill to your state. Currently, I'm the interim manager in PIC. I'm just covering a leave, but I'm also going to be the acting backup when she comes back.
Okay. Any other questions for Dr. Shepard? All right. Next up, we have Richard. Is it Tabar?
Tabar, yes, Rick Tabar. So I'm from Ohio Northern University, seeking licensure in Arkansas, try to become the PIC for Walgreens. I interned for Walgreens, graduated in 2013, by the way. Interned for Walgreens for 4 years and have been with them combination about 6-7 years. And just seeking licensure for the store in Van Buren, and I'm currently living in Fort Smith, Arkansas.
And how did you get Dr. Awesome as your phone ID?
The truth is, I had an ex-girlfriend who changed my phone ID, and I can't change it back. So,
Fascinating. I didn't know you could even do that.
I didn't either. She's a smart one.
Any other questions for him? All right, Andrew Bowe.
Hi, my name is Andrew Vo. I am in Phoenix, Arizona. I went to the University of Arizona and graduated in 2016. I'm currently the PIC here at Amazon Pharmacy, and I'm seeking licensure in Arkansas to be able to ship prescriptions to your state.
Okay. Any questions for Dr. Bowe? All right, Aaron Webb.
Hi, I'm Aaron Webb. I live in the Phoenix area. I graduated pharmacy school from the University of Arizona in 2020. I currently work for a specialty home infusion pharmacy called Solio Health. We have branches all across the country, but we're going to be a shipping hub here in Phoenix. So we'll be shipping specialty and home infusion medications to patients in Arkansas.
Okay. Any questions for Dr. Webb? All right, William Westcott.
Good morning. I'm Bill Westcott. I live in Durango, Colorado. I graduated Temple University, class of '94. I currently work for Farm Care USA. We have long-term care pharmacies throughout the country and one in North Little Rock. I will be assisting for medication regimen reviews remotely for several facilities that pharmacy serves.
Any other questions for him? All right. Sean Williams.
Good morning. My name is Sean Williams. I'm a pharmacist from Columbia, South Carolina. I went to the University of South Carolina. I currently work for Avita Pharmacy. We specialize in HIV treatment, and Avita just wants me getting licensed in the state of Arkansas for the purpose of shipping HIV medications to the state of Arkansas in the future.
Any questions for him? All right, Rebecca Wilson.
Hello. My name is Rebecca Wilson. I graduated from Ohio Northern University in 2015. I live in a suburb of Columbus, Ohio, Heath, Ohio. And I'm also applying to be a backup to the backup for Script Hero Pharmacy.
Any questions for her? All right, seeing none. Uzair Zahid.
Yeah. Hi, everyone. My name is Uzair Zahid, and I'm originally from Pakistan. I'm a foreign graduate, and I graduated in 2016. Right now, working with AFA Mail Order Pharmacy. We are not currently licensed with Arkansas Board of Pharmacy, but we are planning to. We already have a pharmacist who is licensed in Arkansas, so I'm just getting a license as a backup.
Any questions for him? All right, backing up, I think I had Michelle Meyer. Got a note that she's with us now.
Hi, I'm Michelle Meyer. I live in New York City, New York. I went to school in Boston, Massachusetts at Northeastern University. I currently also work for Truepill in the Brooklyn location in New York. And I am applying so that we can eventually apply for a non-resident pharmacy permit.
Any questions for her? All right. And then I believe I have, is it Jamie Montesano? I think we're missing earlier.
Hi, yeah, so sorry about my microphone fail earlier. My name is Jamie Montesano. I live in Kansas City, Missouri, and I work for CVS Specialty in Lenexa, Kansas. I'm getting my, I graduated from University of Missouri, Kansas City in 2013, and I'm looking for my license to be the backup pick for the Arkansas patients we service.
Any questions for her? All right, seeing none, this is all I have for the last big group. We have one individual after that. So Dr. Mitchell, I would turn it over to you.
All right. Any discussion or questions from the board members? Hearing none, I will open the floor for a motion to grant these applicants a pharmacist license.
So moved. I'll second.
All right, I have a motion from Dr. Newsome and a second from Dr. Mack. Board members all in favor, say aye and raise your hand.
Aye. Aye.
Any opposed? The motion carries.
Okay. All right, guys, you've already kind of heard the rundown on CE and when you will get your licenses, as well as just a notification about the local pharmacist association, as well as the closed Facebook group. That is all that we have for all of you that have spoken with the board today. So you are welcome to sign off. And then for the board members, we have one more individual here at the end.
Let them get off first.
Yeah. So it looks like we may have some other people on. If you do not have an appointment with the Board of Pharmacy before lunch today, you should not be on Zoom. If you want to watch, you're welcome to do so on YouTube. Because if we push you out, you can't come back in.
And a few of them maybe, I see a couple of them that are on.
Yeah, we've got our 11 o'clock up.
All right, let's go with Dr. Martinez. Will you unmute yourself there? Okay, we've got Roberto.
Yes, Heriberto.
We've got Roberto Martinez. He's on the Reciprocity today. He's actually at the board office. He came this morning to take the law exam, successfully passed that. So we have him here. He does have some issues. Board members, if you pull up your packet for Mr. Martinez, you'll see his application. That's on the first page. If you'll go to page 7, it's right after his CE. He's got his name on the top of it, and Wednesday, October the 6th, 2021. This is a statement that he sent in. He did check on his license. If you'll see the first page of his, the second page of his license. He did check yes, that he's had some issues with having disciplinary action, having licenses suspended or revoked, having been arrested. Does have those issues. So he does make a statement, and like I said, the statement it starts on page 7. If you go over to page 8 of the packet, which is the second page of his statement, he just kind of starts at the top there and kind of walks through some of the issues he's had. Theft. He had a theft back in 2003. Most of this is due to alcohol. He's gotten a couple of maybe 2-3 DWIs over the years. He did go to rehab. He was in treatment. He's also been in several state support groups. This started with out of Florida and Texas. He was in their support group. He was in Tennessee's. He was in Virginia's. All of this has started from these issues in each state, just kind of piggybacked the last states. You know, he was in their support group. They made him go into theirs, stuff like that. So he has had residential treatment. I show it. He was in residential treatment at the Orlando Recovery Center from November of 16 to January of 17. After that, did a 12-week outpatient program at New Bridge Recovery Center from January through March of that year. And said he completed his will complete his Texas monitoring program around October of 2023. So Dr. Mitchell, if it's okay with you, I'll just turn it over to him and he can kind of walk through these issues and what he's done since and just kind of where he is. Dr. Martinez?
Yes, hi. So yes, well, first of all, my name is Heriberto Martinez. I graduated from the University of Florida in 2007. I currently live in Orlando, Florida, and I practice at Optum Pharmacy. It's a mail order pharmacy. Getting licensed again as kind of a backup to the backup PIC as well. So yeah, pretty much all my issues have been alcohol related. I am a recovering alcoholic, but I have been sober since November 17th of 2016. That was a couple days after I actually showed up to work intoxicated and was pulled aside by my managers. And they said, is there something you'd like to tell us? I was like, yeah, I'm drunk. I'm an alcoholic. They transferred me to a facility to do a breathalyzer, and I was suspended. During that time that I was suspended, I contacted the Florida Professionals Resource Network, which is, they're like the impaired practitioner program for all healthcare personnel, except for, I think, nurses have their own. That ended up being in my favor. They wouldn't let me sign a contract with them until I went to residential treatment. Honestly, I tried to back out of it in the beginning because I was like, no, I think it might be better if I just do an intensive outpatient or something. And they're like, no, you need to go. You need to go to residential treatment. You need to be, you need to do this, or we're going to have to report you as an impaired practitioner to the Board of Pharmacy. So I was fortunate that none of this was ever reported to the Florida Board of Pharmacy. I think they have unofficial knowledge of me being in the program, but since there's no direct communication, they kind of don't consider that. But when I've been licensed in other states where I've had disciplinary action, I've had to report it to Florida.
and I've mentioned that I'm in the program. So with that, I'm actually right now, the contract should have ended last week. They're still just pending the last blood test that they did, a PET test, which takes about 2 weeks to get the results back. Once that's done, I'll officially transition over to my Texas contract, which again will run till about October of 2023. And that's where I'll do my daily check-ins for random drug screens. Any reporting will go through them. My Tennessee program it's like a secondary monitoring program. Oklahoma, I have a program in Oklahoma that's kind of an unofficial thing too. They both will require reporting from Texas as well. But with the end of my Florida contract, my Virginia contract will end. And then I also have a license in Colorado that was put on probation until the end of the Florida contract. So that should terminate as well. I'm just waiting for all the paperwork for the results from the Florida program to be able to request that my license be taken off probation in Colorado.
So you've been monitored, you're being monitored right now by Florida. Is that where you've been doing all of your checking?
Yeah, until they officially get that lab result back, at which point they can send me like a letter of completion, and they'll notify everybody else that I've signed a release of information for. They can send a letter to everybody as well.
In your Texas, you'll be monitored by them until 2023, is that correct?
Correct, roughly.
And how long have you been sober?
Since November 17th of 2016, so a little over 5 years.
So board members, those were the issues that staff had just due to numerous disciplinary action. Like I said, it's all related back to the one issue. But, you know, he was Florida, then Virginia, and then Texas. They just all kind of tacked on their own either probation or support group or their equivalent of the support group. So that was the issue that the staff had and wanted them to appear today to kind of explain that. Dr. Mack.
I just have one question. So Florida had him under contract and the other states just tacked on longer than Florida just because they got involved later, or?
So I guess when I applied for the other states, I disclosed everything and mentioned that I was in the recovery program. So some of the states, well, when I did Texas, they were the ones who said, I went to an informal conference with them, and they didn't put any disciplinary action on my license, but they said, we'll license you, but you have to agree to voluntarily enroll in our program. By voluntarily enrolling in their program, they actually made it so that I had to be in all 5 years, because I think if they make you go to the program, they could consider you for early release, but by me volunteering, I had to complete 5 years. Virginia just really wanted to be like a secondary monitor until I completed Florida's program. Tennessee wanted to be secondary until I complete both programs. And Oklahoma, they didn't make me sign a contract, but the Dr. Kevin Rich over at the Oklahoma Pharmacist Helping Pharmacists program, he just kind of reaches out every quarter to Florida and now to Texas just to make sure he gets like a quarterly compliance report. And that's pretty much been it with the other recovery programs.
Yeah, and staff would ask for something similar, progress reports, quarterly, however they do it, and for us to be notified if he has any type of positive alcohol or drug screen. But we would, like I said, and it still shows, when do you, I know it says 2023, does it say, okay, it shows October of 2023. So, a year and a half left on his Texas contract is what it appears to show. Dr. Krause.
I was going to say that to the board that I recommend, or I like what Luke's saying. I recommend that we do this, we follow suit.
And like I said, and that would be a quarterly progress report. And for him to, Texas has a very strict laws about what they provide to other states. So we would ask for him to sign a release that his, where we can get a quarterly report and also a report of any positive alcohol or drug screens during this period.
So move.
And I'll second it.
All right, I have a motion from Dr. Kraus and a second from Dr. Newsome. Board members, any additional discussion or questions for Dr. Martinez? Hearing none, all in favor of the motion on the floor, hold your hand up and say aye.
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 Any opposed? The motion carries unanimously.
Dr. Martinez, if you just have a seat up front, I'll be out there in just a moment, okay?
All right, thank you.
Dr. Mitchell, can we take a quick 5 minutes?
Sure.
And I'm just going to point out I have Larry Piccone and Turkisha that I think should have finished with their appearance. If you want to continue watching the board meeting, you can do so on YouTube. We ask that you're only in Zoom if you're here to meet with the board or speak to the board. If you are wanting to speak to the board later today on an issue, then you could log in whenever that issue comes up. Thank you, guys. We'll be back in just a couple minutes. I think we've got most of our staff back in place.
Erica and Brad and anybody else from Walgreens, if y'all want to turn your video on, we'll get started in just a minute. Did we lose Dr. Kraus? Oh, never mind. I see him down there.
Yeah, he's on there. He's not on screen. I think we've got everybody back. So we're a few minutes behind, but we had actually left an hour for this discussion without backing anything else up to it. Not scheduled in case we did get behind. We left 30 minutes to be sure we'd have 30 minutes. So we have with us several people from Walgreens. Just a second, I will let you guys introduce yourselves, and staff has had a previous conversation. You guys have some information in your packets regarding some complaints with some redactions, as well as notices of store closures. We have had concerns about store closures in Arkansas, and we're going to kind of discuss that today. So I'm going to kick it off. Erica, are you leading the group over here locally, or somebody else want to kick off introductions?
Thank you, Dr. Kirtley. I'm sorry. Did you have something, Dr. Mitchell? Sorry.
I do, sorry. Is this an informal hearing or just a discussion?
Luke?
This is more of a discussion. We had, there had been some issues brought up at a couple of previous instances where there were some issues with Walgreens store closures, people not being able to get their prescriptions filled, sometimes it taking several hours up to several days. So we asked Walgreens to just come today and talk with not only with Dr. Lawson, who is the local area manager, but also with some people from corporate to kind of see how this can be resolved and what's being done to be sure that people are able to get their prescriptions. We've had numerous complaints, and those complaints are attached in your packet, some of them, but the issues have been store closures, just, one day they're open, the next day they're not, issues with people calling and it taking hours and sometimes never getting a person. and also just taking days sometimes to get their prescriptions filled. So we've had a lot of those complaints. We have spoken to Ms. G, Dr. Lawson, Dr. Cover. We've spoken with them, the staff has, and so we just asked them, we just scheduled a day. The board, we've mentioned this to the board, I believe, at the last informal, and they said they wanted it set for discussion. So this is just kind of a discussion to see what's been done, how these issues are going to be resolved, mainly for the patient's safety so that they can get their prescriptions and, know what's going on with their medications. So that's kind of why we're here today.
Okay, thank you. I just wanted to understand the format we were looking at. Doc, I'm ready.
All right. All right. So as Luke mentioned, we have had a conversation with the board staff about this issue and the ongoing efforts by Walgreens to combat some of the staffing problems and the issues caused by COVID. So we've come here today with the people involved in the previous discussion, plus a few more, and I appreciate the opportunity to be able to talk with y'all about what efforts Walgreens has been making in this situation and answer any questions that you have. And I'm going to go ahead and turn it over to Lynn Stover. You asked for some input from higher up the corporate ladder. And so that's what we've brought you here today. And I'm going to let her go ahead and talk with you about what's been going on. Sorry, Dr. Stover, go ahead.
Thank you very much, Erica. And I thank everybody for allowing us to come this morning and talk with you. I thought what I would do this morning is really go through some information of what we've been experiencing at Walgreens, which I don't know is entirely unique, but really just wanted to fill you in on actions that we've been taking to date and some additional things we have planned going forward. But before I jump into that, I thought it might be helpful to introduce some folks and explain our organizational structure so you know who all is on the call today. So I'm the regional vice president, and I cover Arkansas plus 5 other states for our region. I'm also a licensed pharmacist, and I'm licensed in the state of Arkansas. And I think that, that's definitely something that maybe has given me a unique perspective on everything that's been going on and ways that I can help support maybe a little bit differently. Just knowing what that means and practicing as a pharmacist for many years, I don't take lightly what's been going on. At the regional level, I know many of you have met Tracy Bowman, and Tracy's my regional healthcare director for the region. She's on the call today, and she really helps oversee the healthcare aspect and pharmacies of everything that's going on within the region. And then we have Brian Stallworth, who's the director of pharmacy and retail operations. Brian's there local in Little Rock, and he is one of my direct reports. And he works very closely with Brad Lawson, whom I know you all know really well. He's our healthcare supervisor there locally in Little Rock. And Brad and Brian work daily with our stores and our district managers to take care of the daily operations and any challenges that may arise. We also have Nicole Cover on the phone as well, which I think many of you have met Nicole as well. And then Erica, I don't know if Dwayne is on as well, but Dwayne is our local counsel for Walgreens as well. So I don't know if Dwayne's on as well.
I'm here, Lynn. Thank you.
Yeah, no problem. All right, so, I think what I'll do is jump in, for us, I think we can all agree that the pandemic has been very difficult for a lot of different reasons. And as I stated earlier, I thought it may be easier to share with you what we've experienced and some of the things that we've done to address them. Since the beginning of the pandemic, each of my areas within the region, including Arkansas, their teams have developed what we considered a contingency plan very early on how to handle scenarios of mass illness and the potential need to close stores if we ever got to that point. And that was as far back as March of 2020, when we really started to see a lot of uncertainty what was going on with the pandemic. And it's a big piece of our business continuity plan. So we do have those, which are initially intended to be used for natural disasters or anything, any unplanned event, if you want to think of it that way. But then we fast forward to June of 21 is when we really started to see some concerns within the organization of pharmacists leaving the company, and Arkansas was no exception to that. It's actually something, that we've watched and we've really been trying to stay close to, like I said, across the region and across the country. And at that point, I do remember, Brian and Brad, working with them to develop a phase plan on what we would do as we started seeing staffing challenges and how we were going to strategically reduce operating hours across Arkansas. In response to that. And, this was a really new process for us and not something that we ever wanted to do as a company, but we also understood it was really necessary, seeing what was going on and really wanting to provide that consistency for our patients. And then, you come into August of 21, and that is when we actually had to start with this phased approach with changing operating hours. And to date, if we look from August until now, we've actually gone through 9 different phases of making changes with adjustments of hours, most recently even in this last week. And if you look across the entire state, we've reduced hours in 43 of our 73 stores, really to help mitigate the number of unexpected closures. So that's something that we watch very closely on a daily basis. And I think, as we've gone through all of this and we've really spent some time looking at it, there's been several things that we've learned. If we just focus on the pharmacist staffing piece that we've learned through the exit surveys and talking with individuals who are decided or who are leaving the company. And one is kind of been new and different, I think, than what we've seen or heard during the pandemic, is that we've seen people leaving the profession altogether. I think some of it is due to additional stressors. If you talk with them and understand what it's like to work in retail right now. I think that them leaving retail or pharmacy altogether, some of them are leaving, the retail setting to go into other parts of the profession, really to get away of some of those stressors, that directly deal with interacting with the public. So we have seen that. That's been a little bit new and different for us. I think the other thing that we've done, during that same time frame, we've done a lot of things to help with some capacity concerns, because as you know, there's been a lot going on in pharmacies these days. We're not only filling prescriptions, but we're trying to vaccinate for COVID. And then we're also trying to be a big force in testing as well. And one of the things that we've done, there's a few, but one specifically is reducing the number of appointments for testing and vaccinations, really specific depending on what's going on with each individual store. So not a cookie cutter approach, but really looking at each individual location. We've also added contract immunizers this past fall to really help in our busiest stores, really to take some of that pressure off of the pharmacist in those locations. Looking at and implementing pay changes, not only for the technicians, but pharmacists as well. Bonuses for the technicians and pharmacists. We've done thank you initiatives twice in 2 different waves. And then most recently in November, launched micro fulfillment, which is our central fill, to take some of the prescription volume out of the stores. So we've really, done a lot of things, I think, consistently across the chain, but also tried to be very, very specific in each location to try to help support each stores locally as they need it. And so, I think despite all of that planning and all of those things that, we had been putting in place, I think what we really started to see as we came through the summer and into the fall, we have seen a very large number of employees with illness due to both phases of the variant surge. So first it was Delta during July and August, followed by Omicron in December and January. And to give you some perspective, this most recent surge in, the winter, so December, January, has been by far the most challenging for us across the entire country, including Arkansas. We've had more employees sick the first 2 weeks of January than we saw the entire month of December. And that even carries over for the month before. So if you look back into December, we had more employees sick the first 2 weeks of December than the whole month of November. So it's really been this exponential growth in the number of cases and employees that have been sick. And you can definitely see and feel the impact of us, needing to make sure those folks weren't coming to work sick. And so I think that's where you probably I know you saw the most number of stores that were impacted by that. I think if we look at it during that time frame, In some cases, we already had our stores operating at reduced hours. And then when we had an illness, in this location, especially if it was a pharmacist, sometimes we were unable to open the store if they called us, after hours and weren't able to get there the next morning, or we had to close early because they were sick during the morning and couldn't report for their evening shift, or they started not feeling well while they were at work. And so I realized, this created incredible challenges for our patients, and our inability, to be able to provide access to medications when we unexpectedly closed. I think compounding that problem for us as an organization is that, up until 2020, Walgreens didn't close stores. We had no really good way to contact patients unexpectedly to let them know that we were closing. And so, since the pandemic had started, we do have a developed playbook, on what we are doing to address that. The biggest thing that I think is going to make an impact for us is our electronic system, right? So we have a system, that records hours of operations, and it links directly to all of our digital assets. So whether that be Walgreens.com, the mobile app, Google search, et cetera. Right now, it's only set up to sweep every 24 hours. So if you have an unexpected closure, you can understand that it would be really difficult for us to get that updated and let the patients know. Our Security Operations Center is really working on that, because we realized across the country, this has been a pain point for our patients, and they've developed a major system update that would enable us to update this in as little as 30 minutes. So really something that would be more real time, where we would be able to notify patients right away. That launch date is looking like it's going to be in April. They're working to try to get that a little bit sooner, but we're feeling pretty confident about the April date. And, I do know the stores locally in the interim. And one of the things that's in our playbook that the store teams can do is to make sure that we're notifying patients if they arrive at the store, or they call the front of the store and let them know that the location is closed and where the nearest location is that can take care of them, or even making a phone call to that other store if needed to try to assist in that. So as you can see, there's been a ton going on in retail pharmacy, and I would say the whole region in the country. And Tracy and I have been in constant communication with Brad and Brian. We're notified of every presumed positive or every positive case in every store. Any unexpected store closure we know about. And as you can imagine, this hasn't been a very easy couple of years, but we're working really hard to continue to provide a consistent level of care to our patients and customers and keep safety in mind at the same time. So I'll pause there. It's a lot of information I think I've shared in a short amount of time, but really wanted to open it up to see if anyone had any questions or comments.
Dr. Mack?
Yeah, I had a couple questions. You probably said this in a way, but I just wanted to make sure. Now, if the patient comes to the store, because y'all just have closed in the last few minutes, the actual store didn't close, it's just the pharmacy, I'm thinking. And then, I mean, is there enough communication in the store that they can tell them where the next pharmacy is and they can pull their prescription? Or is that a problem because then insurance has already been billed and it's sitting there? I don't know how all that part would work with Walgreens system.
Sure. Within our systems, the way that it works is if we have a prescription filled at another location, they can pull it over. So all of the pharmacies are connected electronically, right? So they can pull the script over, it backs out the original claim at the first pharmacy so that they can fill it at the second. And then there's a notification.
Communication up front that they realize as the customer's already in the store to send them somewhere?
I would say yes. I mean, we have it definitely is part of the playbook, and we communicate that on a regular basis. And it's something that we do pretty much every day. So if you think about stores, even on the weekends that normally would close at 6 and somebody needs their prescription later and they go to a 24-hour store, that's the regular process for pulling it over and being able to take care of them after hours on any day, really.
And do you think that new thing you're going to do that'll take 30 minutes, but it'll start in April? Will it just tell them another pharmacy's address, or just tell them their pharmacy's closed?
Well, the sweep that is going to be happening would update the phones, all of e-commerce and everything else. So the phones would let them know that this location is currently closed, and it would allow them to ask where the nearest location is, or be able to direct them to Walgreens.com or the app to be able to see which one is open nearby.
Thank you.
Mm-hmm. This is Nicole Culver. Real quick, Debbie, I want to let you know too that Google Maps, so if they were to put in that they wanted to go to a Walgreens, when we have that enhancement, Google Maps will say this location is going to be closed when you arrive. Like, it'll even have that. So it'll be integrated with that part of it too. I don't know if you've seen that on Google Maps, but it will also have an alert there. Sorry, Lynn, I just wanted to make sure that was out there too. And obviously we continue to do the signs, you know, everything that we could. I think that the biggest problem we have is, as I've seen this as a past board member in Michigan, is that we were always open. We always had the most 24-hour stores. We always had the widest open. And I'm sure you remember, Debbie, we were open 8 to 10 every day or 24 hours. I think what happened is we started to not be able to be open the convenient hours. And we had plenty of competitors or other pharmacies that were open, you know, 8 to 5, 8 to 6, no Sundays. They closed at noon on Saturdays. And we always found a way to service the patient. And so I guess we're just asking for that same respect. Like, there's a lot of people that aren't open 24/7. And so obviously with 73 locations, we know that can be bothersome from, you know, the perspective or the optics of it, but we're certainly trying to work through it, and certainly not doing it intentionally. Nor did we, you know, come to the board every time somebody couldn't give us a prescription when we were open and they weren't. And so we're really trying to work with you for the solution and what we can do for the citizens of Arkansas.
But I don't think that's what this is about at all.
Me neither.
Okay.
What we get to is, by state law, you have to be open 40 hours a week. And quite frankly, we have stores that have not been open 40 hours a week, and we've worked through that with you guys. But we also have the secondary issue. If I look today and it tells me that this store is going to be open these hours over the next week, as a patient, I expect that store to be open when I get there. The complaints that we are getting from patients and other pharmacies, the pharmacy isn't complaining that you don't have enough hours as far as, you know, outside your normal advertised hours. It's the patients in their face that got a prescription that is stuck in the system or has been processed or e-prescribed because the physicians also think it's open, and then they pull up and it's closed. And these are patients looking for their medication, so they can't get in touch with their normal pharmacy. And I mean, just putting it flat out there, it is a different stressor when this pharmacy A is closed, but B is so busy they can't answer the phones, and C is so busy they can't pull it, and D you can't get a transfer from. So it's not, the complaint from the board staff isn't the fact that you aren't open as many hours as we think you are. It's, you have advertised hours that you are not open, and at times you have gone well below the statutory requirement for 40 hours a week. And I understand you can say we want grace just like everyone else, but if those pharmacies are open 40 hours a week, we have pharmacies that someone dies, they need to close down for half a day to clean it. There's an ice storm. Like, we don't hold the ice storm against anybody, but that is a far different thing if they are meeting the minimum requirement versus advertising one thing and delivering another. And it gets to the point where I think most of the frustration you hear from, or that we hear from patients and other pharmacies and physician offices and everything else, is how is it legal for them to advertise these hours, and then at the beginning of the day, the hours all change on a nearly daily basis. I mean, I think we've had 1 or 2 stores that were closed for like half the time during a couple of month period. So,
Dr. Lawson, I'm sorry, Dr. Kirtland.
Go ahead.
I was just going to suggest that Dr. Lawson could probably address those issues from what he sees on the ground on a day-to-day basis, and what he's been doing to try to resolve some of that.
Sure, Erica, thank you for that. And board, I appreciate the opportunity to speak with you. This has been a topic of conversation with board staff for many months. I mean, I remember it being sunny outside and wearing short sleeves, and I was talking about this last summer. So it's been something we've worked through many a times, and we have been very receptive to boards' ideas, and thank you for that. They really have been helpful. A few things that we have taken away were specifically changing some of those stores to 40-hour locations. And there was some miscommunication about lunch breaks. I apologize about that. We fixed that immediately when we understood the board stance on that. And then secondly, about informing our patients when they do show up if we have a closure, about ensuring that we have signs posted and directing people to the closest location. Also our front end staff that are at stores when the pharmacy does close. But specifically around the store hours change, before Omicron, which kind of threw a curveball into everything, we were seeing things trending in the right direction because of proactive changes that we've taken with the reduced hours of operation open to the public. That's not where we want to be. Believe me, we want to have adequate staff, and we want to keep our teams healthy so we can be there for the public. We understand that that's not the situation we're in right now, and we want to ensure that we're holding up our end of the bargain to the public to ensure that there's a consistent basis of hours of operation for them. So just as Lynn spoke to last week, we took a really targeted approach when it comes to hours of operation changes to two of our hardest hit areas, which are Central Arkansas and Hot Springs, and making pretty drastic changes so that we would have, if we did have an unexpected pharmacist illness or something going on at one store, where we could potentially move a pharmacist from another location to that store to keep it open. So we've made some drastic changes in hours, and also through that have been really specific about where those changes were made to take into account the social vulnerability index so that we're not disproportionately affecting those in need. So it's a targeted approach. It went live Thursday. We gave a 2-week notice with signs posted throughout our stores and our pharmacies to allow for that additional coverage in those key locations, to allow for emergency coverage in case we had another location done. But this is something that we take very seriously. You can tell by those members of our corporation that are here right now that this is something we take very seriously and are greatly involved in.
Thoughts from any of the
one more
Dr.
question,
Mack?
Dr. Mitchell. So I think you said this, Dr. Lawson, but did y'all, in quite a few areas, let's say around the state, did you go ahead and make reduced hours, which would help the staff being able to, function at the store because there'd be more available instead of having to work late at night? You have more people that can take the day shift. So I just wondered, are y'all being pretty proactive to go ahead and change the hours? Because it seems like I think patients would rather know for sure you're going to be there 9 to 6 versus on a daily basis it changing. So not to say that you can change that everywhere, but I'm just wondering if that's kind of the approach that's been taken.
Yes, ma'am, Dr. Mack, we have. So, and we did this previously. I think that Central Arkansas was somewhat shielded from some of the opportunities that we had in, say, the Fort Smith market, because we did take proactive approaches before we necessarily had so much of an issue here in Central Arkansas. The changes that we made in Fort Smith showed drastic improvement. After we changed those hours of operation, there's been things here and there that have happened, but across the board, drastic improvement out of Fort Smith, specifically because of those changes that were made. Central Arkansas, like I said, I think was shielded, and now it's come to fruition. It's made its way to Central Arkansas, and that's what we're dealing with now. So those proactive approaches we took previously, they helped, but we need to take more drastic approaches now. And that's what we've done. And we aligned to and went live last Thursday.
Board members?
I have a question.
Dr. Jolly?
So I was listening earlier to I think Ms. Stover, and she was talking about exit surveys. So Brad, is this a issue where I understand there's pandemic and there's quarantine situations, but are there also open positions that are unfilled? What's the staffing situation, especially in these locations where they seem to be closing pretty frequently in reviewing the board documents that we've been provided? And then I guess my second question was on the exit surveys, are you guys able to glean anything in terms of hours worked, stress, burnout that may be contributing to some of that?
Sure, Dr. Jolly, I appreciate that question. As Dr. Stover stated earlier, with the exit surveys, yes, that is information that we need, and we are collecting on a corporate level, but we're taking it steps further here at the local level as well. Anytime we do have any type of attrition or resignation from a pharmacist, our district managers and myself do proactively reach out to this team member to gather insight as to what led to this decision, and then also encourage them to complete that exit survey so we can get that corporate data. But from an engagement perspective, before that happens as well, something I am doing personally within Arkansas is I'm holding pharmacist specific engagement calls where they do not have their store manager or district manager on the calls, and they're specifically speaking with me and or Brian to get insight and to create an open environment of communication to where they feel comfortable talking in smaller groups to get some insight as to what some of the issues are that are leading to the staffing situation. Because you're 100% correct, Dr. Jolly. That's what a lot of this boils down to, is that we have had a lot of attrition and have had inability to necessarily fill at the same rate at which they were leaving. And then when you throw COVID and different things going on to that, I don't have the buffer that we used to have to where we could keep stores open because we had somewhat of a buffer of pharmacists. So really getting in with the pharmacists to understand what the barriers are. And I know you guys know it's tough out there right now. I mean, our profession is, I'm so proud of the role that we played in the pandemic and answering that call that our profession received, but it's taken its toll. I think I discussed this with Dr. Kirtley and the rest of the staff last time we had it. You think about flu season and non-COVID times. It's easy to rally your team behind and have that mindset to look, okay, September, October, we know we're going to be doing flu shots consistently, no basis, and you can rally your team behind that because there's ebbs and flows. With COVID, it's constant. There's different guidelines that are changing, different boosters that are coming and third doses. It's nonstop. And then really proud of the role that our company and our team locally here has played with COVID testing, which we know is so needed. But once again, that is adding to a lot of the stressors that we discussed. And so myself, testing specifically has helped my family out. And it's so needed for our community, but we have to find that fine line, like Dr. Stover spoke of really catering each store needs. And so not necessarily a blanket, but digging into each store, seeing their capacity and helping specifically with that store, whether it be throttling down on vaccinations or testing or turning them off for a certain period of time, depending on how they are operationally. Taking that specific approach is helping with engagement. So we are looking to hire. Yes, we need to hire, but we need to keep the staff that we have currently as well. So we are taking active approaches into both sides of that business, but there's no doubt that staffing has been difficult as well.
Thank you.
In some ways, I defer to Dr. McCready because she's lead on all complaints. But you know, we called this in for a conversation, and I think that we've had a staff conversation, but the board staff and the board have given a lot of grace through a lot of struggle throughout COVID to everyone. But this is a different situation than we are dealing with anyone else. Like if we get 10 complaints about pharmacy being closed or patients being unable to get their stuff, I struggle to think if one of them is about somebody other than these stores right now. It's because every time one of them closes, the phones ring, and then the phones ring, and it's patients, it's prescribers, it's other pharmacies with patients in front of them, and everybody's going, what do we do? For me, and like I said, I defer to Dr. McCready on that. For us, the statute says you got to be open 40 hours a week, and that's actually serving customers. And when we have had people in the past, there is an exemption process to be open less than 40 hours a week. Those exemptions have been given in extremely rural areas. I mean, Dr. Krause, Portland, Arkansas, there's nothing anywhere close to it. Bearden, Arkansas, near where I grew up, that there's not another pharmacy for like 17 miles. But, everyone else who's asked that's been in any type of metropolitan area or an area where there's a population supporting multiple pharmacies, the board has basically said, no, either be open 40 hours a week or don't be open at all because of a patient access issue. On this one, some of our advice has been if you can't sufficiently staff a store to keep it open consistently, then you do need to reduce those hours. And it could be Monday through Friday, 9 to 5, 40 hours flat, and that's it. And that can meet the 40 hours. Some people want to do 9 to 4 and then have some hours on Saturday or Sunday, and however that works. But the insane complaints, or the large number of complaints we've gotten, are patients expecting it to be open as advertised, and then the advertising changes or they're unable to get access to their critical meds. Dr. Krause.
Yeah, thank you. So do we have any complaints, to your knowledge, John or Brenda, of any other chains having similar problems in similar locations?
Brenda?
To the best of my knowledge, I'm not getting complaints about other corporations, other independents that are not meeting their hours. I get a lot of complaints. Brad has done a really good job working through those complaints with me. I appreciate that a lot. But no, we're not seeing the complaints about other stores not being open, about prescriptions being in a queue where another pharmacy can't get it, or whether it's already on somebody's insurance. So even if I get a prescription from a doctor because this store's closed, I can't fill it because it's already filled at this corporation on their insurance. So the customer has a choice of not taking their medication or paying out of pocket for something that they shouldn't have to pay out of pocket. I think Brad has worked on some of those through their stores to back that kind of thing out. I think I've contacted him and said, hey, this patient needs this, and he can get a hold of somebody and get them to back it out. But Brad and I aren't the lifeline here to sit here and make phone calls back and forth all day. Brad can't solve this problem. This is above his head. And I think other corporations may have reduced hours. They've met their 40 hours, but they haven't closed their stores. And maybe that answers your question.
No,
Dr.
I think
Stover, I'm sorry. Go ahead.
I'm through.
I didn't mean to interrupt.
Oh, Erica, I couldn't understand what you said.
You locked up on us.
I just said I didn't mean to interrupt Dr. Krause. Sorry.
Dr. G, you have the floor.
Can you not hear me?
We can.
Oh, okay. I was just going to ask Dr. Stover to address what Dr. McCready was discussing about the levers that are being pulled on the corporate level to try to resolve some of these issues, and what changes you've seen since you started implementing some of these, if you could, Dr. Stover.
Yeah, I think I mentioned when I was talking just a little bit ago about the different phases of operating hour changes. So we started that back in August, and Brad and Brian had, really worked through a plan of what to do if and when. So really specifically, that was driven by staffing. So when you ask, have we made operating hour changes to address what's going on? Absolutely. And it's been, one of those situations where we've made adjustments, gone back and looked at it and said, is this doing what we need it to do? Do we need to be more aggressive? And really looking at it from a geographical standpoint of what's going on with staffing in those different areas. So we have done that. I think where you see, the unexpected closures, a lot of that, it's not planned. We don't plan not to have someone to be there. It literally is because something has happened and we have an individual who was scheduled to work and that can't now for whatever reason. And I think what we've learned in the process is similar to what Brad just spoke about, is maybe we need to be a little more aggressive so we have a buffer. He talked about trying to create a buffer in Hot Springs. And I think that the one concern that we've always had is you close a store, it's exactly, I think, Debbie, maybe you mentioned it, is everything gets pushed to another location. So now they're really busy because the volume, it's a lot of volume, a lot of prescriptions being filled. And when you reduce those operating hours, of course, now you're compressing those prescriptions into a shorter amount of time. And so you do see some of that, being more intense in those locations, but it also spills over into the neighboring locations as well. And so God forbid you have two people that are sick in a smaller geography where now you're on, we're pushing scripts around and they don't have maybe the staff that we would like to be operating with. It does make it very challenging. But I do think the proactive approach that we've been trying to take with changing those operating hours, like I said, we've gone through 9 phases of changes, and we're over half of our stores are on reduced operating hours from where we were in June of 2021 at this point because of staffing. So, I think the learning here is, Brad spoke about how do we be more proactive in making some of those changes, which we have done in Central Arkansas to address some of that. But I think it also goes back to how do we make sure some of these system changes are in place so people know about the operating hours ahead of time, which right now it's only sweeping every 24 hours. And I think that change that we have coming in place will help with some of that. But also just making sure our store teams are aware if we do have a patient that comes in, because ideally they would be calling the store so that they're not calling, Brenda to complain. They would be coming to us so that we could take care of them. That's what we're here for. And we never want to create a situation where someone can't get their medication. I mean, that is not ideal for anyone. Because we've all been on the other side of that as well when we've got something filled at a location that we can't fill because it's already processed on their insurance. There's not a ton that you can do for that individual other than if it's not a controlled medication, giving them a few to get through until we can get a hold of that pharmacy the next day to get it backed out. So we've dealt with that on the other end as well, and it's not ideal situation. So we would never want to be creating that situation for anyone else.
Yeah, and really just to, I would say, to piggyback on what Dr. Stover is mentioning, is from a customer complaint or customer concern standpoint, I would say myself, my 5 district managers are really hands-on as well in regards to addressing a lot of the concerns that our patients do have, either in regards to not being able to get their prescription or wait time. We've had several scenarios where the district managers or myself are working in these locations where we know we are short-staffed to be able to direct the patients to their needs, but also to be able to pull any type of tasks that our pharmacists or our pharmacy technicians would normally do, that they can better support the patients that are in front of them. So I would definitely say it's been a full team effort We definitely get our fair share of direct calls here at the area office that between myself and Brad still, I feel, do a really good job of being able to address in the moment. So we definitely hear them too, but we definitely appreciate you all bringing it to our attention to be able to address a lot of those concerns in the future.
Dr. Mitchell.
Yes, ma'am.
So I think we all are very understanding and understand the pandemic, and we understand this is a nightmare for you, you know, on the staffing and everything. So I think we're very understanding there. I think Brad hit on one thing that I don't know if they're going to tell him the truth, but I think it's talking to the pharmacists you have right now at some level that where they feel secure and like they can speak up, because though you don't want to lose anymore, obviously. And once they're gone, you do get a little bit of information, but it's probably just that they were overworked. So I just wonder if there's really some good key ways to get the individuals working there right now, whether it be an area or, you know, a larger area, just to really find out what are they struggling with. They're struggling because they're overstaffed and they're busy. I get that, but what are their ideas? What can be done differently? How can you help them? Because the pandemic isn't going to end tomorrow. And, you know, we may have another surge, heavens, hope not, but we may have something else that comes up with this. So, I mean, something other than just, I'm too busy and I don't have enough staff. What does a pharmacist need? Do they feel like they can speak up? Because I know how pharmacists are, and they're just going to tell you what you want to hear because, you know, truthfully, they want to stay employed right now. But what can we do to really help them?
So I'll actually start.
I see you, Dr. Cross.
With that one. During my store visits, so I'm usually normally in stores Tuesday, Wednesday, Thursday, sometimes on Fridays and Saturdays, either by myself or working directly with the DMs. And I can attest to say that on every store visit, we are speaking directly with the pharmacist and the pharmacy team to gather information on their pain points. How was the week? What are some things we can do differently? What are some things we need to push up that maybe we don't see at a local level that we can push to Dr. Stover and the company to be able to give us some buffer? I can tell you that central field micro-fulfillment was one of those ideas that they felt like they needed someone to be able to fill some prescriptions for them so they could take care of the testing and the immunizations. And then on top of that, the feedback of, hey, can we get some third party to come in and just do vaccines for us so we can just focus on the patient? So those ideas were coming directly from the technicians and the pharmacy. And I can tell you on every visit that is something I am soliciting in the stores as to what can we do differently during this difficult time, not only to retain our current team members, but how do we be more efficient and compliant because we truly care about our patients. So the DMs, district managers, myself, even my HR department, all of us are in stores trying to get feedback on a consistent basis to be able to maneuver as quickly as we can. And even with some of the operating hour changes, that just them being able to know they have some flexibility has brought some higher engagement, which I feel is moving in the right direction.
Another thing to bring up real quick. So another initiative that we have created is we have a process called dynamic workload balancing, where we can help with digital input and digital verification of prescriptions throughout the state. We've identified locations where we may not be having as much of a staffing issue as other locations, to where we have an isolated terminal where we will have a pharmacist that will go there for a shift and support some of these operational opportunity locations throughout the state, specifically during that shift. And I'll flip that back on and off for that specific time. So trying to provide support where we can, whether it be at another location within the state or that location itself.
Well, I'm talking on mute again. Dr. Krause, you have been as patient as Job. You have the floor.
I just think that, you know, I have empathy for their plight. I hope that they can get it figured out. But in the meantime, you know, put your hours on the door and be open for the hours that you say you are and move on. I mean, y'all have got plenty of resources and you know, work with what you got and don't try to be more than you are. And, you know, if you're not going to be open those hours, close. You know, it's simple. Everything else is just dancing.
I think I want to say what I've been thinking as I'm hearing is that, you know, I understand Omicron kind of caught everybody a little bit by surprise. So, you know, fool me once, shame on you, but fool me twice, shame on me, right? So we need to be better prepared so that we aren't having this discussion again, to kind of echo Dr. Mack's point. So. Anybody else?
One more thing, can the third party do the testing as well? So the pharmacists aren't having to fill prescriptions and do the testing and the immunizations? I know they're doing the vaccines, but, and I don't know how widespread that is, but would that, you know, could you have more of this third party group doing a lot more vaccines and a lot more testing?
I would say the testing actually is being facilitated by the technicians. So it's not a pharmacist responsibility. So that's been something, obviously the pharmacist is overseeing it, but some of it's PCR, some of it is rapid testing that's going on depending, but it's actually happening within the pharmacies and within the store. So at this point, the option that Brad spoke about of pulling the appointments back or turning it off altogether is kind of the decision that we've made to do versus bringing in a third party.
I think when we have pharmacists telling us about hundreds of prescriptions in the queue, you know, our staff suggestion is if you can't take care of the primary business of the pharmacy and supplying those medications to the patients, then you shouldn't have extraneous services added on top of it, because the pharmacists can't do it all. And the limited number of pharmacists that are, you know, telling us that they are understaffed, and I don't mean just technicians, like a lot of them are telling us, and they don't want to put it in writing and they don't want to put it on the record because they're fearful for their jobs. You know, I need another pharmacist. Like, I can't say grace all over all this, especially when you add in all the shots and, you know, the testing and, you know, flu clinic and everything else. It's just more than they can handle. And it's pulling them away from, you know, the primary responsibility that many of them feel that they have, which is getting that medication to the patients that already have that known need. Then, I mean, we've got pharmacies that, you know, they just tell people, like, we can't take on another patient at this point. We can't, a lot of times it's around controlled substance issues. They don't even have the bandwidth to have more controlled substances for patients with those needs. They're like, I'm sorry, I'm so covered up right now, I just can't take you on right now. Doctors' offices are doing it.
It might be worth considering hiring an independent third party to survey your current workforce to get some of that feedback that you want. Because like several of us have said, I don't know that they're going to be super honest, because they would like to stay in, you know, they want to stay employed. That's an understandable kind of conflict of interest, or at least it's a difficult situation to be in. Mr. Stallworth, Dr. Stallworth.
Yeah, so I mean, great point around the third party to be able to help us identify some of our opportunities or feedback from the pharmacists. We do have two specifically surveys that a third party does conduct for us, Glint survey and an always on survey, which is pretty much all the time. And the information that Dr. Lawson was speaking of earlier in regards to having those engagement calls is really pulling a lot of that information that they're able to do anonymously with anyone knowing who's made those responses, and us being able to bring that to those calls with the pharmacists to be able to work through specific geographic or district related topics. So definitely something we will continue to focus on, because we do believe that you're right. They won't always give us the 100% honest truth, which is why we rely on the survey to be able to give us some direction on which way we need to address some of the concerns.
If you said that earlier, I'm sorry I missed that part. So
no, I didn't.
Dr. Kirtley, I would just want to add that, Brad and Brian have listened to their teams, and when we've talked about really that core of our business and filling prescriptions for our patients, and then any additional tasks, just being able to listen to the team and see what's happening in the stores, and when we need to be able to dial back that testing and dial back the vaccinations. And I think, a lot of our team has spoke up that the ability of the technicians to help with both of those items has been a way to relieve some of the stress for our pharmacists so that they can take care of other needs of the patient while they're overseeing the technicians doing that. So just being able to adjust each store as needed based on the current situation they're in has provided some flexibility and helped with engagement as well.
And one last point to Dr. Curley's point about the operational concerns with hundreds of prescriptions. Believe me, guys, that breaks my heart. As a community pharmacist, when I see a team in that shape, there's a visceral effect to me. In those instances, we act immediately. If we're on a store walk, Brian, myself, or the district managers, that store walk goes out the window and support goes directly into that pharmacy where we are. We try to identify areas where we can support. We will bring in overnight pharmacy teams that will work when we are not open to the public. We may change operational hours to the public, but then actually be there working in order to stay up if we see this as a continuous basis. So once again, it's that individualized approach to each store to try to support where we can for those issues.
I have a follow-up to Brian's comment about the surveys and things that you're doing. My understanding is in order to access those surveys, they have to put in a ID number, a work number, which identifies the pharmacist. Is that something that can be changed where the pharmacist is assured that that information is not being stored anywhere?
So Brenda, I think I can address that. So it's an external company that requires them to gain access to the system, but we just get the outputs from the survey itself. So we don't, it's not a Walgreens survey, it's through Glint, which is the company that does that. But that's the only, I think it's the only way for us to match it back to a bigger roll up. So I know, like if I'm looking at it as a region leader, I know it's coming out of Brian's area versus maybe Kansas or Iowa. If I'm looking specifically to address whatever the concern is, it helps me at least, it doesn't go down below a certain level so that we protect that identity piece that you're talking about, but we don't have access to know who said what. We can't get access to that.
So do you have access to know the percentage of pharmacists that are actually filling out those surveys? Because my understanding is they don't fill them out because they're concerned about anonymity.
For the store level, we can see direct roll-ups or direct reports. And we can't see anything below that, because then if you only have 2 pharmacists in a store, you want to protect that. So we would not have access to be able to see it was 1 pharmacist in this one store, because then it's not anonymous anymore.
And I'm speaking of an overall number of, you know how many pharmacists you have working for Walgreens in an area? I'm speaking of an overall number.
Yes, we do. We can see pharmacists and we can see pharmacy managers.
And do you know what percent that is?
I don't off the top of my head.
Thank you.
I know pharmacists are very cautious and they know that they put a number in, whether you can go back and say, we don't go to a certain level. That doesn't make pharmacists trusted any better. I would just, somehow y'all really need to get someone that can speak to the people working, and Brad might be too high up for that. Maybe they don't want to be honest with him, and maybe they are, Brad, but you know, it may be somebody that they feel like and can see changes being made, so they know they were listened to. I know you don't want to start some giant gripe session either, but it just seems like everything sounds beautiful from the top, but sometimes if you're in that trench, it feels different.
That was a really good segue, Dr. Mack.
Go ahead.
Because I'm sure could beleaguer this most of the afternoon. From the board members, do you have any other specific questions? Is there anything you would like to specifically ask they would do? I don't see that we really need to have a vote on anything, but if I am wrong, let me know what you're thinking. Otherwise, I think we should probably try to wrap this one up.
I have one last question, if I may, to board staff, if anyone can answer this. Have anybody on staff experienced anything like this in the past? And if so, what were the courses of the board? And if that's something y'all want to talk about later, that's fine too. Just wondered if there's any untapped information out there.
I've been here 17 years. I've never seen sporadic closures like this for any length of time in my years. I understand COVID is different, but the situation we were dealing with specifically with Walgreens is different than the situation we're having with anyone else, to my knowledge, at this time, because it's not just whether or not we know the store might close here or there, but it's consistent or at random. We have patients that are concerned that they don't know if they don't go get their prescription right now, if they're going to be able to tomorrow, or when they show up tomorrow because they've had something happen with their prescription, the pharmacy's closed again. I've never dealt with it like this, which is why we've had a staff meeting with them and have brought them before you guys to discuss for guidance.
And is there any inconsistency that you can see, John, or Brenda for that matter, as far as if things like this continuing to occur with this company, us limiting the hours that they're open, board mandated?
I would not be surprised if you guys instruct staff that if this continues to file charges, and due to whatever hearing, the board will get to determine whatever action that is.
But it can't continue, that's for sure. I'm sorry. Go ahead, Lenore.
No, I was just going to say, I've been here for 30 years and I've never seen anything like this before.
I mean, Lenore, you and I have seen a time where a pharmacy closed for 2 days and we got a couple of calls and we find out literally like somebody died or like fell off a horse and broke their neck, and then was in the process of finding relief staff. But it was like a tragic individual event at that store, and then it was covered. But I've never seen or heard of anything like what we're dealing with now.
No.
I would just ask, and I don't know what my fellow board members think, but I would just ask that staff maybe have an emergency, phone meeting or whatever, or let us know if something like this occurs again.
Yep.
Dr. Mitchell, one last thing. And I mean, hearing all of that, Walgreens might rethink, rather than kind of waiting and seeing when somebody's going to have the emergency, then doing the hours, maybe they would be better served just for now, for the state of Arkansas, to have less hours and cover everything and try to get through this smooth thing with their patients and the board. And then, later when it's over, it just may be better to be very aggressive on the front side.
I've been listening to all the comments, and there's, from an academic standpoint, I don't know, what we have to offer other than graduates. But I mean, this has been going on for a little while. Have you made a concerted effort to come speak to the colleges? Perhaps come have some student recruitment on campus here? See if you can't retain some of the graduates?
Yes, our graduates are each year a very valuable asset to our profession, and this year is exponentially higher. So we did have the career fair last Monday. I have had a concerted effort to recruit specifically for our graduating P4s, but also for our interns, and more of a long-term recruiting effect for P1 through 3. As opposed to speaking at the school itself. I would love to, Dr. Richmond, if you could help me with that, that'd be great. I've run into a lot of dead ends due to COVID over the past year and a half with that. So I would love that opportunity.
Well, and I guess I was asking if there was something specific that you've done that is different from the norm. I recognize that you certainly rely on new graduates to recruit and retain your interns and whatnot. So, I mean, if there would be a genuine interest to come, and not just our school, but obviously UAMS as well, I'd be happy on our end to try and facilitate something with you.
That'd be outstanding.
Dr. Krause?
I just want to reiterate that if, I'm not prepared to do anything right now today, Walgreens, but I think that if they experience this again, at least on my part, I would be willing to mandate their hours.
Dr. Kirtley, Dr. McCurdy, this is Nicole Cover. Again, appreciate the time today. Like it just helps us to all come to the table with finding solutions. I just had 2 quick scenarios that I just for clarification. And it was me, John, sorry, Dr. Kirtley, that did the 40 hours but forgot the lunch break. So I did not realize that was, not a working, serving the patients. But if we're at 40 hours in a location and we have, like, say, COVID takes out the whole staff, or, is there a suggestion of what to do? Like, because obviously that's, like, I'm talking entire staff, not just one person, or is that just the same, which is totally fine. I just want to make sure. That would be my first question. My second question is in the stores that we are down to that 40-hour minimum, and we start to have maybe some challenges or issues, and it is in an outlying area or an area that we know is maybe, underserved, do you recommend that we come to you and say, okay, we can be open all day, every day, but it's got to be 32 hours or it's got to be 31 and a half hours, or is that not an option? Just so that we kind of understand.
I'm personally not aware of any Walgreens stores in the type of underserved areas that we have had reduced hours approved in the past.
Okay.
I mean, the examples I can think of, Portland and Dermott, which are actually 2 stores that, later on, Dr. Krause is actually involved in. But how far is it to the nearest store from Portland, Lynn? It's on the Louisiana side of the border.
What kind of store?
Pharmacy. I mean, well, in truth, it's 10 miles to the next gas station from there. So
yeah,
I'm talking,
you're talking 17 to 20 miles.
Yeah,
Okay.
Walgreens doesn't have stores in the type of communities that exemption is really designed for. If there's a Walgreens store in a town that does not have another pharmacy, I think that is a viable issue. But
Sure.
there, you don't have stores in Smackover, Arkansas,
Right,
or in
right.
Beard, Arkansas, or in, these little bitty communities.
Nope,
So I
totally
don't know that
understand.
that's one, but it's one of those. The exception would be when COVID wipes out a whole group, but a lot of the closures we're seeing is not everyone is ill; it's insufficient staffing.
Oh, absolutely. And that's what I'm saying. Like, we're certainly going to be like, hey, this is staffing, but we do have a store that literally everybody, and would that be taken into consideration, or do we just wait and the board says, okay, we had another situation, and we don't need to address that here today, but we'll do better as far as documenting what those reasons are, just so that we understand if we have to come back. Because you're right, at the end of the day, and we've said this since the beginning, whatever the hours are on the front of the door is what we need to do. And I think that, we have to stick to that, or we have to work for a better solution. Absolutely.
And if you look at other major corporations, they're closing stores. You may just not have sufficient staff to operate the 70 whatever stores. You may have sufficient staff to fully staff and be open 40 hours a week for 60 stores, and that's a business decision you guys have to come to. But we make, this isn't an independent or chain issue. If an independent
we don't think
be
that.
open 40 hours a week, they got to be open 40 hours a week, not 36. If they say they're going to be open 60 hours a week, they need to be open the 60 or reduce back down from
40.
that.
Okay.
But
nope, that makes sense.
The tough part.
Absolutely.
Anything else, board members, I think?
Okay, Luke, do we need to vote on the action that Dr. Kraus and Dr. Mack discussed, or is that in the minutes and that's good enough?
It's in the minutes and it's good enough. Since the board's not taking any action today, it's just kind of a wait and see that this is corrected. There's no need to take any vote or anything. I think I think the board's been more than obvious about what it wants out of this situation. And if there's any questions from Ms. G or any Walgreens, well, I'll be glad to answer them later, unless there's any that y'all have right now. But if not, then I would just ask to recess until 1 o'clock, and we do have a discussion set for 1 with a lot of people coming on. So that's about 40 minutes. Is that enough time for everybody?
Yes, sir, it should be.
All right.
Ms. G, Dr. Lawson, everybody, Dr. Cover, thank all y'all for being here today.
Thank you. Thank
you,
you.
guys.
Have a good day.
Board members, will see you again shortly.
1 o'clock, is that what we just decided?
Yes. Hey, Luke, are you on?
Yes.
I just dumped or dropped a FDA PowerPoint on this issue that I thought was already in there, dealing with the FDA guidance on future compounding. I don't know, is the Dropbox linked directly to our folder, or do you have to put in a different one for
I
that?
just put it in there. Which one is it? That webinar slides?
Yep.
All right, I'll send it out.
Okay. And I can actually send it as a link. That may be easier.
Yeah, that probably will be easier if you just want to email it to them as a link.
I'll do that.
And board members, before we get started, there are some. You'll have a packet of information under vet compounding discussion, and there's several things in there. A comparison chart, which was put together by the American Veterinary Medicine Association. You've got a letter from Oklahoma. You've got a couple of items there. Just a couple of pages from about ProLab Pharmacy. And then you've got one that says Q&B's comments. That's Quarles and Brady. Roger Morris is on the discussion today, but this is a letter from Quarles and Brady on some of their clients that they represent. So if you'll just kind of look through some of that information, the discussion is about compounding for office stock, compounding for office use. So if you just kind of look through the Quarles and Brady letter, the comparison chart, the AVMA documents, and also, like I said, John sending out that compounding webinar slides.
And Rodney, I forwarded that to you for your veterinarians too. Those two links. It's available direct on the FDA website. It's dealing with the more current guidance that they have in draft.
Thank you.
Absolutely.
I got it.
And I meant Rodney Baker and Rodney Richmond.
Oh.
You guys would love last week, like with ACPE, there's like 6 people that 2 people have the same first name with some of the meetings that we have. So it gets fascinating real quick. I was like 2 Johns, 2 Mikes, 2 Cindy's, and there's something else, but it was, you have to revert back to college and go by last names, and you have a common first name.
So Luke, on some of them, it's like Arkansas Board Veterinary Compounding Discussion. And then when you open it, I don't get anything, but is it, am I supposed to see something or hear something?
Me neither, Danny.
Check our
The same thing happened on one individual that we're talking to at 3. When I opened it, it starts off, it wants to save it, and I didn't really want to save it to the Dropbox because I don't want to have it.
No.
Yeah, the PDFs should open.
They open.
Yeah, don't worry about the other Q&B is just an email with that questionnaire. Let me see what this other one is.
That's what it is.
You can download it. It's not asking you to save it. It's just, it should just ask you to download it.
If they're not on the same type of Outlook as us, those that were just an email copy instead of reduced to PDF won't pull up right.
And actually, that other one is just an email that just says when the meeting is. So yeah, just the PDFs, if you can open those. The other two are really just more technical stuff with dates.
Yeah, I can open all the PDFs, just not those other things.
And I see Mr. Baker and Dr. Jenkins again. Are y'all expecting anybody else from your end?
Possibly Dr. Brett.
Dr. Brett, okay. And
see,
grandbabies,
so she may not be on.
I'm sorry, I didn't mean to interrupt you.
That's right. Dr. Brett has a new grandbaby, and born the last few days. So I'm not sure.
She told us she might not be available.
I know.
And Mr. O'Quinn, are all of your people present?
Yes,
Darren,
yes. I see Mr. Teague down at the bottom there.
Okay. Roger, I see you're on there. Do you have you or your clients or anybody else who's going to log in? Are y'all all here?
Just me. The others are probably watching on YouTube.
Perfect. Thank you. John, if y'all
Luke,
want
I'll just note for the record that we have the same board members that we had present this morning.
Okay. So, and for the record, that is 7 out of the 8. The only one missing is Miss Amy 4. So, John, if you're ready, I believe everybody is on here that was going to be here that I've heard from anyway.
I think so. So I think Luke will probably cover whatever I miss in this. As some of the board members have seen through like informal conferences and other things, we have a couple of different issues here that all kind of surround the same issue of veterinary compounding and specifically veterinary office stock compounding. To give a quick overview from the board staff side, just so that I think everybody kind of understands where we are. The Arkansas Board of Pharmacy was the second board of pharmacy in the nation to actually allow pharmacies to do office stock compounding. I think we were second to Oklahoma. That was somewhere around, I want to say 2003. We did update some rules to clarify that that could even be done for veterinary products. Back around, I have to look. I know, Roger, you've got that in your letter. I think 2008 is when we started that process. And then later on, when we saw the incredible fiasco of NECC and watched the FDA with some actions even here in our home state, and then the introduction of 503B facilities, we had previously allowed office stock compounding for retail pharmacy permits that would also have a wholesale distributor permit. When 503B came around, it really changed the face of that nationwide from the way FDA educated most of the boards of pharmacy, at least, that you had to have a 503B permit to do office stock compounding. We changed our permit structure so that instead of simply having a wholesale distributor permit, we had a subtype we invented for 503B outsourcing facilities. That was somewhat difficult in the fact that some states still want to see a wholesaler permit, some states wanted a pharmacy permit, some states wanted to see an outsourcer permit. And so we tried to make a two-pronged catch-all that would meet whatever criteria would branch from state to state. Because if the facilities that were here, they could be one state over and they wanted to see a pharmacy permit, well, they could have that. And with us having that wholesale distributor / outsourcer permit, it allowed outsourcing. When most of that happened with FDA, our board was fairly clear to everybody, or we thought they were from the staff side in discussions, that you could do office stock compounding if you had a 503B permit, but it was kind of only if you had a 503B permit, and on inspection through educational efforts and outreach, that was pretty much what happened in Arkansas. More recently, we have run into some situations where I think there's been confusion on what could or could not be done with animal office use compounding, arguments that 503A, 503B don't apply to veterinary compounding. We've got examples of the FDA's response to an Oklahoma letter of what does and doesn't apply. And I think more confusingly, as of recent, is the FDA's proposed draft guidance that's been out for a little bit, discussing how non-sterile office stock veterinary compounding could potentially be done if that draft draft guidance is approved. Another complicating matter in all this is AMDUCA, Animal Medical Drug Use Clarification Act, where FDA has a very narrow stance of thought that you could only take commercial products to compound for animals. And so there's been a lot of argument over the years whether that applied to food producing or non-food producing companion animals or not, but AMDUCA gets thrown around in the periphery as well. Luke, is that a halfway decent overview?
Yes, and just for the record, we do now have Ms. Four, so we have all 8 board members are currently present. Yeah, this all kind of started with, and they're here with ProLab Pharmacy, they're represented by Mr. Quinn. This kind of all came to the board's attention when they ended up, they bought a book of business and we're doing some compounding, which appear to be for office stock. So that's kind of how this all got brought up. And then it got Mr. Baker and some of his clients got interested in it and the discussion, and also Mr. Morris and some of his clients. So I guess, if it's okay with the board, I guess we can just start with Mr. Baker and Dr. Jenkins. If y'all just kind of want to go through, we met before, with staff. And so if y'all just kind of want to go through what the issues you see and I'll just kind of let you take it from there. Like I said, we do have several people that want to speak, and this is 72 hours. So we just kind of ask you to.
I'll assist with introductions, and so the board members kind of know who we're talking to. So Rodney Baker is actually a professional lobbyist and helps represent the Veterinary Medical Association here in Arkansas, as I recall, and Rodney will correct me. And Dr. Jenkins is a veterinarian here in Arkansas. And I think a lot of what they've tried to express to us is there hasn't necessarily been a good line of communication helping veterinarians know what they can and cannot do. And Dr. Jenkins especially can speak to, here are some of the specific needs that veterinarians see that we may not as a board be aware of. And the FDA is a whole nother issue on that, but helping express, what their needs may be for emergency use medications to have office stock for treating. So Rodney and Dr. Jenkins, I hope I did not butcher that, but thank you guys for being with us. I'm gonna kick it over to you.
Oh, you did fine, and we're pleased to be here today. I appreciate the opportunity to address some of this. I think it's just like Mr. Kirtley said, we just kind of found out about this and looked into it a little more, a little concerned that we know what we can do legally, veterinarians can do, and what is available to them, what services are available to them appropriately. And I'm not the expert in what's going on. That would be Dr. Jenkins. Dr. Jenkins is a veterinarian, Bologna. He is the past president of the Arkansas Veterinary Medical Association and now heads the Government Affairs Committee for Veterinary Medicine Association. Dr. Jenkins,
okay. Well, thank you, everybody, for allowing me to be here today. And also for the opportunity we'd had a few weeks ago to spend with some of the executive members as well. I am coming to you today on behalf of the Arkansas Veterinary Medical Association. To kind of give you an idea, we're about 600 members strong with our veterinarians across the state. Obviously, we have some members that practice out of state, but still members with us. Few points I want to make and would like for y'all to hear. Number one, I want you to realize that as the Arkansas VMA and the veterinarians in our group, we have absolutely no financial gain in a rule change, but rather our goal is an improvement in our overall unique patient care. We, as you can imagine, treat a variety of patients from the standpoint of size, species, and physiological differences. We treat anything from less than a 1 pound kitten or puppy to birds or reptiles that may weigh less than a gram. And then there's also situations, not only vary in size, that we may have a litter situation a large litter of animals that we've got to try to, do some compounding of medications on. Currently, we're limited to only being able to prescribe compounded medications for a particular patient rather than dispensing it. We have some limitations on practicing after hours and on weekends when compounding pharmacies are not even open. And especially, in emergent situations, that can be another challenge with that. There can be a delay in getting medications ordered and actually getting them received. We, especially over the last few years, we've seen that be worse. As you can imagine, COVID has really made that more challenging on receiving medications as well, and have seen a lot of things going back order because of it. We also are challenged with treating some things that are zoonotic, just to mention a few: Giardia, toxoplasmosis, and some fungal infections. There's also some transdermal medications that we could stock that would be really helpful from the standpoint of the aggressive cats and dogs that we periodically see. That could be something we could dispense to owners to apply at home and ease their transportation to the clinic and then examination of them in our practices. Obviously, that's going to help with safety on our behalf and then the owners and our staff. So, with that, the Arkansas VMA would ask the pharmacy board to please consider changing the rule sooner rather than later, if possible, in Arkansas, so that as veterinary clinics, we can stock compounded medications that can be dispensed by our doctors directly to our patients to start a course of therapy. And we were considering up to, but not exceeding 5 days. We were considering in that it would help us cover a 4-day weekend or maybe a holiday that fell on a weekend. And at that point, the specific prescription can be filled by a compounding pharmacy that's approved in the state of Arkansas. And I want to highlight what I think Luke and John both said is this has been confusing. I mean, just over the course of the last few months, I have learned a lot about it. And we want our veterinarians in Arkansas to be compliant and to be doing the right thing. And I once again, I appreciate your time. I appreciate the opportunity of getting to visit with you before. I even would look forward if we had some more opportunities working together with the VMA and the pharmacy board. I think we'll all be better. And with that, I'm open to any questions. I'll be happy to give you more specific drugs if that would help you or situations at all. But thank you again.
And I think, Dr. Jenkins, as we go through this, I'm sure the board will come back around to you and want to know like kind of what some of those specific needs are. And just for the board members, I advised Dr. Jenkins, I said, it's a whole lot easier to look at some specifics for specific considerations than it is to say a big nebulous global topic of what you think you need. So I appreciate him being here with us today and doing that.
Yeah.
Luke, go ahead.
Yeah, I was just going to say, just kind of keep me posted on being here. I've got some appointments this afternoon, but I can move things around. So whatever you need.
Well, if you need to get off screen, we absolutely understand. We have to do that as well sometimes.
Okay. Thank you, though, everyone.
Luke, who'd you have up next?
Yeah, Mr. Morris. This is Roger Morris. He's with Qualls and Brady. And Roger, you work out of Phoenix, is that correct? Out of the Phoenix office?
Correct.
Out of the Phoenix office, we deal with or talk with Qualls and Brady and Mr. Morris quite a bit. He is the lead of their healthcare department over there. So anyway, he penned a letter that I have provided the members. So Mr. Morris, if you just kind of walk, and this is some of his clients He represents a lot of people in the healthcare industry. So, Mr. Morris, if you just kind of want to walk through your letter and the concerns or issues or whatever that you have and that your clients brought up today.
Sure. Thank you, Ms. Daniel. Thank you, members of the board. My name is Roger Morris. I'm a pharmacist and an attorney. I teach pharmacy law at two of the universities, Midwestern University and University of Arizona, and I teach an FDA law class at the law school at Arizona State. My firm and I represent several thousand pharmacies around the country, a number of them who are involved in the veterinary space to deal with it. I wanted to put out there a couple of pieces of information we tried to highlight in the letter because it's a decent amount of legalese that's there. But I wanted to start with veterinary compounding is different than human compounding. It is governed by different sets of laws under the federal law for the FDA, and it's found in different sections with it. As long as I have been in pharmacy, and I grew up in it, my father and my grandfather were both pharmacists, there has been a debate what's manufacturing and what's compounding from the FDA perspective, and there have literally been 70 years of lawsuits and cases between the FDA and the pharmacy industry over whether something is compounding or manufacturing. There are a number of laws that have been passed based on that, dealing for almost all with human compounding. There's a little bit that deals with veterinary compounding, but I want to make sure I understand anything you think you know about compounding, you probably believe it to be about human compounding. Veterinary compounding is different. It's a different set of federal laws that deal with it. So that's the first comment that's there. The second is a number of references have been made already by Mr. Daniel and I think by Dr. Kirtley about FDA guidance. I just want to make sure we're clear. FDA guidance is nice information. It is sometimes useful information, but it is not law. It is not a statute. It is not a regulation. It does not have the force of law. It's an idea that the FDA has that it puts out there. And sometimes it turns into law in the future, but guidance by itself is not law. So there's a decent amount of FDA guidance out there about human compounding. There's even some draft FDA guidance out there right now about veterinary compounding. And the draft FDA guidance, which I'd love to rely on, but it's not law to be able to do it, actually allows office use veterinary compounding, allows pharmacies in the draft guidance to be able to do that. But again, that's not law. What do we have as law that exists right now? You have the Arkansas law. You have the statutes and the regulations. And the Arkansas statutes and regulations, as updated, as indicated by Dr. Kirtley in 2003 and then ultimately in 2010, specifically allow for veterinary office use compounding by a pharmacy. It does not have a 5% limit. It specifically allows it, recognizing the need for those kind of products to be in there, as Dr. Jenkins mentioned when he walked through his examples, that there are lots of reasons why you want to have office stock in place to be able to do it. In fact, this board, and it's in my letter that you can see it, actually issued some guidance that went after the 2010 changes that went into place, and you put out in your newsletter in December 2010, when you said that office use compounding was allowed, that this will allow pharmacies to prepare customized medications to be administered by veterinarians in their practice, which will get veterinarians additional choices to best treat animals. That's from the December 2010 Arkansas Board of Pharmacy newsletter. Nothing has changed legally since then. We had a horrible situation in the human compounding space with the New England Compounding Center that occurred in 2012. And as a result of that, 503B outsourcing facilities were created by the federal government, by the FDA. 503B outsourcing facilities specifically state they're for sterile products and do not apply to veterinary products. So while the concept of 503B to make office use compounds sounds nice, it doesn't apply technically under the federal law to veterinary products that are there. So we have an Arkansas law in place that allows this to occur. We have some federal communications that may be a question, may not, but aren't law as we sit here. And so what my clients are urging at the request of veterinarians like Dr. Jenkins, and I don't know Dr. Jenkins, but I heard what he had to say, is to let them have stock in their office to be able to treat animals who are needed urgently. Currently, 37 other states allow veterinary office use compounding for non-patient specific in some form or another, whether it's to dispense or to administer in the office. And you have the laws on the books to allow it. I just want to make sure that you actually go forward and deal with it. I'll hang on and I'm happy to answer any questions, and I look forward to the discussion. Thank you.
I'd love to hear your take on Amduca and how it continues to apply or does not, since it's been around since '94.
But Amduca is a fascinating law, and I think there's a lot of things that need to be clarified on it, Dr. Kirtley, as to what it does or doesn't do. But since it's been around since '94, and you guys passed your laws in 2010, I don't think there's anything that changed on it. Is the situation?
Well, I don't know that many pharmacy boards paid much attention to Amduca, and I mean, ours is a rule, not a law. So it's not a statute. It's a rule that was passed by the board. But one of the stressors that we deal with, and I fear you might have some feedback on it, is when Amduca basically says you cannot use bulk substances to produce compounded medications for animals, whether it be food producing or companion. But I mean,
Sure.
like, we could write all the laws we want, but we don't override a federal law on something like that, which is a risk to the pharmacies and the veterinarians.
Dr. Kirby, I agree with you that a federal law, you can't overwrite with it. So the first thing is, can they compound and be able to do it? Then we get into the details of what are they allowed to compound with. But the first piece is, are they able to compound? And then they have to use appropriate materials, because there's lots of other restrictions also. There's products that they're not allowed to compound because they're not safe. There's certain other chemicals and pieces. But to me, the concept of can they compound is the first one. And then the second, I agree with you that we're talking about your regulations, but your regulations are still legal and binding as compared. They're just not as forthright as statutes, but they are certainly much more binding than guidance.
I can appreciate that stance on it, that, you know, whether you can or not is one discussion, and then what you can do with it is another one that is far more convoluted.
Agreed.
Who's next, Luke? I think Roger was punting to some of his folks. Or Roger, did you have some more people with you that want to speak? Not from Charles and Brady.
No, I believe everybody else is just watching. They're excited to hear the discussion.
I've lost Luke on my screen. I don't know where he went.
Oh, hold on. Sorry, I was muted.
There you go.
Mr. O'Quinn, if you and your client are ready, if you'll just, Mr. O'Quinn represents ProLab Pharmacies. They were, like I said, this all kind of started when they bought Book of Business from U.S. Compounding. They are a pharmacy and not a 503B outsourcing facility. So there were some issues with prescriptions they were shipping into the state. So, and they have signed an MOU currently that they will only ship in patient-specific prescriptions into the state of Arkansas. So they're here today, like I said, to be involved in this discussion, and also amend that MOU to allow them to ship in patient-specific, non-patient-specific product to be used for office space. So, Mr. O'Quinn, if you introduce yourself and who you have here with you.
Yes, I'm Darren O'Quinn. I'm a pharmacist and an attorney as well. Taught at UAMS, College of Pharmacy Law for about 30 years. And I represent Mr. Jay Teague and his company. And this issue first came to light over when Mr. Teague acquired another compounding pharmacy or book of business from that, and started sending compounding products into Arkansas. It was discovered that some of those were for office use instead of patient specific. And so we entered into a memorandum of understanding with Dr. Kirtley and Mr. Daniel. But in that, we wanted to reserve the right to come back and address the issue of shipping for office use. I mean, just this past week, the issue is probably a good example of why some things need to be in a veterinarian's office, just with the snowstorm and those types of things, ice storm. Also, the other veterinarians testified or, gave us input at the hearing with Mr. Teague on specific instances of where it's not reasonable for a veterinarian to wait a number of days for medication. They need it in stock, and they gave a lot of examples of cats and large animals and different things. And I'll let Mr. Teague explain better, but I mean, I agree with what Mr. Morris has said and how he summarized the law. So, Jay, would you like to make a comment?
Thank you all for y'all's time. Again, I'm Jay Teague with ProLab Pharmacy in Paris, Texas. There's nothing really more that I have to say than what Dr. Jenkins addressed and Mr. Morris as well. I would just ask the board members today to possibly make an emergency rule change to what y'all's regulation is stating that will be treated as human use, just like a 503B, and to allow 503As to send office stock to veterinarians. That's really all I have to say. I think Dr. Jenkins is the expert on this, and again, he stated that they have no financial gain in this. So I think he's better equipped to answer those questions for his patients than anybody. But thank y'all.
Thank you, Mr. Teague and Mr. Quinn. I know, Mr. Putman, I know you're on. I didn't know if you had any comments or if you were just here to listen. But if you had anything you wanted to say, I would be glad to give you the floor.
I appreciate that, Mr. Daniel. I'm just here to listen and otherwise stay out of the way.
Okay, perfect. Thank you. Like I said, I knew you were here. Just wanted to give you the option.
Thank you.
And I guess, Dr. Kirtley, we have time. We'd set this for 2 hours, so we have time. I don't know if there's anybody else on the Zoom right now. I know there's several other people. Not sure who they are, but if there's anybody else who wants to, I'd just like to open it up if there's any other comments, or if anybody has anything they'd like to say for or against. Or I know there's some other people on the Zoom that may not be a part of Mr. Quinn, Mr. Morris, or Mr. Baker's groups.
Sure, I've got it shows Corey Hawks. Ms. Hawks, you'll let us know who you are and who you're with, and we'll give you a chance to speak.
Absolutely. Thank you so much to the board for your time. So my name is Corey Hawks, and I actually represent, our firm is out of Washington, D.C., and we have been in the compounding space for several years, but we actually represent the 503B companies that are in this space and that are working to try to provide these CGMP manufactured products to veterinarians. There are several states, Connecticut and Michigan, who actually require states. I know Mr. Daniel and Mr. Kirtley both mentioned that letter to Oklahoma from the FDA, and I appreciate Mr. Morris's description. We are following the Food, Drug, and Cosmetic Act that specifically allows, and again, in human, I appreciated that, but it allows for the dispensing of 503B products because that's what they were made to do. So as we discuss this, we wanted to just add that the FDA has encouraged us to report drugs such as Reciprocity and which is an animal drug. It's only on the animal list, and the FDA is involved. So although it is murky, we would like to say that this is what 503B drugs were made for, is to fulfill this office stock need. They're made to a CGMP requirement, so they have sterility testing, stability testing, and they're made to sit on the shelf. So we're here in that space, and we feel like that's why the FDA, that's why it was created, was to fill this need, and hope that the veterinarians in Arkansas can utilize those to the best of their ability. Whether there's no day limit, if you guys go with a 5-day limit for traditionally compounded drugs, perhaps on 503B drugs there would not be that limit, simply because that's the reason why they were created. So thank you so much.
Ms. Hawks, I think we'd probably love to have your contact information if you want to get on our website, provide it, because I'm sure we'll have some questions for you. And I would say this, partially for the record, but so that you know as well, we've even mentioned to Mr. Baker and Dr. Jenkins that there has been some really unfortunate confusion or either incorrect or bad information shared, to where even some of the veterinarians don't even know that 503Bs exist, and have even at some points been told, well, those don't have a permit to ship into Arkansas, which is not the way the board looks at it. when we generally look at things in a hierarchy of what can and cannot be done, it's anytime I'm looking for a medication, a drug to treat, whether it's my, a fellow human or my pet or my whatever animal, I want the highest quality product or the highest proof of quality that we can have. And, oftentimes in the hierarchy, we look at CGMP manufacturing, CGMP 503B facilities, and then 797 for pharmacies. Those are a tiered approach. And the CGMP requirements are much more stringent as far as proof of concept and proof of, in safety, stability, and everything else, which is, I think, why many of us have been strong proponents of 503B facilities. So I'm sure Dr. Jenkins and his folks with Veterinary Medical Association would, as they're learning more about this, they've already expressed interest in trying to learn how they can work with 503Bs to catch a lot of their needs in this. Our actual opinion from the staff right now is 503B facilities are absolutely welcome already to provide office stock for whatever it is they can legally produce to veterinarians, just like they could to a physician's office or a hospital in the state. So we have not put a restriction on that.
Excellent. I have a couple of questions for Ms. Hawks.
Yes.
What firm do you represent? Like, what firm are you with?
Political Capital. It's out of DC.
Okay. And
I can send you my contact information. I've been in correspondence with Mr. Daniel for several months. We've been going back and forth, but I'd be happy to share that with the board as well.
Do you represent a particular trade organization?
No, just individual clients within the 503B space.
Okay. And do you have any idea how many of the approximately 75 registered outsourcing facilities actually produce veterinary drugs?
We work primarily with 3 that are in this space, and there are a variety, but it's difficult, as Mr. Kirtley said specifically. Some people don't even realize that 503Bs exist, so it is very much an emerging market, especially in some states. But yeah, no, we work specifically with 3.
Okay, that's very interesting, because it's been a minute since I ran a 503B facility, but I specifically remember FDA coming in and telling me they did not want to look at anything related to veterinary drug products because it was outside their scope and it was not considered 503B. So unless that's changed, they were holding facilities to the certain GMP standard for the human products they were producing, but not for the veterinary products.
Right. And I think there's gray area, just as Mr. Morris said. I mean, the FDA comes in with things that they say and do. They want us to report those drugs. So our veterinary clients, 503Bs, are required to report those drugs to the FDA. And then they are those veterinarian specific 503B facilities, they are still inspected by the FDA. So they still have to register, they still have to be inspected, they still have to follow through with all of the requirements given to a human use 503B. And so it gets into that kind of gray area that yes, they do have oversight of those facilities, but then they make comments just like you said. You're like, we don't want to get too involved, but then they're incredibly involved. They do all the inspections and they do everything else. And so it kind of becomes this space where 503Bs are just attempting to make sure that they are covering everything. And I do have a really good comparison chart of what is exactly, or what's expected between a USP standard and the CGMP standard, a 503A to a 503B, and what we, even in the veterinarian space, are still expected to have from the FDA, including sterility, stability, and all of those things.
I think that was in our packet. I was wondering what the source of that was, because it was interesting for sure.
Dr. Kraus.
Dr. Kraus.
So I hope my comment doesn't set us back too many decades, but 503A and B do or do not apply to products for veterinary use?
Do not. They are sections 503A and 503B refer to sections in the Food, Drug, and Cosmetic Act, which is specifically for human. There are completely separate federal laws that cover animal use compounding. or animal use medicine, I should say. That is my understanding. I am not an attorney. That is not legal advice. That is my final disclaimer.
Well, I'm just thinking, you know, if you're compounding something for cows, well, that's food. So you would think that, well, they would have oversight over something that you're making for food producing animals. But
I didn't say FDA didn't have oversight. I'm saying that 503A and 503B specifically refers to sections of the Food, Drug, and Cosmetic Act. And the Food, Drug, and Cosmetic Act only applies to human drugs. There are completely other federal regulations and federal laws that FDA absolutely has some authority over veterinary drugs, but they're just not included in sections A and B of the Food, Drug, and Cosmetic Act. There are a lot of attorneys on this call. If I am wrong, I would love to hear that.
So here's
if I could,
well, I was going to say, here's the problem. It probably should not apply under 503A or 503B. But the problem is, if you are a 503A or 503B and the FDA is in there, it is up to whoever is in your house at that time and what they want to look at. And what we see, I mean, given we look at 483s for all of the different facilities that permit with us, and I mean, Kevin could, you know, he can jump on in a minute and tell us, but even when they are looking at veterinary stuff, in some of them, it is the same inspection as it is for human because they look at the same quality measures. So it gets weird. It probably should not apply in that specific section, but there's definitely law on it elsewhere, and it gets entwined.
So the non-compounded medications in a veterinarian's office, are they FDA approved drugs?
Yes, the non-compounded would be commercial products. So Dr. Jenkins has a supply of specific prescription drugs that he would get from a oftentimes, and Dr. Jenkins will correct me, from a wholesale distributor, but most of the time veterinarians are dealing with a veterinary specific wholesale distributor, not like the pharmacy distributor you have. So there are things, and we've talked to Dr. Jenkins and Mr. Baker, that in some instances, there are commercial products that they could use on the human side that they don't have access through their wholesalers, but a local pharmacy could actually supply it directly to them and stay under 5% and without even being licensed as a wholesaler, because we have a much broader access to various medications on humans than what Dr. Jenkins will have. Now, he has access to veterinary drugs that we cannot get in the human pharmacy commercially as well.
But that's usually a manufacturer's decision, not a FDA decision, right? I mean, usually the producer of that drug says, well, we're only going to sell this to veterinarians. We're not going to sell it to pharmacies that sell vet products.
Well,
It's
that's
a
true. There
separate
are
approval
some
process.
very strict limited distribution models on the veterinary commercial drug market.
So I can't remember now, but are the powders, the raw active pharmaceutical ingredients and things that we purchase for compounding, are those in and of themselves FDA approved? Not the finished product now, but the powders themselves?
Nope.
Okay.
And that gets into Mr. Morris's point of, can you do it or not versus how you can do it. And the old 1994 MDUCA basically says you can't really do it from bulk API, which is, I would say, has been ridiculed many, many times over the years, that I can take bulk product and make something for a preemie baby at a children's hospital, but not for an old dog. But that's the way it is, unfortunately.
Wasn't there a particular circuit court that maybe struck that? It wasn't the circuit court we were in, or am I remembering something different?
I defer to the attorneys, but circuit court level is only a specific area of the nation in many instances.
And I believe Mr. Morris had something.
Yeah.
Been patient with his hand up. Go ahead.
Sure. Just wanted to clarify. I think Dr. Mitchell asked the question. technically 503A and 503B apply only to human drugs to be able to do it. Animal drug approval is in the Food, Drug, and Cosmetic Act. It's in Section 512. So it's part of the Food, Drug, and Cosmetic Act. It's just a different portion of it, but it talks to the manufacturing of animal drugs. The compounding of animal drugs was the subject of, and you guys may remember this, the Frank's Lab case. This was the Venezuelan polo ponies, where there was a disaster down in Florida where a whole bunch of the ponies died. The FDA went after the pharmacy for it. The court found that they didn't have jurisdiction. The court found that the FDA has jurisdiction over the manufacturing of veterinary products, but the states have jurisdiction over the compounding of veterinary products. And that was the distinction. The FDA is still working on guidance. That was the draft guidance I mentioned, but they still have not finalized for the veterinary piece that's there that ultimately will allow the office use compounding, but they haven't finalized it yet. And it comes with lots of details that Dr. Kirtley mentioned, how you do it, not if you can do it, the process that's there. But just sort of to clarify those issues. And I believe the Franks case was not appealed, but it would have been the Fifth Circuit issue had it done that. I'm sorry, the 11th Circuit.
And I know, Dr. Jolly, you had your hand up. You still have questions, comments?
Yeah, just a real basic question, because I just want to make sure I understand the scope of the discussion, and I haven't heard it yet. Are we talking about non-sterile and sterile products that AVMA is requesting, or so both?
Yes.
Yeah, Dr. Jenkins would tell you he has need for some sterile and for some non-sterile, and not trying to step on his toes, but a lot of times it's issues that are as easy on a non-sterile as having a flavorant added to a specified strength of something for a specific animal, but other times it's need for sterile injectables for emergency or for initial treatment of animals.
Okay, thank you.
Dr. Richmond, did you have, I saw your hand up earlier. Okay. Dr. Mack?
Just trying to make sure I heard Mr. Morris right. Did you say that, I can't remember the number, it's not 503 or 504, the 503A or B, I think you said 512. Does it say in there that whether or not you can compound for office use falls under the state rule, not FDA?
Sure. 512 goes through the manufacturing process for veterinary products. It doesn't talk at all about compounding one way or the other.
So then the state is able to make their rules, such as Arkansas made their rule that they wouldn't allow it. Is that what you're saying?
That is certainly my position, correct.
Okay.
Yeah,
I was just trying to make sure I caught that.
Yeah, and our rule is in regulation, I got it pulled up right here, regulation 7-02-0002. At the very end of that, which is subsection M, compounding veterinarian products. 1, prescriptions for animals may be compounded based on an order or prescription from a duly authorized prescriber. 2, these prescriptions are to be handled and filled the same as human prescriptions. So it says under that regulation that prescriptions for animals may be compounded based on the order or prescription of a provider or of a duly authorized prescriber. And then, of course, we've always had the rule that they're handled the same way as human prescriptions.
So Arkansas is allowed to do that because it didn't cover it in 512 and Arkansas did it, but now there's some questions. So this is probably basic compounding that I just don't know that much. Why would veterinarians need it to compound in their office more so frequently or readily than a human a regular doctor needing to for patients? Why is vet so different than regular patients?
Dr. Jenkins, maybe can you, I think we talked about this before when you and Dr. Brett were here. So if you want to comment on that.
Yeah, how many species are you going to see today, Doc?
Yeah, just excuse me, just myself, I'm going to see 2 and potentially 3 today, and that, and I may be a little bit unique in that if you went to a practice in Little Rock somewhere, they may see 3 or 4 when you get into talking about exotics and that sort of thing. So the main thing is the unique situations that we're presented with and unique cases, and being able to prescribe it immediately and not have that delay in time.
Yeah, and I think Dr. Brett had mentioned stuff from snakes to squirrels to guinea pigs to all. I mean, stuff that weighs a few ounces to stuff that weighs, several thousand pounds.
Right, exactly. And you know, you're talking about a few grams to only a pound. You know, I could give you a specific example. Let's say metronidazole. You know, the lowest strength I can get that in is a 50 milligram. Well, if I've got a puppy or kitten that's 1 or 2 pounds, that strength is really way too high. And if I had the opportunity to have that compounded, say in a 10 milligram per milliliter suspension, I could really safely and effectively dose that puppy or kitten. And then take that situation a little bit farther. Maybe those come in a litter situation from a shelter, and we've got people who are going to foster those animals. I need to be able to break up that compounded product and send it out with maybe 3 or 4 different fosters. I mean, that's even, you know, a more unique situation. One other thing I want to clarify, y'all kind of touched on this, and I brought this up the meeting a few weeks ago, is, you know, keep in mind food, fiber, milk, meat producing animals is a whole nother beast in itself. Okay, meaning that we are limited on, number one, primarily antibiotic and NSAID usage in those animals, and you know, there are big restrictions on not using compounded products in those. But when you talk about exotics, small animal companion, and equine, this could really open up, you know, a lot of opportunity for us. And any other questions that makes sense? I can give more examples if you need.
A couple more to go along with that. I do remember all that conversation now that you're saying all that. I'm trying to get my head around, I mean, if a patient is a baby, you might have to compound, a human baby, you may have to compound very small amounts too. I'm trying to figure out how does it work for humans and it's not working for vets? That's one question. And then the other, I mean, just not knowing that much about vet school, does every veterinarian come out fully trained on compounding, or is that something you just developed because you're a specialist?
No, absolutely not. I'm not a specialist. I'm considered a general practitioner in the veterinary medicine world. No, we did not have training, and most all of the, you know, accredited veterinary schools are not going to do compounded training, and I have no desire to do that. And I will speak rather our as veterinarians, you know, use compounding pharmacies, and that's how we do it. We have no desire to be doing that in our clinic. You know, from number one, a sterility standpoint. Number two, that's not what I'm trained to do.
If I could add one difference between human and animals is the emergency room for animals doesn't exist unless Dr. Jenkins or his colleagues is willing to open up on Sunday afternoon or to go to where that client lives. And that there's not emergency rooms established for animals around the state. I believe I'm correct on that, Paul.
Yeah, I would, you know, and I would just add too, that, you know, we tend to keep a certain amount of pharmaceuticals in any practice, and it varies practice to practice. But, you know, I think why we're struggling with this is you're talking about a smaller entity versus a large hospital that I would have to assume, you know, may have a pharmacy team and a big pharmacy in it, and maybe compounding pharmacists under the roof. And that's not in our scope of practice.
So you're not wanting to compound, you're wanting the pharmacy to be able to compound it and send it for office use.
Correct.
But it works better for you to get an office use than a patient specific because maybe you might need it again. Or I mean, why
Right.
couldn't they just fill it and send it to you for patient Lola or whatever?
Well, that's probably happening, but our concern is that compliant at this point. And that, yeah, that probably does happen a lot, but we want to make sure, number one, we're doing it right. And number two, yes, there are still going to be situations today. I may call the compounding pharmacy that I use locally and have something filled because it's not going to be urgent. They're not out of it, and it's going to be an ongoing refill. You know, another example is, once again, emergent situation. You've got a hyperthyroid cat that comes into you in very critical situation. If I've got methimazole here that I can apply transdermally to that cat, it's not patient specific because obviously I didn't anticipate that cat coming in, but it's in an urgent situation with its retinas detaching and its heart rate through the roof. That would be a great situation. We could grab it off the shelf and administer it to that cat. The other one I touched on is, you know, a drug we use a lot of, dextomidine, mild sedation. If we had that, let's say in a paste form that was made by a compounding pharmacy that we could keep here in the clinic, and we've got an unruly or unpleasant cat or dog, we can put a label on it, send it out the door for them. You know, those are reasons why if we could keep it here, you know, we could dispense upon the need arising.
And each clinic might have different thoughts of what they want to have.
Absolutely. That's a great point is, you know, put me and 9 other of my colleagues in this room and they'll throw you 90 different examples of medications because yeah, I'm going to have my magic trick that I'm comfortable with and use, you know, versus maybe what my colleague, we're not going to be far out of bounds, but, you know, maybe I'm comfortable with that dextomidine paste for this dog. Maybe that's not what they like. They might like acepromazine. Yeah. So we're going to vary some. Yes, ma'am.
And you also have the zoos, which have every animal they can possibly fit in it, which is more convoluted. I mean, in all reality, our zoo here has, you know, pharmacists that act as docent, and I would imagine are leaned on for some of their expertise in the care of those animals.
Yeah, I would add to the zoo situation is you have to look at that animal and go, how do I keep from it eating me today? Okay. And then secondly, how are we going to get this drug, you know, administered to it? So that's an area that we feel like is really being challenged on the compounding issue.
And Dr. Mitchell, so if these were compounded for office use, I know everyone's going to be a little different, but did they last very long? I mean, how long can they sit on that shelf? Because that brings up another problem of them spending a lot of money and then not using it or not needing it.
So that, in my experience and in my own practice as a consultant now, that is completely and totally dependent on the individual pharmacy or outsourcing facility and what quality parameters they have in place. Have they done stability studies? Have they done process validation? Most of your 503A traditional compounding pharmacies that are doing a lot of vet and want to send it for office use have done some sort of a stability study. I wouldn't begin to speak as to whether or not, you know, it meets the requirements of GMP because I haven't specifically reviewed them, but it is interesting that it's a very interesting question because it's so nuanced in the vet world, and every veterinarian's practice is so different in terms of the animals they treat, the species, the number they treat in a day. I've worked with veterinarians that don't have like a physical office, like they literally, their office is their truck and they travel around to barns and those types of places. And so to me, circling back to your question about shelf life, it totally depends on how it's labeled and how the manufacturer is supporting that labeling. So whether it's an outsourcing facility, and I say manufacturer, but it could be a compounder. So whether it's an outsourcing facility that has validated processes according to GMP and done ICH stability studies, or it is a 503A traditional state regulated pharmacy that has met the requirements of USP, there is a way to have reasonable, usable dating, regardless of how the original producer is registered. Does that make any sense at all?
Yeah, I'm just thinking if it's 2 months, 3 months, 6 months, I mean, I guess, is it going to be the veterinarian's responsibility? I'm sure it is. Their veterinarian's responsibility to go through and clean that stuff out constantly. And I just wouldn't think it would have a really long shelf life. So that makes me wonder, are you sure you're going to even get the emergencies that you're going to use that for during that shelf lifetime?
Some do and some don't. And the fact that we have seen a migration towards a lot of larger, and this is totally my opinion, but we've seen the migration towards fewer kind of mom and pop local pharmacies doing vet medications to it being the big national companies that ship to all of the states, is because they're able to make a lot of their products in larger batches and do that testing to have that extended date. And where Dr. Jenkins may only need to keep 1 or 2 bottles on site, it's not practical for a local pharmacy to, from a financial standpoint, it's not economically practical for them to make that and do all the studies that you need to do to have the extended shelf life when he doesn't use very much. But when you combine that across the nation, it becomes a little bit more practical. Ms. Hawks?
Yes, thank you. I just wanted to echo you. I think you said it absolutely perfectly, Ms. Mitchell, that it's really expensive to run those beyond use state testing to make sure that you know exactly how long a specific medication will last on the shelf. And that's some of the added expenditures that 503Bs do take on, is because they're held to that CGMP standard. They are required by the FDA to do all of those to fill all of those tests. And I think 503As, as you said, they can do those, but it's a much higher expense, especially if you're only making a small number. So when an animal comes in to the vet clinic, they can either go to a traditional medication, they can go to a 503B medication, or they can go to a compounder. And I think that's where all of these issues come into play, is that each one have a different set of standards. They're all regulated differently, and just trying to make sure that the vet has, as Dr. Jenkins said, that they have what they need when they need it, and that they can get the patient or the animal what they need.
Dr. Krause?
Okay, so from where I'm sitting, 503A and 503B designations don't necessarily pertain to veterinary compounds, but they do pertain to the preparation of compounds, whether it's veterinary or human. Am I correct in that? Is that much sane? So what we have here, is my understanding, is we have a veterinary pharmacy that is wanting to send sterile preparations through the mail that is not 503B, or are they 503B?
The 503B group, we were mostly looking to address dispensing. I believe right now Arkansas is a non-dispensing state. And so we were hoping that the board would address the dispensing element of that. Although Mr. Kirtley said it perfectly, that you can purchase as much as you want from a 503B. We just wanted to see if it was possible for those pharmacists to dispense that to the animals they serve.
But the pharmacy that we're talking about right now is a 503B pharmacy. Does it have a 503B designation?
What for Ms. Hawks, yes. ProLab, no.
Right.
So like US Compounding had both when it was in business, and there's a couple of other, there's I know of at least 2 or I guess 3 503B national facilities that they concentrate almost exclusively on veterinary products. So I think that if I boiled it down, there's 3 asks going on here that are individually separate to help clarify. Ask number 1, can 503A retail pharmacies do office stock compounding for veterinarian office use? In that, there's a sub ask. Are you talking about sterile or non-sterile? But I think the request is for both. Question number 2, I really think is, how do you qualify for that, and what will the board actually allow you to compound? So can you do it? What can you do with it? The what you can do with it has some extraneous extra pieces in it, like how long of a BUD can you give on it? If it's under straight 797 and it's an aqueous product, it's going to be really short, and that's not really a whole lot of use for office stock. If you have spent the time and the money for stability studies and everything else, then it could have an extended BUD. Ask number 3 is, if ask number 1 is approved for office stock or currently for the 503Bs, we limit that any office stock cannot be further dispensed. It is only for in-office use. So the 503B industry sees an immediate advantage because there is there's some language in 503B that some people interpret to say that it could be further dispensed. Some people say that's not what it means, and I'm not the attorney to figure that crap out. But many states will allow a short supply so that if Dr. Jenkins sees an animal has a product on the shelf from a 503B, he can give an emergency dose and give that owner enough medication to get through until they can get a patient-specific prescription. So I think those are the 3 asks that you have. Ask number 3, in many ways, because the 503B arrangement could be completely separate from ask 1 and 2. Ask 1 and 2 are really more for regular pharmacies, because 503Bs can already do 1 and 2. They have a request for 3. Now you're muted.
Yeah, sorry. And just kind of the only, Ms. Hawks is really the only one here that's representing 503Bs, unless Mr. Morris can correct me if I'm wrong. But I think most of the issue here, or the most of how this started, is pharmacies, 503A pharmacies, wanting to send office stock for veterinary use, besides outside of what Ms. Hawks has discussed.
Mr. Morris, can you spitball for me about how many states are allowing traditional 503A state regulated pharmacies to compound for veterinary office use, and how many do not?
Sure. I actually sent materials to Dr. Kirtley and to Mr. Daniel, and I believe it is 37 states currently allow a traditional, we're using the term 503A pharmacy, to compound for office use stock. And then where the distinction comes in, if it's to be for administration in the office, or if it is to be allowed to be further dispensed.
And we've discussed, that's a straight reading of the rules. Like if you read one part of ours, it looks like you can do it. When you take the whole and you have to treat it like humans, and it says prescriptions, not prescription drugs, then it gets weird. So I know, Forrest and Brady did a thorough review of all the laws. The AVMA letter also outlines some very specifics on that is very useful, that Rodney and Dr. Jenkins got us. I tell you, the whole process would be so much easier to discuss if the FDA would adopt a final piece of guidance. And I think Mr. Morris will agree with me. The problem is guidance is only useful for what it says. And it's probably more useful when guidance tells you what you can do versus what you cannot do. Because if they tell you that you can do it, then it is very difficult to be punished for something they told you can do. If the guidance says you cannot do it and you do it anyway, the guidance is not law or regulation. So then it winds up in a battle of who wants to spend the money to go to the courts. If you get, the hammer thrown on you in FDA, do you go fight it? And can your legal team establish that it was not a legal piece of guidance? Roger, I think that's a pretty good rundown.
I think it's good. The only piece I'll disagree with you on, I would prefer not guidance. I'd actually prefer FDA regulations that actually say, yeah.
I agree. I'll take guidance because it happens in sometimes a couple of years rather than a couple of decades.
Right.
Does the guidance right now say you can't do it, even though it's not law?
The proposed guidance that is in draft form would allow for office stock compounding. So the reasoning that many people have is, well, if the proposed guidance would allow it, some people say that means you cannot do it now, but the guidance would allow it. But the argument is the guidance can't trump a law. If the law does not allow it, guidance can't override that. So there's some thought processes of, well, it must be legal, but we really want the guidance to give their interpretation of how it's legal before they come back and pull it and say, that wasn't actually legal. We were talking about that. Like, we bought a ring and everything, but the marriage did not happen. So,
yeah. I mean, and like Mr. Morris said earlier too, guidance is just that. It's guidance.
Yeah.
It's not law. It's not enforceable. It's not. So,
But nothing says you can or can't except the Arkansas law says you can't.
No.
It's
I wish it was that simple. It is incredibly convoluted to where we could do a spider graph of decisions, and every time I would make the graph, somebody's going to throw in something like, well, wait a minute, you said yes, but you didn't have a qualifier of yes, you can do this, but AMDUCA says you can't do it that. Well, yes, you can do it, but it should have been under CGMP because you're also permitted as a 503B. And in everything else, we know very, very well the capabilities of our inspection staff, our inspector investigators. Dr. Robertson, Dr. Fain, Dr. Holland are all highly trained. I mean, Dr. McCready as well in sterile compounding inspections, largely on 797, but even Dr. Robertson having additional CGMP training. We are back on track where we are basically 2 years out on any inspection. We've caught back up through staff shortages and through COVID. And I mean, Omicron hit us really hard and we back off. Ice storm hits for a couple of days. We're not inspecting on Monday after everybody's closed Thursday or Friday and catching up Saturday. The bigger stress that I think the staff has in this is I have no idea what the capability, qualifications, or thoroughness of inspections are for other states. And I don't say that to denigrate other states, but I know we use the NABP blueprint for compounding. I know that our people are very highly qualified, not only because they have a doctor of pharmacy degree, but also because they've had all this additional training. I don't know of another state that all of their inspectors have that kind of training. Many states, it's not a pharmacist, and I'm not saying you have to be a pharmacist, but I don't know what training you get to be equivalent to having that pharmacy degree, having that professional experience, and having like your SISI certification.
Dr. Krause?
I mean, since the FDA doesn't seem to have anything over veterinary compounding, based on what I'm hearing, well, not
512.
No, they do. It's just not in 503.
It's 512, I think is what he said.
Yeah.
But it's on manufacturing is what he's
I was going to say
clarifying.
that's manufacturing, not compounding.
But
That's
they will tell you if you are using ingredients to make products and distributing it to a medical professional like a veterinarian, they count that as manufacturing. at that point because it's not patient specific. So if you read, I mean, we get the magic, 8-ball out and ask it questions, it might provide more clarity. But when you are making non-patient specific drugs from bulk ingredients and selling them to a veterinarian or a physician, they're generally going to call that manufacturing.
But is there a percentage with them that you can still do?
No. Unless, I mean, if I missed something on that, somebody else correct me, but no, it's an N of 1.
So the question on whether it's manufacturing or compounding, and I start every one of my pharmacy law classes and my FDA classes on what is manufacturing versus compounding. And there's been dozens of lawsuits about this over the years. Shockingly, the FDA loses about half of them, which is really bad average for a government agency on it. But we get into, is it manufacturing or is it compounding? And obviously, as you get broader scale, the argument tilts towards manufacturing, but it doesn't have to. But that's the area that's gray. And I think that's why you guys are having this couple of hour discussion today.
And Roger, it gets more comical when you figure out which district made which determination and how that has a national impact versus a regional impact. And quite frankly, needing clarification via an actual law or regulation or a Supreme Court, decision to give clarity to everybody.
Let me just say for the record that I have veterinarians that I have compounded for in the past years ago. I don't any longer because of the situation that we have currently with 503As and Bs and the FDA and the changes that were made in compounding. That being said, I don't have a problem with this company doing any compounding from a philosophical standpoint, but I want to be able to do it too. I don't want to say, well, if you're in Paris, Texas, you can compound as a 503A something sterile and send it into Arkansas and move on. I don't have that latitude. And so I think that if you have pharmacy rules and regulations and laws, they should be the same if whether you're in state or out of state, as long as you're providing for the citizens of Arkansas and in this situation, pets, but patients, I should say. Is the FDA, I don't see, other than it's always been my understanding that if you did sterile products and you sent them into this state for office use, that you had to be a 503B. Am I misunderstanding that?
Say that again.
That if you are a pharmacy and you are going to if you're going to mail in sterile products, you should be you're 503B. If sterile products for office use, excuse me.
For office use, yes.
Yes. That you had to be a 503B facility. That didn't matter whether you're doing whatever for a dog or a human or whatever. That was just 503B. That's the preparation of a particular product. We're not talking about the end user, what species they are. I don't know if we're looking at a rule change that we can make, or is this a rule change that has to come down from higher ups? Because if the FDA has a say in this, then I feel like, well, that's their ball. They have to run with it. But if they are not involved with it, then maybe we have some latitude.
I think if you go back to the 3 questions, question 1, can a 503A, can a normal pharmacy do office stock? The board can make its determination and the FDA can make its own determination too. And if the board says you can do it and the FDA comes after you, the board can't really help you.
Can the board help you anyway?
Well, right now we're telling you that you can't do it. And the FDA is basically telling everybody they can't do it, but we're saying that 503Bs can. So if you do it right now, the board isn't going to help you because the board has basically said you can't do it because of this.
But what you're saying is the board's help is basically repeating or saying, I know what the FDA is going to say, but we don't have really a position on it on our own.
Well, no, I think what I'm trying to say is if the board makes an independent decision that is different from the FDA is not going to listen to us when we say, look, we know so-and-so was just doing what we told them they could do. The FDA is going to do their own thing.
But do we know what the FDA is telling us to do?
Well, they have draft guidance. If they would finish, my opinion, I agree with Roger.
That's a smile on a dog, draft guidance. That's what you want to make of it.
But the draft guidance would specifically tell you it allowed certain activities. And if they tell you in writing in the draft guidance that they allow a certain activity, then you can take comfort that that activity has therefore been allowed.
And what is that activity that you can, any pharmacy could do a office use? Is that what the draft guidance says?
For veterinary.
For veterinary office stock.
What can you do right now for office stock at a pediatrician? Nothing? Or
a 503B can produce products and send them to physician offices or hospitals or veterinarian offices or clinics of a medical professional with the authority to obtain, possess, and use those medications.
But this pharmacy is not a 503B, right?
Do what?
This pharmacy is not a 503B.
Well,
John, I have a quick question on that.
Yeah.
So I'm not disagreeing with what you're saying at all, but I feel like I'm remembering when I first was appointed to the board that was like, our position basically was that our regulations, even for human use, that our rules and regulations allow office use compounding. But if you do it for human use, FDA is going to come after you. So we strongly recommend that you don't. But our legal position was our rules and regulations permit this activity, but like, don't do it because FDA says you can't.
I think that was the position as far back as 2003 or 4 when we originally adopted it. I think the position changed when we came up with the outsourcing facility designations because it was
the wholesaler. Are you talking about when we did our statute? Okay.
Yeah.
So that makes sense. I'm trying to figure out though on regulation 7, and I pulled up this news that we sent out in 2010, where it says that we specifically changed regulation 7 to delete the prohibition on pharmacy compounding for veterinary and office stock. How did we get from there, which is what I remember from my practice, to the board says you can't do veterinary and office stock? Like I somehow don't understand how we got there.
Because you have to treat it the same as human drugs, and we changed the way we treated human drugs.
When?
With outsourcing facilities, with 503B, when it became a federal law that it could not be done on humans, then it follows that you cannot therefore do it on veterinary if you have the same rule for both. In reality, what you really want on number 1 is to change the rule where you don't have to treat it the same as human drugs.
That helps me because I was just confused about how we got there. And I think where some of the confusion is maybe for ProLab is that at least within the compounding industry that I'm familiar with, most people assume, whether that's correct or not, but most people assume that veterinary compounding is not part of 503B because the word human appears like 27 times in the federal statute. And again, it's the specific section in FDCA that talks about human drugs, not animal drugs. So I think maybe that's the confusion. And I don't know that we're going to solve it today. So my thinking is that we just sort of attack these 3 questions that you've presented and get the board's thinking on those 3 questions. Because I don't think we're going to be able to, I think I heard emergency rule change. I don't think we're going to be able to do that today. And I think we could discuss this until the cows come home, pun intended. Come on, that was a good one. I've been waiting to use that.
There you go. And that was my point. I mean, anyone who throws out doing emergency rule does not understand the process of an emergency rule in Arkansas in any way. Like that is, if you watch the legislative action on emergency rules, and Rodney will probably start laughing if you ask him about it, because it is literally, it takes just as long to get something effective, but it's twice the amount of work and twice the amount of scrutiny and twice the amount of committee meetings to do it. I mean, there could be an emergency rule that could happen faster, but I think it's generally due to like the governor's declaration of an emergency versus the process we have to go through administratively.
So I have a question, John. This would be for anybody that can provide input. So what would be the barriers to a veterinarian using a 503B versus a 503A? I understand for non-sterile compounding, there may be custom dosage forms, particular drugs that you may not be able to get from a 503B. I don't know, but particularly non-sterile versus sterile.
First obstacle they have is most veterinarians have never heard of a 503B facility. They have no idea what an outsourcer is. That is, in some instances, I have been told by veterinarians that it's because there are people in this specific niche market that tell them this is the only way to legally do this, even though they are not a 503B. So what we've discussed even internally is, with Dr. Jenkins, with Rodney, with Dr. Brett, who we've met with also, is we can help by showing here are different avenues to get access to medications, one of which is your local pharmacy may have a human commercial product you don't have access to that they could help get to you. Number two is there are these 503B facilities running generally at CGMP, targeted production rather than 797 that can supply this to you. But I mean, can you imagine your world if you had no idea what a 503B was in the hospital that you're in?
No.
And if someone came and said, here's this thing called 503B facility, and here are some that can fulfill your needs, it changes your entire world. But they don't teach that in veterinary school. It didn't exist when most of these guys were in veterinary school.
So they do have a workaround, but it's unique to them. I mean, because they don't know about it, 503B. And then they could get their office use and everything.
For the products the 503Bs make.
Mr. Teague?
Sorry, could Mr. Teague raise his hand? If I don't know if anybody saw that.
I think though, and I think Dr. Mitchell will agree with this, if you're a 503B, there's only a certain amount of products that you're going to produce because of that testing specifically for sterility. Now we do all that testing ourselves when we use third parties. But for instance, say if a animal needs Panazaril oral suspension, which I don't believe any so-called 503B veterinary facility is making, we don't make just one strength. We make from 1 milligram up to 200 milligram per mil. So that's a good, for instance, of there's tons and tons of different things that 503As do that 503Bs will not do because of the guidelines that they have to go by. And we just follow, of course, y'all's regulations in each state that we do business in, and we, of course, will. Thanks.
I see you, Dr. Ford, or Ms. Ford. I'm going to answer or respond to him. I don't want to speak for all 503Bs. I would defer to Ms. Hawks for the specific clients that she represents. I will say that in my experience, having been in several dozen 503Bs across the country, the ones that are making a very large number of products tend to have, it's not a hard and fast rule, but as a generalization, the bigger the product list, the more compliance and quality issues they have. Because typically the less control they're going to have over their processes. So, but I will defer to Ms. Hawks on speaking for her clients, and then we'll go to Ms. Ford.
Thank you. I do know that as 503Bs strive to follow all CGMP requirements, it is, as you said, it's a very high level of standards. And so what is expected of them it is much higher than what's expected of a 503A as in a USP sort of standard. I can't speak to all of those inspections and how they went in your experience, but I do know that they are willing and they are adaptable to make different products, but there is no replacement, as you said, Mr. Teague, there's no replacement for that personalized medication. 503Bs have a fantastic standard and they're working to fulfill everything that's been expected of them, but there is no replacement for that ability to make personalized medication.
Ms. Four, I see you, Dr. Mack.
I didn't have a question. It was,
thank you. I thought your hand was up. Dr. Mack?
Sorry. I just wonder, I guess this might go to Dr. Kirtley, but for question number 1, is that would the board allow 503As to make office use for veterinarians? Is that what question 1 is?
Yes.
And could it be maybe a certain day limit and or a certain just non-sterile versus sterile?
I'm going to treat this kind of like we do when we have support group issues. The first question is yes or no. Does the board have an appetite for exploring that? If the answer is no, then we don't have anything else to answer for number 1. If the answer is yes, then you have to start into the minutia of what, how, when, where, all that. My suggestion would be is if the board would say yes on 1, this isn't something you can hash out in the next 30 minutes in this meeting. I think it's trying to put some heads together offline and kind of figure out an approach for an upcoming meeting of here's kind of the outline of what would be suggested. And I'd suggest, like, Dr. Jenkins has been great to work with as far as a local veterinarian of here are the specifics of what I need.
But but that is the question. Could 503A, so that would be Dr. Krause for that example. Could 503As compound, and depending what we decided, sterile, non-sterile, for veterinary office use? That's how simple that question is, number 1.
Yes, good. And I think Dr. Jolly had a comment. I saw his hand up.
Yeah, going back to, I think it was Dr. Kirtley that mentioned this earlier about, we don't inspect out-of-state 503As, and we can't speak to what goes on within those facilities independently ourselves. So going back to my question about barriers, talking, I guess, mainly about non-sterile products from my standpoint, what would be the barriers to an Arkansas-based veterinarian using an Arkansas-based compounding pharmacy versus an out-of-state? Is it going to be selection of products, or do we have in-state pharmacies that can meet their needs?
I think part of it's going to be selection of product and availability. Some of these large, like I don't remember who it was. I don't remember who it was, but somebody mentioned about, and I think maybe it was Mr. Teague or somebody, but the larger facilities are making, they can make large batches of it and have it on hand, as opposed to your local pharmacy may not even have the ingredients to make what's needed. But that may be a better question for one of the practitioners to answer. But
Dr. Jolly, the biggest thing is we have local pharmacies that would be interested in this realm, but because they had actually talked to us or had listened to what the board had said over the years, they are not exploring this area of practice in any way with office stock because they do not, they understood that they couldn't do it at this time. If the board said that they could, I absolutely think there are pharmacies in Arkansas that would do the same thing. They have, I think they've been more aware of the conversations going on and therefore did not. In other states, they have had allowances to do that and they have built that business. But, you know, Arkansas has led the way on a whole lot of compounding stuff for a long time. I mean, look at the number of 503B facilities we've had in the state, off and on through the years.
Yeah. Okay, that helps me. Thank you.
Ms. Hawks?
Thank you so much. I wanted to actually go back to Mr. Kraus. You made a really good point about the basis in law and falling back to that. If I can, and this may be a stretch, but if I can take number 3 off the table for 503B, just for simplicity's sake, the Federal Food, Drug, and Cosmetic Act already makes an allowance for 503Bs to supply and dispense. In section A8, it says, this paragraph does not prohibit administration of a drug in a healthcare setting or dispensing of a drug pursuant to a prescription executed in accordance with section 503B. So really, I think 503Bs are just looking for the Arkansas Board of Pharmacy to say vets in Arkansas should follow federal law and in this, and clarify, because they do look to the state and especially this board to make sure that they are compliant. And if the board simply said, we would like to mirror federal law, New York has done that, several other places, that just says 503Bs may both administer or dispense 503B from a pharmacy or from a veterinarian may dispense those medications. We could fall to that federal law instead of trying to create something new.
And Dr. Mitchell, I know you and I have discussed this before, because if you read it one way, it says a 503B can dispense, which we absolutely allow and even have in our rule. They should have to be a pharmacy permit. And if you read it another way, it allows them to sell it to someone else and for that third party unassociated to them to dispense. And
in like a wholesaler type of transfer, we're just thinking 503B to a clinician, to a clinic, and then dispense, correct? Yeah, that's all the clarification we were looking for. We're not looking for any sort of middleman.
Well,
are you wanting the 503B to be able to fill a patient-specific prescription for an animal?
No, so that a veterinarian could place an order to a 503B, receive those medications, and then distribute them to their patients, the animals that they serve.
And that's the two interpretations right there for you.
Right.
And that sounds like wholesaling, and DQSA specifically prohibits outsourcers from wholesaling.
Wholesaling.
Super confusing.
But in Arkansas,
license them as wholesalers, so it's a total mess.
So we would define that as a wholesale transaction of a compounded product, then being further dispensed, which is prohibited by our rules. So it would require a change to our rules, even for a 503B, to do that.
I have a couple more questions for Ms. Hawks that I'm asking. I don't have an agenda on this at all. I don't have a dog in this fight. So, oh, there's another pun. Look at me go. Do you know how many outsourcing facilities do veterinary compounding? I know you said you represent 3. Are you the only 3 that do veterinary compounds, or are there more?
No, I believe there are more, and I know that the primary company that we work with makes over 200 products. And I'm happy for veterinarian specific. Yes, just 200 products just for veterinarians, and I'd be happy to send you that list. But yeah, I know that number is growing. They're all made to CGMP level.
Okay, and then my other question for you is, for your 3 clients, are they licensed as outsourcing facilities with the state of Arkansas?
Yes, I know our main one is. We collaborate with several 503Bs, but I know the one that we work with primarily, yes, they are registered in Arkansas.
Okay. I mean, and the reason I'm asking is that I feel like outsourcing facilities wanting to do veterinary compounding is a little bit new in the industry, and a lot of the newer outsourcing facilities are having a hard time getting an Arkansas permit because FDA has not been doing inspections. I mean, I personally have a couple of clients who've been waiting over 2 years. So I was just trying to figure out, I guess, accessibility for the Arkansas veterinarians, if we're saying, okay, we would be fine with them using an outsourcing facility, how many outsourcing facilities has this board licensed that are actually providing veterinary products? Because that to me speaks to, you know, sort of real world availability for the practitioners in the state. Does anybody know the answer to that question? Paging Dr. McCready.
Yeah. Dr. McCready, Dr. Robertson, don't we have 2 or 3 when we looked?
We do have 2 or 3. We've got one that's reapplied that their application had expired. So we do have 2 or 3, yes.
Dr. Robertson, anything to add to that?
No.
Okay.
So if it is helpful, we were talking with the Ohio Board of Pharmacy, and they looked at us and said, we're going to have to talk to the FDA and ask them what their interpretation of that law is, just like Dr. Mitchell and Dr. Kirtley said. They said, we need to talk to the FDA directly. And so they actually reached out and received a letter in response to the FDA, which I believed I supplied to Mr. Daniel. But they did weigh in and say, yes, 503Bs may dispense their medication. So I'm happy to supply that letter from the FDA.
That's not the question, though. It's not can a 503B dispense. It's can a 503B sell to a practitioner for them to dispense, or can a 503B sell to a separate pharmacy? Like can 503B, you know, number 1, 2, 3 sell to me at John's Pharmacy and me dispense to a patient? So I haven't looked at the Ohio letter. If we've got it, I'll review it. But you can ask a very simple question and get a very simple answer, but this is a 2-step, not a 1.
And I apologize, Ms. Hawks. I did not make that available to the board, and it just slipped through. But I am sending it right now, and I do apologize for that.
Dr. Jolly, and then I see you, Dr. Mack.
Yeah, I'm not trying to jump ahead, but I would say as far as the need that the veterinarians have explained, I understand that and I empathize with that. And I think I don't have an issue with us figuring out a way to address that need. But I think this is going to require a lot more discussion. So how would we go about that? I mean, would we have a special meeting just to talk about this issue, or what would be our next step here if we agreed that we need to explore this further for a potential regulation change or whatever? John, I would defer to you on what all would be involved there and what we need to do as far as our next steps. But again, not trying to get too far ahead of my fellow board members, because you guys, there may be additional discussion. But I just think that's where I'm at this point.
Dr. Mack, and then I see you, Dr. Krause.
So I was pretty close to what Dr. Jolly just said. I guess I'm wondering specifically from John and Luke and Brenda, do you think if we set up something and work through this, do you feel comfortable that we could come with a small window to help? I wouldn't even go to sterile personally, but a small window of either products or types, or how many days supply, that kind of thing. Do you think, especially for question number 1, do you think we could make something that is not really complicated that could help this need? I guess that's my question, whether it's in state or out of state. I mean, if it's 503A in general.
If the board directs us to do so, that is what we will do.
And I think I would like to ask, is Dr. Jenkins, did he step out? I just wonder what more of the need is. Is it more sterile products for injectable type stuff, or is it more non-sterile? But we can ask him when he comes back.
Well, and it's funny to me to hear, Dr. Mack, to hear you say that, because my instinct is the opposite. I feel like in general, facilities that do sterile compounding are doing a whole lot more testing on their sterile products than they are on their non-sterile products. And there's a lot more work on the quality side for sterile than there is for non-sterile. So it's definitely going to be an interesting discussion.
But every 503A isn't doing sterile. So we would I'm just saying, could we help them in a small way by starting with the non-sterile that every pharmacy, Dr. Krause has included, could make as an office use? If it was either a small number of products, I know we don't want to get into every scenario, but if it was some small concession to help is what I'm saying, not really going all the way into sterile and everything.
I see, Dr. Krause. Mr. Baker or Mr. Teague, do y'all have any input on what you're being asked to make for office use? Is it more sterile or non-sterile? What's the ratio there?
I wish I had a ratio for you. I don't. I'd hope that Dr. Jenkins would be back. I just sent him a text asking to come back. He did indicate earlier in this meeting that both sterile and non-sterile products were needed, if you recall. So, but I don't know the ratio.
Yeah, he needs both.
Dr. T, what are your?
Well, I would say about 20% of our products are sterile, and that includes ophthalmics. But Dr. Mitchell, you're correct. I mean, we're using, I don't know if I'm okay to say this, but we use Eagle and Dynalabs and ARL to do all those testings, and they also test our non-sterile for potency and BUD studies as well. But some docs like to use apomorphine capsules and dissolve it in the eye. Some like it as an injection. It's just kind of like Dr. Jenkins said. Everybody has their own, lifesaver, I guess you'd say.
Ms. Hawks, of the couple hundred veterinary products that your main client makes, do you know the breakdown of sterile or non-sterile in those?
I don't off the hand. I just text someone that, so I am looking, but I know that as far as I know, the majority of them are all sterile.
Okay. I think Dr. Krause was next, and I'll go back to you, Dr. Mack. Dr. Krause.
Yeah. So, I think about the time Brian made his comments, as far as what to do with this, and then talking about it and thinking about it, and I please don't mean any slant towards animals or the veterinary world, but I mean, I see absolutely no problem with this board re-examining a rule or regulation change to pull veterinary compounding out of our regulations pertaining to human compounding. And if those that are wishing to do compounding for veterinaries know that, you could get a visit by the FDA. Of course, that can happen to any of us at any time, but know that because we don't have what seems to me clarity on how to handle issues like this. There seems to be problems, and I am not sure that there's a real big problem with people doing this for animals. It's a lot of time. We're not talking about children or prisoners or anything, we're talking about animals here. So I don't see a problem with allowing pharmacists to compound for office stock for veterinarians, for patient specific. I don't really see any danger there to the profession or to any other individuals in us doing that. But I do think that it should be a level playing field. And if the FDA doesn't or does have explicit things that we should follow in veterinary compounding, well, I think it's up to us to make sure that if you're going to get in that realm, that you know what those are. But I can't stand this kicking the can down the street any further.
And I think, Dr. Mitchell, can I speak? Darren?
I had Dr. Mack up next, and you're right.
I'm
after
sorry.
her.
I didn't see that.
Sorry, he could, but so I guess where I was going, Becca, is from what I understand today, they can get all the products they want, sterile, non-sterile, anything from a 503B today. Right? Even office use.
I don't know that. I would be fascinated for Dr. Baker and Dr. Jenkins to offline get with Ms. Hawks and her client and figure out an answer to that question and report back to the board, because I don't know what her clients make and what Dr. Jenkins and his colleagues need. I don't have the answer to that question.
Okay. So whether they can or not, if question A1 was, will we let 503As, every pharmacy in the world, office use compound? That doesn't mean there is anybody that can even do all of those things for sterile. I mean, there may be some pharmacy somewhere, but I don't know that every single pharmacy is equipped to do every kind of sterile product that the veterinarian may want. So that's why I was kind of leaning towards the non-sterile. But the way I understand the question is just, do we want to let every pharmacy be able to office use compound for a veterinarian, whatever they ask you to do, whether you can do it or you're not? You may not be able to do everything. I get that.
I think it would have to be all qualified pharmacies, just the way that we do it now for human prescriptions. I mean, to be a compounding pharmacy, you have the extra questionnaire, you have to turn in extra, you have to turn in, I mean, especially if you're doing sterile, you have to turn in sterile inspections, you have to turn in all your third-party certifications. You have to turn in all of that. I don't see how this would be different. Then, I mean, we're just not saying that, the retail pharmacy down the street just doesn't know sterile compounding before, can't just start making sterile products.
Okay.
Yeah.
So then it is very specific pharmacy. So either way you look at it, what I'm saying is veterinarians are going to have to learn about these 503As and 503Bs, because that's where they're going to get their products. I mean, they're going to have to, even if we allow this right now with 503As, it's still only specific pharmacies. It's not every pharmacy down the road from you. Is that correct?
Well, yeah, I mean, just because you have a pharmacy license doesn't mean you can do everything.
Right.
Whether in state or out of state. If you're, if we're dealing with a state that doesn't inspect but every 5 years, we're not going to approve them to do that.
So it's almost like communication is problem number one with the veterinarians, that they just don't know about the Bs. And it's going to be the same if we allow A's, because they can only get it from special A's. So that's kind of how I'm wrapping my head around it.
Dr. Mitchell, just one comment for Dr. Teague, and probably Dr. Jenkins is back and he could comment on this, but there's a real need for the availability of these products, like from 503As right now. So I don't know, and I know Dr. Kirtley talked about the emergency rule process, and that's hard to do, almost as hard as just changing the rule. But I don't know if Dr. Kirtley knows of any interim like guidance the board could put out more quickly, or moratorium on enforcement, or I'm just thinking out loud, but there's a real need, as we speak.
I think that you have a client that's a 503A.
Right.
Ms. Hawks has clients that are 503Bs that can currently do this legally without question from anyone. So I understand that you feel like there are 503As that this demand is there, but I don't know. And what we've tried to work or attempting to work with, like Dr. Jenkins and Mr. Baker, is if we educate, many of those needs may be currently fillable without having to do an emergency rule or trying to say we have rules we're not going to enforce or something like that. We frankly don't know that.
Well, and I understand what I was, I guess, getting at is some of the testimony or statements to the board is that the 503s really don't have a large inventory of veterinarian type products, where the 503As can get very specific in what they're doing. So,
well, I think a lot of that on the 503As is, though, they are prepared to make patient-specific needed medications for those individual units. I don't think that the testimony is that a 503A is trying to make 10 different strengths of one thing so that the veterinarian has all 10 strengths. But I mean,
I don't know. I'll let Mr. Teague would know that, I think. But Jay, can you comment on the availability of your 503A type products?
Well,
I guess the different lines they have, different products they have.
I mean, good Lord, there's so many different strengths that we can do. I mean, and I think that's the process. And I was not, I guess the question was, because Dr. Mitchell is an expert with 503B or worked in one. I don't know the answer to it, but I do believe that if you're a 503B, each product has to be, the FDA, you have to tell them what you're doing at every point. So I think there is a limit of only, say, so many products that a facility can do on a given time period. And I think that goes back to the logistics of it. So let's just say there is a 503B facility that's doing veterinary products. There's no way possible that one 503B facility in this country can take care of every veterinary clinic in this country either. That's just not possible logistically. I mean, even if also they could be shut down tomorrow. I mean, we've all looked at these 583 reports and seen, not only in your state, our state, how many of these 503Bs are shut down the next day. So I think that's another problem. I don't know if that answers the question or not. Sorry.
Mr. Daniel, did you have your hand up?
Yeah, I did. And I just had a quick question for Dr. Jenkins that he's back. I think I was going to ask this earlier. Do you know what the board was discussing this while you had to step out? Do you know like what percentage of, say, would be sterile to non-sterile? Like, I mean, what you would be required if you were able to order all of this from and get it in for office use? Would you just have I mean, it didn't have to be exact, just kind of an example of what it would be, more sterile or more non-sterile?
I would tend to say more non-sterile. And y'all help me out if I'm wrong on this, but when I say non-sterile, I'm thinking oral products and transdermal gels. Is that correct? In that area? Yeah.
Right.
You know, the injectable stuff that we're going to use compounded, at least for myself, and I think I can speak for my colleagues, we feel pretty comfortable on that, you know, because we're using that for a specific patient right then. You know, injectables are not getting dispensed out of our clinics. So by and large, the majority is going to be non-sterile.
Thank you.
And I apologize for stepping out.
No. You're fine. Yeah.
It's like you're working or something.
Yeah. You've got a business. So, yeah.
I think Dr. McCready has a comment, and then I saw you, Dr. Robertson.
I actually have a couple of comments. The first is that there are several 503Bs that are licensed with us. We just actually approved another one this morning that is a veterinary compounding 503B. Dr. Robertson has done a very in-depth study of review of their documents and that type of thing. And we do that with everyone that comes in. And we do have 503Bs that can provide veterinary products right now. I also think that within the state, we have 3 inspectors that go out in the stores, and we know that they're in those stores. We know what they're inspecting, and we know how often they're being inspected. And I think our pharmacies probably could handle this. I don't know. There are other states that only inspect every, as Dr. Kirtley said, 4 or 5 years. And that's not an issue that I think we want to open up to the state of Arkansas and the patients of Arkansas. And I know it's just an animal, but it's somebody's animal. And so just an animal is really not, I don't think you can say it's just an animal because it is somebody's pet.
Not somebody's baby, though.
Well, maybe the only pet they have. That's all I had to say.
All right. So it sounds to me like for question number 1, does the board want to allow traditional compounding pharmacies that are not registered as outsourcing facilities to compound for veterinary office use, that the answer to that question is not something we're going to get to today, but there is enough interest in possibly allowing this that we should move forward with figuring out the answer to that question. Do I see heads nodding, or do we want to just flat say, nope, sorry about you right now? Dr. Kraus?
Well, I think we should allow it for any pharmacy that our inspectors can inspect. I don't think.
So you're saying that, yes, we should further explore allowing this?
Well, if we can't inspect it or police it, I mean, then don't police the in-state pharmacies that do it.
So let me ask it this way. Can I hear from the board members that feel very strongly that 503A pharmacies, that the board's position of not allowing traditional pharmacies to compound veterinary office use should continue, and that we should just end this discussion right here and not pursue it further? If that is your opinion, like, can you wave at me or speak up?
Everybody's screen just froze.
Can I make a statement real quick? Or a statement, Dr.
Yeah,
Mitchell?
you forgot Dr. Robertson.
Oh, sorry.
That's okay. I get forgotten about around here a lot. That's fine. I'm used
Well,
to it.
usually it's not me, so I'll apologize.
No, that's fine. Just for context, I think it's helpful for a little bit of the background of some review that I've done. There was some data that I looked at from a 503A that was doing veterinary compounding. Within 8 months of that data review, there were 105,000 doses dispensed. Of those, 5% were injectable products. So that's just one representation of one provider. And of those, 54% roughly from my review could have been, so 54% could have been taken care of by a manufacturer in an FDA approved product or a 503B. So that being said, I guess it kind of goes along with the context of 503Bs are not the panacea, but I think they definitely help. They have a place, and that's all I want to say.
All right, so I see you, Ms. Hawks, but I'm really trying to like wrap this one up and figure out where to go from here. So I don't see any board members that said, I absolutely think that we should just keep saying no and move right along. So Dr. Kirtley, whatever we need to do, I guess, to further discuss question number one.
I think we can start working on some language and getting some external information on kind of what those needs are to help frame that around making a separation from must be treated just like human drugs.
Okay.
You know, it'll be changes in what Rule 7 for compounding.
Okay.
And we're going to have to at some point, you know, due to this going to a virtual, we had to move a couple of hearings that would have taken a long time. So we're going to ask, at some point, we're going to ask the board to set a date between now and June. So if we needed to have a discussion sooner than June, that's available, because we're going to ask the board to have at least 1 day of hearings, maybe a day and a half between now and June, due to some stuff that had to be moved from this board hearing. So like I said, hopefully it won't be another 5 months. We can get it in sooner than later.
And my plan would be to have some potential proposed language to get direction from the board on whether or not to proceed with rule changes at whatever meeting we can get that done. If it's minor wording changes at that point, then it means I can start the filing process with Department of Health. Once they approve or have feedback that for any fix I need, then it goes to the governor, and then it starts that prolonged process.
So then I would say everybody on this meeting that is not a board member, if you have sort of like, if I could in a utopian world write the reg, if I could redline it to be exactly what I want it to be, here's what it would say. If you want to provide that to the board so that when we have that discussion, we at least have a starting point for, you know, what if you could ask for the world, what would it look like? Then we can figure out what this board is comfortable with. that would give us I think a good starting point.
Yeah, and y'all all have my email, Mr. Morris, Mr. Quinn, Mr. Putman, Ms. Hawks. And like I said, I didn't mean to skip you earlier. I forgot about your emails. And Mr. Baker, if y'all want to say maybe within 30 days, if y'all want to get me something, and then that way I'll have it from y'all. And even if you don't provide anything, if you'll just email me, so I'll be able to get when the board does set a date, I'll get that date out to you. But say if you want to get me something within 30 days, that way staff can look at it, and then we can set a time between between now and June, and get this set for a further discussion on maybe the possible changes to rules.
So then I guess that would that discussion would also include question number 2, which was if the answer to question number 1 is yes, then what could a 503A make? I'm really not sure where to go with question number 3, because I think that's more of a federal issue, but I also have significantly less understanding there, because I think it goes back to who is actually doing the dispensing.
The veterinarian.
I think that we first of all need to see, so I saw the email from Ms. Hawks, and what it is, Ohio told you what they had gotten, but it's not the actual letter from the FDA. So I think a first step for me is I'll get with like Steve Shireholt or folks in Ohio and see if they can provide me the actual FDA letter, because it'll be pivotal on, was that an FDA regional office or is that FDA DC? If it's FDA DC, like policy department, then I take that as the gold standard of what their opinion is. And I think will help with this committee work, how we would proceed. Because if it says kind of what they state in their guidance that, hey, yes, that is allowed. If we got that from FDA DC, then I'm okay with it.
Yeah, sometimes the different sections of the country put out different statements that kind of conflict. So yeah, something out of DC would be, golden. Any more questions? Anybody? Boards? Dr. Mack?
Do you think in the meantime, y'all could provide to, I guess, the vet society or whatever, the ones that are licensed as a 503B in Arkansas, so they could at least start communicating with their vets?
Yeah, I'll be glad to forward that to Mr. Baker and Mr. Jenkins as a part of, and I'm sure as the Veterinary Association, they can get it out to whoever needs to see it. I'm sure we have a list. If not, we can put one together. But I think we already have a list of all the 503Bs that are licensed.
Yeah.
If I could, just for information, we have offered to help put out information as we've come to understand, the lack of understanding, whether that be lists or articles for newsletters or speakers from the agency to even come to veterinary meetings. But I think all those things are probably needed.
So am I misunderstanding? If there's an issue with a question around issue number 3, why are we even talking about issues 1 and 2? Did I misunderstand something? I thought the third issue was the ability of veterinarians to dispense office stock, non-patient specific.
That's from a 503B. Issue 3 revolves around 503Bs. Issue 1 and 2 are 503As. So I know it was brought up about, 503Bs can already dispense, but it has to be for office stock only. So the question was, can they give it out to their patients, resell it? Here's 1 dose, take these other 4 home, that type of situation. But that all, the issue 3 concerns just strictly 503Bs.
Yeah.
They're already getting to dispense. So it was just whether it can be redispensed.
Yeah. Further distribution of a compounded product.
That's one thing that has been addressed in other states, so we could look at what other states are doing, get a guide, a lead on that maybe. Am I correct, Dr. Hurley?
Yeah. And there's several other states that have produced some specific guidance on that. I think our issue is, if there's 15 regional FDA offices around the country, a lot of times boards will hear from their local office. Like for us, it's Dallas, but DEA, it's New Orleans. Well, if Dallas FDA and DEA give an opinion, it can apply in Texas, but not in Arkansas because of it's not the right region for. So if what Ohio got was full federal from DC, it gives a level of clarification we haven't seen. If it was from an office in Ohio, it may not be useful to us.
Then if there's nothing else, I know we've got a 3 o'clock set. So if there's nothing else, thank everybody for being here today. The great discussion. Mr. Morris, did you have something?
Just to saying goodbye.
Okay, good. Well, it was good to see everybody. Like I said, if y'all will email me any, wording that you might have for the language, and if you'll get it to me within 30 days, and then I'll let everybody know. I've got all y'all on my list to notify when we'll set this again. Like I said, the next board meeting is not till June, but we're going to have to set something between now and then for a day of hearings, so we can squeeze this in for a discussion. So like I said, I appreciate everybody being here today, and I'll be in contact about the next meeting.
Thanks very much.
Thanks.
You guys want a 5-minute break before we go into our 3 o'clock? Get back at I don't know, I show like 3:16. It'll be a quick one.
So, hey, John or Luke?
Yeah, I'm still here.
Hey, do you want me to move up Dr. Lomax, or I'm not sure what your schedule? I thought he was on for 4.
He is, but we've got something else at 3. So yeah,
Okay.
let's just keep him around 4 o'clock. Probably sounds
Okay.
good.
Will do. Thanks.
think it was Dr. Mack maybe that joked last week about the weather in our February board meeting. For whatever reason, both February and October board meetings always fall on the weeks that my kids get out of school at 1:30 instead of 3:30 on Tuesday and Thursday for parent-teacher conferences. So those sweet little darlings are home now, and if you hear them, my apologies. They're trying really hard to be quiet, but they're boys, so it's hard.
Well, we've tried to move the February board meeting around for many years here, and it doesn't matter how you move it, something always happens.
So John or Luke, when are y'all thinking about having this hearing meeting with the like a one-day hearing meeting? When are you thinking about doing that?
I don't know, maybe April. I want to talk to their, they've got counsel, so I want to talk to them and see what their availability is, but yeah, maybe around April-ish. We've got a informal set already in March, and let me pull up the calendar. I believe it is
Like March 1st and 2nd or something like that.
It is, and as of right now, I've only got one day, so hopefully we can fit everything in. Right now, we just got, I mean, it's still set for Tuesday and Wednesday, but we haven't set anything on Tuesday yet. So right now we've got Wednesday, so hopefully we can just maybe just have one big full day. And that being said, I was going to ask y'all, you know, with it being 1, 2, 3, 4, no, I'm on the wrong month. With it being, I mean, literally 3 weeks away. I mean, are y'all wanting to do virtual again, just due to everything that's going on, or?
I don't care. Am I down to even be at that meeting, Luke?
I don't know that anybody's just, I mean, I've got maybe 2 or 3 people that have said they could be there. If we could have, I mean, 3 at a minimum of, minimum of 3, I mean, most, I mean, 5 or so, but like I said, since it's only 3 weeks away, I didn't know if some people, we had originally set it for in person, just like we'd set this one for in person, but then, you know, stuff happens. So I guess we, and yeah, I guess if whoever is going to come, since it's mainly going to be one day and still may have some COVID issues, so y'all wanting to do, just go ahead and do it Zoom. It's going to be mostly technicians. I mean, they're usually fairly easy.
I think you're going to have greater participation through Zoom.
Yeah, I mean, we're going to have maybe a couple of prescription areas, but most of the day is technician applications. So they're usually pretty easy, even via Zoom.
So Zoom is good with me.
And you're talking about the 1st and 2nd?
Yes, but it's scheduled for the 1st and 2nd. But right now, I've just got stuff set for March the 2nd, which is a Wednesday. So it'll just be one day.
Okay.
So real quick, I'm gonna let Luke lead off on our 3 o'clock to introduce it. But tomorrow afternoon, the last one we had on our agenda was 1:30. I am asking, Nancy is going to let we have someone that needs to visit with you guys to potentially take another round of law exam that we're going to add at 2 o'clock tomorrow. And we also had information from the Pharmacists Association that I shared with you via email. They have been working on the contraceptive protocol pursuant to one of the state laws that passed earlier, that when we've discussed with them, we really need to figure out what the protocol is so that we can determine if the protocol is approvable to then educate for the protocol. Like, we need to know this is the endpoint of what we're trying to educate for to do so. So I'm going to invite them to talk to us tomorrow afternoon as well. But with that, I'll turn over to Luke.
Yeah, and we've got 3 or 4 just short discussion topics for tomorrow, but we can probably fit those in the morning.
Yeah.
Originally, we had 5 hearings scheduled for in the morning. Now we've only got 3. A couple of them resolved themselves. So we can probably fit those discussion topics in the morning and, you know, knock on wood, have a shorter afternoon.
Yeah,
So
and if we open up,
yeah,
we may even be able to do the contraceptive thing tomorrow morning as well. Just have to wait and see.
All right. Mr. Mosby, are you there? I see your name, and Dr. Johnson. Are y'all ready? Okay.
We are, except for I haven't seen Dr. Haas.
Oh, yes, that's right.
Is he there?
There's a phone number down here. I don't know if that's him.
Dr. Haas, is that you? Well, we're going to have a little bit of trouble if Dr. Haas is not on. We have been trying to reach him.
Excuse me, this is Dr. Haas.
Hey, all right.
Okay. Thank you, Doctor. Thank you for being with us, Dr. Haas. This is Luke Daniel. I'm with the State Board of Pharmacy. We'll get started in just a minute. I know John stepped out real quick. Is he still okay? And so what this is, we have all the board members back. Dr. Krause, are you back? Perfect. Okay, this is, and I'll turn over to you in just a few minutes, Dr. Mosby, and I'll let you introduce everybody. But this is Amy Johnson, board members. If you remember, she was here in August of last year for a hearing. The facts, let me pull up her, you've got a packet in your file there. Let me pull up what I've. So you've got a packet there. Those are her, you know, most of this you saw at the last hearing, and we're not going to go through all of this again. It's just here in case you need to reference it, or in case I or Mr. Mosby need to reference it. But you've got the evaluations. It was a 1 day and then a multi-day evaluation at Palmetto. You've got medical records from 4 different places there. And you've got the police and fire reports that were made. This was just a really, really quick background. This all happened between May and June of last year. Dr. Johnson was then working, and I believe was a co-owner, or may still be a co-owner, at Holiday Island Pharmacy outside of Eureka. There were some issues where she had called the police, she had called the fire department, she was observing smells, she was thought she was being poisoned, etc. Anyway, there were a lot of issues. You can look through the findings of fact there. The board the board appended, they didn't make, the board took no action on the charges in this case. So you look at the facts in order, and it said on charges 1 through 5, pending evaluation and a return to the board. So, and that was evaluation by a mental health psychiatrist, mental health treatment. So I'm looking at the Palmetto report, which is the multi-day on September the 8th. It's dated September the 8th. It has the recommendations of, monitoring with the Arkansas support group, avoid excessive contact with irritating chemicals, etc. Said we recommend at least monthly serial mental status examinations by a qualified psychiatrist or a psychologist approved by the Arkansas State Board of Pharmacy. Says she is not ready to practice pharmacy with skill and safety till her mental status has been cleared. There was a lot of issue in the meeting with this possibly being more of a mental issue. I don't know that there was ever suspect drug use or anything like that. It was more of there might be some type of mental disease. So after this evaluation, this was done before the October meeting, and then she was here in October, and the board asked her to get a mental evaluation with a board approved a psychiatrist. Mr. Mosby, Dr. Johnson's attorney, sent the staff some information on Dr. Haas. And so we said yes, that she'd go to him for an evaluation. So Mr. Mosby, I'll turn it over to you if you just introduce yourself, your client, and then Dr. Haas can walk us through his evaluation and his findings.
Okay, I'm Robert Mosby, attorney for Amy Johnson, and Amy Johnson is here as well. So yeah, just to follow up on the previous meeting to see a board approved psychiatrist. The initial thought was we were going to try and get into a forensic psychiatrist because we just couldn't find out what this actual cause was on all this. We wanted to see if we could find out what's going on there. We kind of and then we kind of took issue with the diagnosis of delusions and the drug screen monitoring requirements from Palmetto. Amy tried to get in with a forensic psychiatrist. It was not available. She was able to set up a meeting with the forensic psychiatrist. He basically looked at her file and came to the determination that he could not do anything with it and make any kind of diagnosis. He basically just tore up her check and wasn't able to help her. He did the right thing. But Amy had been seeing Dr. Haas for a while. We knew that you guys were probably going on some type of assurances going forward. She'd already started that process. She's been seeing Dr. Haas since September, once a month. Dr. Haas is not a forensic psychiatrist, but he has been practicing for nearly 50 years and is qualified to speak on Ms. Johnson's mental status. And like Luke said, he was approved by the board. It's his opinion that Amy has not been. Oh, it's his opinion that Amy is. She's not delusional. She's not doing anything to intentionally hurt herself, and she's mentally fit to return to work. I did ask you, let him know that you guys would probably want some assurances, and to make sure her mental health going forward was fine. And his recommendation is that she could have monthly check-ins with him, and we're fine with that. We've been fine with that. Like I said, our main contention is the drug screen piece, but we have Dr. Haas with us today. If you guys have any questions for him, he is available.
I've got a few, Dr. Mitchell, if I may.
Yeah, if you want to ask questions, or if you want me to make just some brief comments, and then you can ask questions.
Yeah, if you'll just make some brief comments about how long you've been seeing her and kind of what your therapy involves. Like, we don't need to get into, a lot of personal details, but just how long, what's it involved, and does she have any diagnosis?
Yeah, well, if you review everything, I know I have a print copy here. My email went down in my office today for some reason, so I'm at my home and had her chart and the old records brought over here to my office, where I'm just working off my iPhone, and I can't see anybody, but I'm hooked in on the Zoom meeting, so I was afraid to try to maneuver anymore. If everybody's seeing everybody, I'm not quite sure how that works. But the bottom line is, I have notes from 10/14/21. I've seen her at least monthly, at least on a monthly basis, probably 5 to 6 hours at a time. I reviewed when I initially saw her all the previous avals from the two other psychiatrists and the psychologists, and I think everybody's initial impression at that time is back in June she had a 2-week period of odors and smells, and she went to various medical doctors trying to figure out what was going on, and I don't have to rehash that unless you have questions. She openly admitted that she had confusion during that time, felt sick. She didn't know what was going on with her. She felt people had broken into her house and moved things, and there were problems with landlords, stress different stress a week prior to that in regards to business stress on her pharmacy company, and then I believe the police had called the board. They're concerned about her because of feeling that she was, I guess, delusional. They threw out some words, I think schizophrenia and stuff, when I went through their some reporting. But by the time I saw her, every time I've seen her since that time, she has no really significant symptoms of bipolar disorder, which, sometimes you can see paranoia or mania. There had been no prior history of any kind of significant depression in her life, to my knowledge, and or any kind of problems with her work. She's had no evidence of hallucinations or delusions since I've been seeing her, and she's been fairly euthymic, or in a normal mood, other than being frustrated and in regards to dealing with the issue of having her license suspended at this time, and wants to try to get back to work and make a living. The drug screens, I think those are the initial things everybody seemed to go to, but all the drug screens were negative for any kind of drugs early on. So I'm not quite sure what happened during that 2-week period. She doesn't know what happened. I think she admittedly felt she was ill during that time, or things were happening to her and didn't know why. But since I've been seeing her, she's been very clear in her mental status. She's very, very appropriate. She's, really quick to think. Her thought processes are really quick. She's able to respond appropriately. She doesn't seem to be depressed to me. She's eating well and exercising routinely, trying to maintain her life. and this has kind of been the story, at least on a monthly basis every time that I've seen her. Initially, I'd spent, quite a few hours, at least a couple hours or more, reviewing all the data and everything. But there's no signs of any type of schizophrenia. I just kind of were diagnosed with some kind of adjustment reaction for some unknown reason, and it sounds like she had some paranoia or delusional symptoms during that period. But we don't know what the illness has come from. I think she tested negative COVID. But, there's viruses that happen, people that don't go to sleep, that don't sleep well. There's things that happen that people get sick for some periods of time for other reasons that develop some, paranoia or even psychotic symptoms. Since that 2-week period, apparently, to my knowledge, there's not been any type of abnormal behavior. So that's for my recommendation. I don't see any evidence of any drug use. She doesn't really drink or use marijuana or other drugs from her history. I think things have been really solid in her thinking processes when I see her, and so that's kind of where I'm at. I don't know if any of us are ever going to know what happened during that 2-week period, but since that time, she seems very confident to act in her position as a pharmacist from my standpoint. Bottom line, I haven't been practicing 50 years, hopefully, but I have been board certified since 1980, and I guess that's 42 years in adult psychiatry. And I've run a chemical dependency unit before. I've been a medical directors of some different hospitals in the past, and of adolescent units, of a geriatric unit. So I've seen a lot of people in my career. So that's just a little background information about me. And so let me just open it up for questions and concerns that you have.
Okay, so I guess the main question is, you're not as old as Mr. Mosby said you were?
I don't think so. But
Yeah, I meant to, yeah.
Okay. No, I don't. So seriously, so there might have been some delusional or some psychotic features during those 2-week period, but you haven't noticed any since you've been seeing her?
No, I haven't. Ever since I've been seeing her, I haven't seen any of those type of behaviors or symptoms. And what makes me feel a little better about her is that she didn't deny that she was sick during that period and didn't know what was going on, and had all these feelings. And she did go to doctors trying to seek help, and she's willing to follow up and see me at least on a monthly basis, that I could follow her if something odd would start happening to her. And would like a commitment, from her that if she did start feeling bad or something did start seeming peculiar, to be sure to contact me and let me know.
Dr. Haas, this is, I'm Becca Mitchell. I'm one of the board members. I just have one question for you. Would you feel comfortable with Dr. Johnson filling prescriptions for you or your family at this time?
Yeah. Yes, I would.
That's all I want to know.
Yeah, I feel. Yeah.
And I would ask, regardless of the decision the board makes today, and Mr. Mosby and Dr. Haas, we would like some type of written report just with his. It doesn't have to be long, but just with, his, not really recommendations, but he doesn't see there's a problem. He believes she's safe to practice, et cetera, et cetera. If we could just get that. Like I said, there's no rush, but we just need something in writing, and it can be short and to the point.
Okay, that'd be fine to do that.
Board members, is anybody else? I know Dr. Haas, he may need to get back to his practice. I don't know what he has going on this afternoon, but are there any more questions for Dr. Haas? And then we'll turn it back over to Mr. Mosby. Dr. Haas, we appreciate you being here today. If you need to get off and return to your practice or whatever you need to do this afternoon, that's fine. You're welcome to stay home. But if you need to return to work, you're welcome to do so. Thank you for being here.
Okay, well, I'm happy to help out, and I will. I hope the best, and hopefully, my input can help the board in making the appropriate decision that they feel they need to make. So,
yes, sir.
Okay, thank you. I think I will just drop off because I do have other patients.
Okay, thank you. Thank you for being here, Dr. Haas.
All right.
Time.
All right, bye-bye.
Mr. Mosby, I'll turn it back over to you if y'all have anything further, or if you want to discuss anything else or make any comments.
I appreciate you guys allowing us to get Dr. Haas in first. Got to get back to everything. But so that kind of addresses one of the contentions we had with her current mental status. We feel that she is competent to go back to work immediately. No delusions. I think you addressed all those things there. The other thing is the requirement for a drug screen. We still take issue with that. The Palmetto's kind of using a drug screen as a proxy for Miss Johnson's mental status, which that makes sense at a chemical dependence facility where the mental status is directly tied to use of controlled substance. Doesn't make as much sense in Miss Johnson's case. As you guys know, the monitoring is a burdensome program, and it's also going to infringe upon her livers. If she wants a glass of wine, that's not going to affect her mental status. At least that's the way we feel. Not that she drinks a lot or even regularly, but still a infringement. If she breaks a bone, she can go take a pain medicine. It's just would rather avoid that and the burdens associated with the monitoring program. But so that's kind of where we're at on it. If the board is willing to let her return to work, we totally understand the requirement of, continued mental evaluations. But, we would just like that to be without the monitoring program. And if I'm sure there will be some discussion, but the board would be open to that, I'll stop right here.
And I don't know that staff has anything further besides, like I said, we don't want to rehash all of the old, the boards. Everybody was on the board when she was here in October. And, if you, and like I said, if you need to, research anything or look back on anything, everything's included in her packet. It's just that the board decided until she had this evaluation, they were going to pin those charges. So it's just kind of a decision needs to be made today about the steps moving forward. And like I said, the board really has no further comment or argument about anything. It's just, we had Dr. Haas here today. You heard what he had to say. You've seen as was pulled up, you've seen the report from Palmetto. I'm sorry, Palmetto.
I see you, Dr. Mack.
I just wanted to remember without looking through this. I know that our concern was we didn't want to overrule what Palmetto said because she had been there and they sent us something and they're medical and we're not. So I remember all that really well. But is she on the monitoring program because of what Palmetto said? Is that why we have her on that? And I guess to safeguard us and allowing her to go back to work, it would seem more comfortable to leave her in that. But I'm just wondering, did we have her go into that because of that particular thing that Palmetto wrote?
She's not in the monitoring program yet. This Palmetto evaluation was prior to the October board meeting. So their recommendation in that evaluation was 1, a monitoring program with the support group. 2, to avoid excessive contact with irritating chemicals, because there was some testimony that she might have come in contact with whatever it was, a pesticide, fog, or something like that might have caused this issue. And the third recommendation was at least a monthly serial mental status examinations by a qualified psychiatrist. So that's why, like I said, a board staff talked to Mr. Mosby, and she got in to see Dr. Haas, and you heard him today. And it says, and 4 was Amy is not, and this is all out of the Palmetto evaluation. Amy is not ready to practice pharmacy with skill and safety until her mental status has cleared and delusions have resolved. And she has regained the confidence of the board, and she can practice safely. So you heard, like I said, that was all. 3 and 4. I mean, 2 is just kind of stay away from those products. And 3 and 4 are all resolved or revolved around her seeing a psychiatrist, which she has. And I mean, like I said, if you believe his testimony, then her mental status is cleared. And well, he states her mental status is cleared, and the delusions have resolved. So that all being said, I think Mr. Mosby and Dr. Johnson's main issue is her being reinstated, and whether it's with or without a monitoring contract.
But we have one group that says she needs the drug testing and monitoring, and one psychiatrist now that says she doesn't. So it's kind of.
It's basically up to you guys. It's another one of those, you got 2 questions at hand. 1, are you ready to let her go back to work? And 2, are there any restrictions or conditions of number 1, if that's a yes or a no?
At a minimum, we would just request that she stay with her monthly evaluations and monthly meetings with Dr. Haas. At a minimum. And then
How long?
I really don't know. I mean, at least I would think at least for the next 12 months. I mean, if she's seeing, I'm not a doctor, but if she's been, seeing somebody for that would be, I guess, 15 months at that time, because I guess she's been seeing him for 5. So if that's, that would be, I guess, 17 months. So, another year, if she hadn't any problems in that time, I don't see any problem with her not having to be, continue to go. But at a minimum, we would like for her to continue those right now. It's just whether or not the board wants her to be monitored by the support group. I don't know that there was, it's up to the board. I don't know that there was ever a question of drug use in this issue. And it appears to be more of some type of 2 or 3 week mental disease, defect, whatever you want to call it. I don't know that anybody knows exactly what happened during that time period, but
I'm not sure we felt real comfortable that it was a 2 or 3 week thing, because when she was before us, I felt uncomfortable then. So I didn't never just think it was a 2 week thing.
Okay.
Can we hear from Dr. Johnson? Tell us how you're doing. What was the question? How are you doing?
Yeah.
I'm doing good.
Okay.
I guess what have you been, just kind of, since we met last October, what have you been doing? And just kind of give the board an update on you.
As far as I was sick in June, and once I got out from Holiday Island, I progressively have gotten better. I have not been sick. I'm not having to follow up with the doctor for the various reasons. I feel good.
What have you been doing during this? Since you're not working in a pharmacy, what have you been doing?
What have I been doing? I'm not working and have not been working because the board has, my license has been inactive. I have been doing some things as far as around the house. I've been doing outdoor activities as far as riding bikes and things like that, and trying to patiently wait for the board to get my license and get back to work and get to functioning as I haven't always in the past.
Thank you. Dr. Newsom, did you have a question or a comment?
That was going to be my question. How is she doing? And,
As far as
you
health
answered-
wise, my health is good. Like I said, it progressively got better just getting out of the apartment up there.
Dr. Johnson, if the board were to reinstate your pharmacist license today, where would you go back to work? Like in what practice setting, how many hours a week? What does that look like for you tomorrow if we were to reinstate your license today?
Are you asking where? I mean, I do not have a job currently as far as that is to go back to work. I've always worked retail pharmacy or in management.
Okay. So I'm trying to figure out,
You want
Yeah,
to know
sometimes-
specifically where I'm going to work?
I thought maybe you had something in mind or a position waiting for
I haven't been
you.
able to apply for a position with my license being active. So I do not have a job currently lined up because I didn't know if I was going to be able to have a license or not.
Okay, I guess I was thinking maybe you had owned the pharmacy and that, so you were going to go back to work at the pharmacy that you owned, but I could have been just totally.
No, ma'am, my partner actually closed the pharmacy in October without even consulting. There's a lot of issues as far as with that, but the pharmacy up there is closed.
Okay. So a lot of times when we have someone on the in the support group, when they go back to work, and I don't think you should be necessarily in the support group, but when we have someone in the support group, we sort of phase them back into the workforce where they can work part-time for a while, and they check back in with the board, and then they can work full-time, and then they can eventually get permission to be a PIC. And so I'm wanting, I guess, to get the appetite of the board if that is something that you think is necessary. I mean, my personal opinion is that Dr. Johnson has done reasonably within reason what's been asked of her. She's been accused of no, crime or practice non-compliance, and we have a competent medical professional that believes she's fit to practice. So I kind of don't feel like I can say otherwise, but I would like to know what the other board members think. Because I don't get a vote. Dr. Newsom?
Yes, I don't have any problem with her going back to work, but when you are looking for a job, look for one where it's not a lot of stress, because we don't know if all this was caused because of too much stress on you. Of course, all of them are going to be fairly stressful right now because of the times that we're living in, but try not to put yourself in a boiling pot.
Yes, ma'am.
Miss Rader, I felt like I could see in your face that you had something to say.
Well, I agree with Dr. Newsom. I think that probably going back on a part-time basis and kind of easing yourself back into the work environment, I think would be good. But I agree with Dr. Mitchell as far as, you have a physician that is saying that you are fit to return to work. The Palmetto, I mean, I don't think that you need to be in that type of a recovery program because it's not been proven that you have any of those problems. So again, I agree with Dr. Mitchell.
All right. Mr. Daniel, is reinstate the correct word?
Yes, she signed in an agreement not to work. So if somebody's going to make a motion, it would be to reinstate her license. And also we would ask that she continue to receive or continue to have monthly meetings with Dr. Haas for the next 12 months. And
Do you want to wait until we get the letter from Dr. Haas saying that he feels like she's fit to practice before we reinstate, if that were the vote?
his testimony today, I mean, this is recorded, so we have his testimony that she's safe to practice. We would just ask that, like I said, she continue to see him and get maybe a progress report from him at 6 months and then at 12 months. And if there's no more issues at 12 months, if she's still doing, good, that he said today, then she wouldn't have to meet anymore. But we would say starting from this month, an additional 12 months with progress reports at 6 and 12 months.
Any other discussion from board members? Does anyone want to make a motion? Dr. Newsome, you're on mute. There you go.
Okay. I would like to make a motion that we reinstate Dr. Johnson's license and that she continue to see a counselor for the next 12 months.
I'll second that.
Can we just add a progress report at 6 and 12 months?
Yes, sir, that'd be fine.
Dr. Richmond?
Yeah, just for clarification, do we want her to see a counselor or a psychiatrist?
Well, that's what I meant, psychiatrist, counselor.
I would say
I
board
just kind of
approved
interchange those
psychiatrist.
words, yeah.
Yeah, I would say board approved psychiatrist and Dr. Hossie.
Okay.
And she's already familiar with him, so.
Dr. Newsome, do you amend your motion accordingly?
Yes.
And Dr. Cross, do you still second that motion?
I do.
Okay, so I have a motion from Dr. Newsome and a second from Dr. Krause. Any other discussion? I'm looking, I don't see any. All in favor, hold your hand up and say aye.
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 Any opposed? The motion carries, and let the record show it was unanimous.
Mr. Mosby, I'll get you a letter in the mail that just states that what they decided today. And Dr. Johnson, your license will be moved back to active as of today. And we'll get you a new copy of your license in the mail to you.
But Luke, it would have been up for renewal 12/31. We'll just have to figure out how to let her renew it to make it current.
I'll switch it back to active, and then she can get online and renew.
But we
It's
would not
already
want to
renewed.
assess her the penalty for waiting until February to renew.
But I thought
She already
you've
renewed.
already renewed.
Oh, she already.
renewed.
Okay. I was just trying to look it up and wasn't fast enough.
It's already
Okay, yeah.
renewed.
So
Okay,
if
good then.
you've already renewed, then we'll just switch it back to active, and that'll be the end of it. But we will mail you a new copy of it, just so you'll have one with the new expiration date. And I'll get you a letter in next few days, Mr. Mosby, just so you'll have something in writing. Perfect. Thank y'all for being here.
All right, I think we've got Darren back with Kyle Lomax.
We do. And Darren, are you wanting to put anything up on the screen, or you just, I've given the board all the documents that you sent me. I just didn't know if you wanted to put anything up for them to see.
No, not really.
Okay.
I'll be really short and then turn it over to Dr. Lomax.
And board members, you've got a packet in your packet there. You've got one that says Southern Pharmacy, Kyle Lomax, and it's got, checklist, central field policy, and just some other documents that we provided. So, Mr. O'Quinn, I'll just turn it over to you if you introduce yourself and your clients, and just
Okay.
Tell the
Thank
board why
you.
you're here.
All right, thank you. I'm Darren O'Quinn. I'm here today with Dr. Kyle Lomax and Southern Pharmacy. And this situation, I guess, arose at a recent inspection with Dr. Fain when I think she noticed some packaging from a different store was in Dr. Lomax's pharmacy. And how that came to be is he has basically 4 pharmacies. Then he has another pharmacy in Jonesboro that specializes in, I guess, special packaging for make it easy. He can explain that better. But approximately 80 to 90 of his patients at those 4 pharmacies or 5 pharmacies use this specialized packaging. So it has the potential to affect those patients. So the way he set up this operation is basically the issue is it a central field pharmacy or not? And when Dr. Lomax was setting up his operation to use the special packaging because that one particular, I guess the way it's done is too expensive to have in all of his pharmacies. So he got with Rusty McSpadden during one of the times Rusty was in his pharmacy, and they concluded that it would not be a central pharmacy if, for instance, a prescription came into one of the 4 pharmacies and it was legally transferred to the Jonesboro pharmacy with the specialized packaging. And then from that point on, it actually lived, at that pharmacy. It's not the situation with a traditional central fill. And from what I understand is central fill, you send it to a central location, they fill it and they send it back to the pharmacy. The prescription never leaves the local pharmacy. It's just filled at a different pharmacy. This is not that situation necessarily. They legally transfer the prescription to the Jonesboro location. It's filled, and then the Jonesboro location actually delivers the prescription to the patient. So that'd be different than a central fill as well. On some occasions, it's not, certainly not a lot of times, but on some occasions, when the central fill cannot directly deliver the prescription to the patient, they will deliver it back to the originating pharmacy for delivery to the patient. And maybe the patient's not home, or they're on vacation, or whatever it is. There would be reasons that would come up, and Dr. Lomax can explain it. So I guess number one, if he needs to be a central fill pharmacy, then he's submitted some policies and procedures and that sort of thing. And that's what he wants to do if that's the board's decision. He was just under the understanding from talking with Dr. McSpadden that he was not running a central fill pharmacy under, I believe, regulation 4-211 in the traditional sense of the word. So
Darren, you had us at not central fill pharmacy until the product is returned to a different pharmacy for further delivery to the patient. And at that point, you either call it central fill or you call it a pickup station. So I think rather than
what I'm saying is 95% of the time, it doesn't go back to the originating pharmacy.
Yeah, but it's like 100 or 0. So I think what we were trying to do is say, hey, if you have need for the ability to return it to the originating pharmacy, we have a fairly simple process that is not stressful for pharmacists. Submit an application to get approved for central fill, and you can do it either way at that point.
And I'll let Dr. Lomax talk about that. I think when this was initially conceived, this process, they didn't have the software or something, he really couldn't be a central fill at that time. And Dr. Lomax, do you want to kind of comment on how everything operates and whether, you've submitted, you don't mind being a central fill if you need to be?
No, no. If it's the board's decision that the delivery of that product back to the originating pharmacy is central fill, then we're completely fine with submitting an application for that. We legally transfer prescriptions and fill them out of that pharmacy in Jonesboro is where it's located, because that's where the automation is. And we just don't feel that product needs to be in the hands of somebody instead of at a door. So if it's the board's decision that is central fill, I would be happy to put in writing in my policies and procedures and change my workflow, whatever I need to do.
Dr. Mack, you're on mute.
Are all 4 pharmacies in Jonesboro?
No, ma'am. They're in rural locations.
Yeah,
So I
talking.
don't know how you would deliver them from Jonesboro. They drive all over the state to deliver?
No, they're all close by.
Yeah. We have a radius of about 40 miles that we cover. So it's rural. We're working these up anywhere from 7 to 10 days before the patient's supply is exhausted. And we have a lot of care management and care coordination that goes into making sure that product's delivered before the doses are expired or the medication is due.
So it's deliverable. Okay.
Yes, ma'am.
You've got Amy with hand raised.
I keep hitting the wrong button. I'm sorry. I didn't have a question.
Yes. So Kyle, just real briefly, and I was trying to explain this, but once you engage legal counsel, I can't really talk to you directly. The way that we have designed central fill is, I think the board is fairly agnostic as to where the prescription is processed or where the prescription is filled. With central fill, though, if you want to take it back to that home location where it started or have that ability to, it has to have labeling information of who actually did the physical act of the back end fulfillment of packaging it and labeling it. What most of our places will do is, if they want pharmacy A to see the patient and it to be filled for pharmacy B, it will have pharmacy A name on it, like Monette, and say fulfilled by or filled by or dispensed by pharmacy B at this location, just as a label edit or as a sticker on there that is additional to it. But the problem you run into is people can argue that if you don't have that central fill approval and you're doing something like that, you're either illegally running a central fill operation or a pickup station other than where it is. So we just try to help people to understand before it gets away from them. If you want to have that type of setup, not that you already do, but if you want to have that type of setup, this would be the appropriate request. And that way you're covered whichever way you want to deliver.
Okay. Yeah, we had a pretty lengthy discussion on our options early on. And because of the technical aspect of the software and because of the challenges that would come in running the central fill that's defined in the policy there, that we kind of went with this transfer model. But I do understand the delivery of the product is probably where this is qualifying as central fill, and I'm happy to adapt anything to make that compliant.
And I don't think it should cost really anything extra other than the one part of the label if you're wanting to do it that way. And I think that could be an additional label.
Well, my question would be is that since the prescription lives at that pharmacy, it's transferred legally, the prescription that's been assigned a number, would that labeling have to be associated with the location, like in my rural area? Because we're legally transferring the prescription either via fax, via verbal, or via the shared database. So we're assigning a prescription number at that Jonesboro location, and the labeling would reflect that. Would I have to have a separate label that would be associated with, because of that scenario? If I take it back and deliver it to that patient, or that patient needs to come in and pick it up at that location? That's where I guess I'm confused on where I need to label it.
Our usual issue is more that the pharmacy doesn't want to put the location that actually prepared it versus the location where it's picked up. And I'm pulling up our rule because I haven't looked at that in a minute or two. But when we look at it,
maybe I missed something, but when it's transferred and it goes to the Jonesboro facility, it's mailed out from that facility to the patient.
Yeah, except in some instances where if they can't get delivery physically to the patient, they'll take it back to pharmacy B that the patient usually sees, and the patient will pick it up there.
Yeah, so we're only talking about a handful percentage of that are actually be considered central fill, correct?
Yes.
Right now it's maybe we're talking around 80 patients across 4 of my rural locations that this would be considered, central fill. And even inside that, we're delivering some of those directly to the patient, so it could even be smaller than that.
Yeah, but the thing is, you may find a whole nother group of people that you don't want to deliver to further out in the boonies.
Yeah,
that you could do central fill from Jonesboro, drop it off in, where is it, Leachville?
Yes.
Because that way you're not traveling from Jonesboro past Leachville. It's, guys, I can't deliver all the way out to you, but you could pick it up in Leachville and you may grow that by 20 people.
That's true.
And, and those prescriptions would have to have the central fill label.
Yeah, and what you could do, and we'll work with you on, you've got the right policies and stuff to satisfy our requirement.
Okay.
You already have the label generation for Jonesboro. And I mean, Dr. McCready will correct me if I misspeak, but you could add a secondary label for the Monette store or the Leachville store or something like that, so that it reflects both. You know, this prescription, you know, picked up at this store was originally prepared at such and such. That would work, Dr. McCready, Dr. Fain. So people have made some of the central fill stuff far more complicated than it has to be.
Okay. I'm probably going to need a little assistance in working through that. So if I can use Dr. Fain as a resource, I'd appreciate it. So
Our advice is usually free, unless you don't take it and then it ends up costing you something.
Well, I'll take anything free I can get these days. Yeah, I appreciate the board giving me the opportunity, and if they'll grant me approval to do central fill based on our conversation and working with Dr. Fain to make sure we're compliant, I'd appreciate it.
Do I have any
Board, I would just ask
questions,
for,
comments?
oh, go ahead.
Go ahead, Luke. I'm sorry.
No, I was just gonna say, we just asked for a motion that says granted as it was presented.
Dr. Cross?
What I was gonna say, Becca, I was just, Dr. Mitchell, that we accepted as presented.
Is that a motion?
It is.
Do I have a second?
Second.
I have a motion from Dr. Kraus, second from Dr. Jolly. All in favor, raise your hand and say aye.
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 All opposed? The motion carries, and let the record show it was unanimous.
Darren, I'll get you a letter that just says it was approved today as it was presented. And Dr. Lomax, like I said, always feel free to reach out to anybody here. We'll be glad to help them any way we can. All wrong advice is free. Right advice gets pretty expensive.
Yeah. Well, thank you all. Thank everybody for their time. We appreciate it.
Yeah.
Thanks,
I
Darren.
appreciate the board protecting the public at the same time advancing our profession. So thank you.
So Luke, along that lines, for everybody, we actually have a discussion topic under tomorrow's agenda, but actually Lynn knows a little bit about Central Fill since he set it up before, and Lynn had a request to add 2 locations to his Central Fill agreement with the board, including one of them where he's planning on putting in another robot piece of equipment so he could use that to source from as kind of acquired or stored. Is that basically accurate, Dr. Kraus?
It is. Yeah, and I also just sent out, speaking of, I just sent out the Dropbox link to tomorrow. You have 2 folders. One is discussion, one is board hearings. You say it's not open to board hearings till tomorrow. The discussion folder has Dr. Kraus's email. So if y'all want to go ahead and discuss that real quick, just ask Dr. Kraus, just ask you to not vote. And, but if you want to just quickly go through your,
I mean, basically he had asked us how to do that, but you wanted to add 2 new stores to it, one of which is a brand new opening store that with volume, you're going to put another robot in there.
Correct. So, well, quasi correct. To be more specific, the robot at one store, the people there have really bad names for it. And the robot at the new store is nice, and we're not doing much business there. And so what we were wanting to do for sanity's sake, because it is a high stress time in pharmacy, but is to move that out of there over to the new place. And so in talking to you, you suggested, and I agree, to adding this location to the city drug. So there are 2 stores within the same town.
Yeah.
On that aspect. The other aspect, because it is twofold, is I've done a similar thing between Hunters and Delta Drug of Dermot, and I've got a machine there, and I would like to add it to Hunter's Central Fill location. Now, I don't use this stuff much at all on this side, but I do on that. So that's what I wanted to ask.
So he's already approved for Central Fill. He just kind of is adding 2 locations.
Yeah, he's just changing his arrangement slightly and adding the location.
Correct.
I would make a motion. We allow Dr. Kraus to do that.
Now second it.
I have a motion from Dr. Mack and a second from Dr. Newsom. All in favor, say aye.
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 Any opposed? The motion passes. Let the record show it was unanimous and that Dr. Kraus did not vote.
Thank you.
Dr. Kraus, I'll just get you a letter so you have something in writing.
Sounds good.
Anything else you want to address today, John? We've got a couple more discussion topics. Like I said, I think we'll have plenty of time tomorrow.
Yeah.
We do have, like I said, I just sent out, you do have 2 folders in the stuff for tomorrow. Once you go in, it says February 9th discussion topics, February 9th hearing books. Again, just ask you to the discussion topics or some rule changes that we have set tomorrow. I don't believe there's going to be any opposition or anything like that. We do have a few letters of support in there. I have 1 support group issue, and then have a couple of other short discussion topics. So we'll just fit those in when we can. I believe the support group and the rule changes are set for 1 o'clock.
Yeah.
So we have, like I said, 3 hearings in the morning. They're all technicians. Just ask you not to get into those documents and until tomorrow. And then we have 1 tomorrow afternoon, have confirmed. I believe all 4 of those should show up. None of them are, several hour hearings. So like I said, if we can knock out the rest of those discussion topics in the morning, and I think John's got a student coming in that needs to address some issues tomorrow afternoon. So that's what we've got tomorrow. And I believe there's a link in the new folder too, if you deleted what you had today. But I will, at the end or shortly, I'm gonna close out the Dropbox for today. So those packets won't be accessible after about 10 minutes from now.
A couple quick things. So on the agenda, it said that we were going to discuss dates for the October meeting.
Yes. Yeah.
Do we
When
need to do that
are
today, or?
what are they usually, John? Are they set by stat? Or are they usually a certain week?
Second Tuesday of the month.
So that would be the 11th.
Yes.
Yeah, but they got the drug summit. Is it the 12th of October?
Let me look. I've got a meeting on that Thursday, so.
That was my next question was is there a plan for travel or conferences? I know it's been a little bit weird the last couple of years.
We have like board conferences. We have Multigun September 18th through the 21st. Then there's not one in October.
Yeah, Drug Summit is October 12th.
Okay, so we would have to do either the week before or after that.
I know I'm always just one person, but I have a conflict every second Tuesday of the month.
That's only 3 meetings a year for us, Amy.
Yeah.
So the 19th, so the 18th and 19th, or the 4th and 5th would work better for you.
Yes.
Okay. And I would ask to go ahead and set it for 3 days. Like I said, we didn't need 3 days this time, and might not in June either, but it is nice if we have that 3rd day and need to have hearings. So I guess it just depends on if you want to have it the first week of October or the 3rd week.
Let's go for the 3rd week.
Does anybody have any conflict with the 18th through the 20th?
Not that I can think of at the moment.
When is District 6?
Yeah, I wonder when District 6 is.
Oh,
I think it's
I forgot.
early.
Okay.
It is.
I had it somewhere.
Yeah, I thought it was early. Multigon's early. It's 18th through the 21st. Let me pull up NEBP's website and see if it's on there yet.
Where's Multigon going to be this year?
New Orleans.
New Orleans.
Oh, okay.
And that's 18th through 20th September.
That's what I thought.
September 18th to, yeah, I got the 21st, I guess, for a travel day, but yeah, 18th to the 20th. Let's see what the meetings.
That September.
It is August 28th through the 30th, so it's early.
Early.
Good.
So yeah, August
Multigon
28th
is
to
the
the 30th.
18th through the 21st of September.
Yes, 18th through the 20th, I believe, are the actual meeting dates. I had the 21st
Okay.
on my calendar too. And then District 6, 7, and 8 is in Oklahoma City, and it is August 28th through the 30th. So it's early too. they're both early this year. And then, yeah, ASPL is always the first weekend of November for anybody that goes to that. So it's the third through the 6th. So yeah, so if we could do the 18th, 19th, and 20th, that would be great if that works for everybody.
I'm blocking it.
We're talking about all the dates I lost. What month are we talking about now?
I'm sorry, October 18th, 19th, and 20th.
Okay, thanks.
So 18th, 19th, and 20th if needed. 18th for the, regular business meeting, and then 20th or 19th and 20th for board hearings. But I just like to set the third day, even though we might not need it, just in case. And like I said, the drug summit was the 12th, if y'all want to put that on your calendar. And where is it this year, John? Is it up north or is it Hot Springs?
Hot Springs.
Hot Springs, okay.
They tried to look at different convention areas, and for the size of the meeting, Hot Springs was our only option. So.
And like I said, we've got that March informal that'll be one day, and we'll move it to virtual, and we'll just set another day as needed at some point in the future.
The only other thing I had was, I think Dr. Kraus had brought to my attention that there was the conference center at the Pharmacist Association building prior to that being demolished and burned. The board had donated that area or made a donation to dedicate that to Dr. Hosto. And so there was potentially a discussion of where we're going to do something as a board for the new building. And so whether we discuss that, now, or we just put it on a list to discuss at some point in the future, I just wanted to bring that up. And we'll let Dr. Cross expand a little bit more on that.
It would have to be individually from us, not the agency. And I don't know what was done, 25 years ago. I'd have to ask who even has records of that. But I know that there was a big push that they dedicated the Hosto Center after Lester's death. And I thought that, or I think that John has been working on something to still kind of have a tribute, because there won't be a separate building or anything in the new building.
Dr. Cross?
Yeah, I don't remember how that worked out or what went down. I just assumed that the board had either, dedicated or donated or something to, for that facility to be named after Lester. And then with the new building being put in place, if something like that could be worked out in the new facility. And I'm not saying that I have the answer, but I think that it's worthy of our consideration.
Mm-hmm. All right, so I know he's watching on YouTube. Dr. Vinson, if you'll just maybe give us some ideas. Then as individuals, the members of this board, not the board itself or the agency, as Dr. Kirtley said, but if that's something that individually or as a collective group we decided we want to do, it'd be nice to know maybe what some options are.
I know they saved the plaques and everything off the building before it was destroyed.
All right, if there's nothing else, do we want to adjourn? I will take a motion for that. Dr. Kraus?
Motion to adjourn.
Second.
Okay, I have a motion and a second. I'm not even going to take a vote unless I have to. I think we're good to go. I will see all y'all at 9 o'clock in the morning.
Yeah, we've got a 9 o'clock start tomorrow. Thank you.
Bye. Have a good afternoon.
See you guys.
Thanks, everybody.